Nice to see you.
Uh, I'm making you all live. 5, 4, 3, 2, 1, start.
Good afternoon to all, and a very, very warm welcome once again to all of you. Welcome you all again to an interesting webinar focused on common to advanced ENT type surgeries.
कौन सी side है?
For ENT today again, this is our 14th program.
कौन बोल रहा
I
है?
think we are setting new records.
File.
One is, I think, in any of the surgical, first of all, surgical webinar is done lively. Second is that we have been doing it on, as a series, it is on foot, which is the 14th webinar. I think no one would have done in the pharmaceutical industry. So this is again a record. And if there is another record also, that when all this surgical webinar, which we have conducted in the last 14 series, has crossed more than 100 hours of teaching and sharing of knowledge by Dr. and Dr. Rajeev Pachauri and Dr. Pramita and many eminent personalities across the country and across the globe. That is, it's a big record for this Explore ENT webinars. So it's record breaking, I would say. I think we are setting up a new records for companies to come and break, and I think it will remain for a long time. So once again, my heartiest welcome to all the ENT surgeons across the globe, across the country. So with this, this is Mahendra Varman from Sun Pharma Care Division, of which is dealing with Cipodem, Recipar, and Montac-Apex, and new introduction, Abitavert. So with this, let me hand over the session to Dr. Rajeev Pachauri. Sir, Dr. Sir, please.
Thank you from my team and Varman, all my friends, and welcome all my friends from my country, from abroad, all over those who are just logged in with us. And this is our 15th webinar, and I specified it is almost 111 hours. So very auspicious, we can say 111 hours completed so far in our 14th webinars. So today we have a very hectic schedule, and all the cases in nasal, head and neck, here is there, and whatever you can think of. And we are expecting, I think, at least 8 to 10 hours minimum we should cover it. And today again, I would like to welcome Madam Paidawadi Madam and Samanvi Bill from LGPJ and Sudat, and all the friends. And again, a request to everyone, please give us feedback about questions and suggestions and discussions. And let's start from now. And over to Dr. Satish. Ramita, you are there? Yeah. Any comment from your side? So, what Satish, Dr. Satish, now.
Hello, boss.
Good afternoon, everyone.
Afternoon.
Good afternoon. We welcome you all to the 15th webinar of ours. We have all interesting cases lined up today. And thanks for Satish Jain sir and Pachauri sir for organizing this evening for all of us. And all the questions are welcome. We'll have a good discussion today since we have interesting cases. Over to Satish, sir.
Yes, Satish sir.
Thank you.
No,
Thank you all.
Satish, before that, belated happy birthday.
Thank you. Thank you, man.
Friday was the great master's birthday.
That is over now.
It's sort of a celebration. I have come for 5 minutes. I'm going to delay, but only to begin this with a very happy birthday to our dear
It's all done, man.
Master Satish.
Yes.
Thank you. Thank you.
He is in birthday hangover. Still
No,
birthday
no,
hangover.
Thank you and good afternoon, everybody. Today, I welcome you again to this webinar. I hope to be a great day with some legends with us. You all know them, very familiar to us, our own. And I welcome Farida Madam, who has always treated me like her son.
Thank you.
She has been an amazing teacher to many, including me. You know, when I was in post-graduation period, she used to come to our college as an examiner. And she always treated the students like, colleagues. Helped them, encouraged them, and that's what I have been observing for all through those years. And she has been same. She encouraged me in my life throughout my career a lot. Madam, who has a vast experience of teaching. She has been in medical college for almost 20 years. Now in practice, to her credit, number of papers, medals, fellowships, so many things, innumerable things. And we always see her in forefront of academic activities everywhere. She has been to Mario, been to many, many awards, and now teaching so many. And in Surat, so many junior colleagues are, taking her open. She has been guiding them through their practice. I know Vishal and all those doing joint practice. And Madam has been instrumental in, treating them. Thank you, Madam. Thank you so much for being with us.
Pleasure to be with you, Satish. A pleasure to be with you.
Madam has a special interest in head and neck oncology. And, we have a couple of cases in oncology today. So we'll have a, great insight from Madam and learn so many things from her. Thank you, Madam, once again. And then, yes?
Just a word of caution. He's going to take revenge on you for all the exam questions you asked. So be prepared for very difficult questions.
No. I am not going to. Not at
Satish
all.
cannot have any questions. He only has answers to everything. No question.
Okay.
And,
Satish, carry on.
and then I welcome another, I call him dynamite of academics, Dr. Ramandeep Virk. And thank you, Ramandeep, for joining us. And he has been a great friend for all. He is professor of ENT in a prestigious, you all know, the Postgraduate Institute of Medicine and Sciences in Chandigarh. He has been in forefront of academics. To his credit, number of publications. He has a special interest in endoscopic surgery, laser surgery, otology. And, he has trained so many students in his career over the last more than 15 years. He has been training. He has a keen, interest in instrumentation, keep up of instruments, guiding. I have been guided by him several times when I supposed to buy some instrument. He is the man who's to ask for. Besides that, he is a wonderful human being, amazing biker. I spoiled his Sunday today. He was supposed to go by, he goes to Kashmir and even beyond. On bikes. He has a special interest in all those things. Thank you, Ramandeep. And today, we have his interest of cases, JNAs, laser stapage, and so many. And I believe we'll have a good time learning from him again some important things. Thank you, Ramandeep, for joining us.
Satish, I think when you told him he has to come on Zoom, he thought he has to come on his bike, right?
Yeah.
And no, Raman is really among the very brightest minds in ENT.
Yes.
He's a big thinker. This is something I'm taking out of her. But really one of the guys who should be, he does the PG Institute proud because he's truly a genuine thinker.
PGs love him, boss. He encourages like anything. He treats them like friends. Throughout, right from his first year, PG behaves with him like a friend. Amazing. And Ashish, remember, we had a great time with him last year when Krishna sir organized that LChem autosclerosis panel. What an amazing videos he had shown that time. Thank you, Ramandeep, once again for being with us.
For ruining my Sunday. I will remember.
Thank you. And before we start, we have a big thanks to Sun Pharma for this entire support. We have been throughout for last 2 months. And this program is all the brainchild of Dr. Rajeev Pachauri and Paramita, who have been a big help in organizing this event. I have been just part of the program and they are the pillars behind this program. Believe me, they have the kind of hard work they have done in organizing these webinars is amazing. Thank you once again. And today we have a big day. We have almost scheduled 12 cases. To begin with, we are starting with an interesting case of JNA. We have always, a couple of times we discussed a lot of things about JNA. But JNA, some pathologies requires more and more discussion. The different extension of the tumors pose different problems. So this time we have come up with 2 cases, with the one being the limited extension and this being with a different extension. Last 2 cases we saw, the last one was going to the cavernous sinus superior orbital fissure. This tumor is going more and more laterally, particularly destroying the posterior wall of the maxilla, which I am going to share with you. So this is overall the picture of this case, and the investigation which I like, the first investigation to order is a CT angiogram. The rest, the MRI and other things are required if the tumor extensively invades the skull base. Otherwise, the CT angiogram is good enough. It gives us a contrast picture of the tumor, which is the highlight of the tumor as it enhances on contrast administration, being a vascular tumor, along with the most important information of the vascularity, the vessels supplying the tumor. More than that, this information can be given to us by the radiologist that these are the vessels supplying the tumor. But looking at the CT angiogram, the way I've been showing dynamically, gives us a complete three-dimensional picture of how the vessels entering into the tumor. And that has a huge impact in surgical planning. Sometimes, because in our technique, the hallmark of technique, in endoscopic technique, is to go onto the vessel, catch the vessel first, and then go into the tumor. If you go into the tumor vessel, you cannot remove it. The kind of bleeding it gives is something which will never allow you to work with the endoscope. So in situations where you can't catch the vessel first, to me is probably a contraindication to endoscopy. And we have got certain cases where we had to avoid endoscopy. We had no option to catch the vessel before going into the tumor. So this case, like this is the CT angiogram. As I told you, this is a preferred investigation. I'll start from below for everyone quickly. We have discussed this several times, but yet again quickly, this is our common carotid artery on the right side. This is a right-sided tumor. Now see, it is dividing into two vessels, external and internal. Can you see this?
Yes, yes.
This is arterial phase, this is the vein, which is prominent in the venous phase of the angiogram. So if I have to focus on the external carotid to begin with, as it gives number of branches, see the branch arising from it? See, you have to keep an eye on the branches, and that's how this is the facial artery. That's the facial artery going toward the mandible. This is the lingual artery. And if I follow the course of the external carotid going itself, behind the angle of the mandible, see this vessel. Here it is, it divides into two branches. See this?
Yes.
See this dividing into two?
Right.
Let me change the intensity. See this? The one going laterally is the superficial temporal. We had a tumor few months back, I'll share with you sometime, had an extensive blood supply from the superficial temporal artery, and that itself was a huge contraindication for any endoscopic approach. You can't go and catch that vessel first before you remove the tumor. As simple as that. So here, this where I went, sorry, I'll go back. Yes. So this is behind the angle of the mandible, the external carotid dividing into two, and this one, the huge one, see this? This huge one is the internal maxillary, and what we need to see, look, keep an eye on my cursor, how this vessel is entering into the tumor. Can you see this?
Yes,
This is the posterior wall, this is the maxilla, this tumor coming from behind is destroying the posterior wall of the maxilla and pushing anteriorly, trying to go into the maxillary sinus, though periosteum is always intact, but yet it pushes anteriorly. And see this vessel, how it is entering into the tumor at what level. Can you see this vessel here?
Very clearly.
Yes, yes, very clearly.
Now you have to decide at this point of time, can you catch this vessel first before you remove this tumor? And then only you can think of doing a proper endoscopy. Let me reconstruct in all three planes to show you better. That's the beauty of dynamic imaging. See here, I am in the axial again, I'll catch the same vessel. See the same vessel on the axial?
Yes.
I will bring my cross edge over here to pick that vessel in the coronal. Now I have caught the vessel in the coronal. See here where my cross edge is.
Okay.
Now, oh sorry, again reconstruct. So this is how you can catch the vessel in all three planes, and that is most important, because this has a huge impact in surgical planning. Now this is my vessel. I will catch here like this, go to the coronal, enlarge, keep an eye on the vessel. This has been the vessel. See this?
Right.
And now if I follow this vessel, see this, how this vessel is entering into the tumor. Can you see the entire course?
Very clearly.
Now this is the maxillary sinus. From superiorly the tumor is pushing anteriorly, and from here the vessel is entering into it and riding high up into the tumor. See this?
Yes.
If we can catch this vessel intraoperatively, we can, before removing the tumor, we can very well do this tumor endoscopically. That is the main role. Now if I keep the cursor over here at this point of time, we will see this vessel here. This vessel, if you see in the sagittal plane, that gives you another insight. This is the maxillary sinus, and see how this vessel is entering into the tumor from here. Can you see here? So
Yes,
we have to catch this vessel at this point of time, at this point of place in the surgery, during the surgery, and see how this vessel in the axial plane. So we can catch this. We will go when we do the dankers, when we remove the anterolateral wall. We'll go far anterolaterally here first and catch this vessel first and remove this tumor. And that is how you can plan very well on this three-dimensional radiology. Any point of time, had this vessel been entering into the tumor from behind, and I had to go through the tumor to catch this vessel, would have been the absolute contraindication for me for an endoscopic surgery. So majority of the primary tumor, however big they are, they do not invade intradurally, the primary ones, and any given extension can be removed endoscopically in a better way with good on-site magnification and illumination, provided the vessel can be caught before you handle the tumor. And that is the hallmark, that is the principle of endoscopic surgery. And in this patient, I have in my mind now how to and where to catch the vessel. This vessel is little lateral as compared to the previous case. Let me show you again to begin with.
Yes.
This is in contrast to the previous case. Now the tumor is coming forward, bulging anteriorly, and this vessel is somehow, going through the tumor. See this vessel. Again, I am showing it again and again. See this vessel, how it is entering into the tumor. So when I am going endoscopically from here, when I remove the medial wall and a part of the lateral wall, I have to go right laterally there at the edge of the posterior lateral wall and see the vessel and how it is riding high up. As I come medially in the posterior wall, I will see the vessel riding high up, but still it is not passing through the tumor, still it is passing on the anterior wall of the tumor. And see if I see the dimension, if I take the dimension from the level of the floor, see the level of the floor here, this vessel is somewhere still 1.7 centimeter, 1.6 centimeter above the level, very well within the reach. And again, why I am saying this vessel is still anterior, let me go to the sagittal plane. See this sagittal plane at the vessel level. As you come from anterior, from the maxillary sinus from here, see this vessel is still anterior. So as it enters from lateral to medial, this is the point where we are supposed to catch this vessel. With this three-dimensional picture in our mind, our first approach after the dankers will be to go and catch this vessel. That is our goal. Second part, another important thing, as far as the three-dimensional or the extension of the tumor is concerned, this tumor is extending behind in the posterior part of the nasal cavity, nasopharynx. It is big. It is like a ball within the nasopharynx, the huge one tumor. This tumor is so huge in the nasopharynx, if I measure in dimension like a cricket ball, this measures right from here to here almost 5 centimeters. Anterior to posterior almost 4 centimeters. If I see another plane, I will show you the other dimension in the coronal. Then this tumor is extending. See in the infratemporal fossa, very clear,
Yes.
going posteriorly in the infratemporal fossa, that is anterolateral extension, this is posterolateral, and then some part of the tumor is between the pterygoid plates. In the pterygoid fossa, you can see very well. Can you see here?
Yes, yes.
Yes, sir.
So these are the extensions of the tumor, and again, if I reconstruct in the coronal plane, this is a very important information we get again in the coronal. See this tumor. The superior inferior height of the tumor, I told you it is like a cricket ball. Again, more than 4 centimeter. Hanging down in the oropharynx, and this patient has intermittent breathing issues as well. That's how he has come for surgery now. Because otherwise it is painless. He had some bouts of bleeding which he could ignore, but now with the respiratory issues, now he has come for surgery. And another thing, see, this tumor is entirely one component. Entirely one component. What it is prolapsing here and there is different thing. The important thing which we should never miss is this pterygoid fossa component. This is the maxillary sinus. If I go behind, that's the pterygoid fossa. This component in the pterygoid fossa may be missed if you are not careful. And that is only in the upper part. This is upside down picture. And see, this is the pterygoid process, and this is only in the uppermost part. Lower part has muscle and there is no tumor. And that's what we'll corroborate intraoperatively as well. Now, regarding the destruction of the pterygoid process, this tumor has gone laterally in the infratemporal fossa here. It has eroded the pterygoid process medially, the Vedian canal completely eroded, and we have to be very, very careful in the region of the Vedian canal, which again remains one of the common side of a residual tumor. We have to drill away thoroughly. If you go to a publication from Dr. Alok Thakkar from All India Institute, 2016 in head and neck, they had almost like 40% incidence of the pterygoid canal invasion, which can be easily overlooked. And this is something,
Yes,
this remains, or this forms the major cause of a so-called recurrence. And see here, the tumor is little bit prolapsing in the sphenoid floor. Not much in the sphenoid cavity, just into the sphenoid floor here, and just protruding inside the inferior orbital fissure. A little bit, very small component going, not much behind. Anything, and this floor of the middle fossa is completely intact, no intracranial, no significant intraorbital, unlike the previous case where it was going to the superior orbital fissure. More and more component is in the nasopharynx, posterior nasal cavity, the pterygopalatine fossa, infratemporal fossa, and this huge component in the infratemporal fossa going behind as well. That is our part of area of interest which we intend to resect. MRI in this case is always useful to substantiate that your diagnosis, because it gives flow voids. Like any vascular tumor, it has flow voids by means of which you can diagnose. We are never supposed to take a biopsy in these patients, because these are male adolescent patients who present with obstruction and bleeding, and that's how the radiology can reinforce the diagnosis. In doubts, you can get MRI done, you can get diffusion to rule out any malignant or any other tumor. The MRI can give you good information about involvement of the critical neurovascular structure, skull base, intracranial structure. In this patient, since the tumor is not invading deeply into the skull base, we didn't order an MRI. That would not give us any additional decision-making information. That is all about the radiology. Raman, anything you want to add on? You are in the institute, you are in the all MRI and angiograms and all that, and you've been doing a lot of angiofibromas. Anything you do different? Hey, you have to unmute, man. Unmute. Yes.
Can you hear me now?
Yes, very well.
Okay. So as far as the protocol, it's the same. It's absolutely the same. There is no second opinion about that. A few things I would like to add is like the extension you are showing in the nasopharynx. This makes a tumor slightly difficult because of the dense adherence to that area. So I would be more comfortable doing a tumor which is not densely adhered into the nasopharynx completely, because it is occupying both sides. It's one space, but left and right both. It makes dissection slightly more tricky. That is one. Secondly, as Satish has always said, that in the sphenoid sinus, the tumor doesn't attach. In the brain, it doesn't go intradurally, it can reach up till there, but it can cause local destruction, but it doesn't go into the brain tissue. So there's a reason for that. And the reason is, if we go back to basic anatomy, we know it arises from the sphenopalatine foramen. I mean, there are various theories and there are various areas where they say it arises from, but for most of us, especially PGs and young surgeons who are in this talk, it arises from the posterior superior part of the sphenopalatine foramen. Now, why is it not densely adherent if it encroaches into the sphenoid sinus, or why isn't it adherent to the orbital tissue? There's a reason for that, because the body and the wings of the sphenoid bone, it undergoes endochondral ossification, whereas other parts, including pterygoids and nasal bones and other part of the skull, undergo intramembranous ossification. So this is the difference. So therefore, occurrence of microreceptors होते हैं जो adherents के, which include different types of cadherents and integrins, are different for both type of tissues, and hence any growth which originates from one of these compartments will not be adhering to the tissue of the other compartment. So that is the reason you will not find attachment in the sphenoid sinus, you will not find attachment to the tissues of the orbit, or even intradural, as Satish was mentioning.
Great boss. That's a great,
Very
clarification.
informative.
Yes. Why it doesn't attach to the sphenoid sinus has been so important to know. And thank you, Ramani. Madam,
mentioned
you
he's
want
a
to
great
add on
thinker.
anything?
Yeah.
Madam, you want to add on anything before we start? I have watched up.
No, yeah, please wash up, and we would like to see your surgery start. I have
So-
nothing to add as of now, Satish.
Thank you. So I am all set
Raman,
here.
you can see it again. Endochondrial. At what else? You can see it again.
Endochondral ossification.
Yeah, and membranous.
Yes. Yeah, Ramandeep, unmute.
Unmute. If you don't mind the critical point, you just
Yes.
re-emphasize.
Yes. Can you?
Yes, I will just repeat what I said. The body and the wings of the sphenoid, they undergo endochondral ossification. Whereas other parts, including pterygoids and other parts of the skull, they go intramembranous ossification. So endochondral versus intramembranous. So the microreceptors for adherence, which include different type of adherents and integrins, are different for both.
Okay, thanks.
Superb.
Super,
So,
got it. Yeah.
are you getting any endoscopic picture now?
Yes.
sir. Yes, sir.
Let me do some white balance. Okay. Now,
So
how's the
Satish, are you
picture?
going
How's the
to
picture?
put on standard or chroma clara or clara or chroma alone?
Okay, let me show you which you want. This is standard.
Yeah, okay.
Oh.
The
Not
right
changing.
arrow on your camera.
So, what do you suggest to do in Clara to see vessels much better?
So this is basically you are using a image one spice system by Carl Store.
Yes, that is a.
Yeah. So SPICE stands for Store's Proprietary Image Enhancement System. SPIES.
Yes. So
It
this.
has two, standard is what you would get from any other camera. Then it has Clara, and then it has Chroma, and then it has a combination of both. Clara will give you increased contrast. If you can focus at an area of the tumor, जहाँ से tumor दिख रहा है, and you press Clara, you would be able to see with increased contrast.
I don't know why it's not changing.
Dark also comes into view.
So that is the beauty of the SPICE camera.
Of the SPICE camera, exactly.
So this is the initial picture without any preparations, and as usual what I'm using is the saline adrenaline soaked, the gauge pieces for the decongestion. In contrast to the sinus surgery where we don't use these gauge pieces and we use absolutely atraumatic Merocell.
Yes.
So this is the initial picture.
Saha from Calcutta is asking, can JNA cause bone destruction?
Yes,
Like-
though it is benign, but it expands. And during that expansion, it can easily destroy the bone. and it destroys. You see in the large Jain is the skull base destruction. That's why it enters the intracranial space.
Yes.
How can the tumor enter the intracranial space without destroying the bone?
Yes. Yes.
So it is locally aggressive. It is locally aggressive and it destroys the bone. But it protects the neurovascular structures. You know, in contrast to the paragangliomas, they destroy whatever they come in contact with. Even the neurovascular structures, they destroy. But here the Jain is, they respect the neurovascular structures like the nerves I will show you, and we have seen in the previous cases, the V2 and other nerves, they respect, except the, the Vedian canal, where the tumor, when extensively invades the Vedian canal, it is difficult to save the nerve. Similarly, the carotid artery in the last case you saw, it pushes, it grows by pushing, by expanding, and there is always a thin periosteum which remains over the carotid artery, however extensive the primary tumor is. And that is the beauty of this particular tumor. This, if you follow, after understanding this, certain features of this tumor, I believe and I think it is a very well behaved tumor. What we have to do is to take the advantage of this understanding. And here, our goal of this surgery, in this endoscopic surgery, I told you, this can be removed endoscopically, provided we expose it from all around and take the vessel into control before we go into the tumor. I may have to divide the tumor after controlling the vessel in the end, like we did in the previous cases, to remove the tumor in two pieces, so that we first remove the intraluminal part, acquire more space inside, and then we can bring in the extraluminal part. So that is a strategy in the laterally placed tumors many a times. But the main, highlight or hallmark of this surgery, main hallmark is exposure, exposure and exposure. My 90% of the time is going to be invested in exposure. We'll expose it from all around 360 degrees, and then we'll catch the vessel, and then we'll go into the tumor. So in this exposure, in this dankers, modified dankers, I would say, the danker which was described earlier was through the sublabial space. So this is the axilla. My point of, interest over here before removing this medial wall and the anterolateral wall is to know the level of the orbital floor. That is going to be my upper limit. Unless you open the maxilla, you can't see the level of the orbital floor. By and large, what I can say, if you take this level of the axilla, staying 1 centimeter below the axilla, just 1 centimeter below, I can remove this wall and still my orbit remains up. So I can still spare my orbit, avoid an orbital entry into the beginning. See this, my man of the match tool for the entire surgery. This is never to be used to remove the tumor. To remove the tumor from inside, never. Though this has a property of hemostasis, but we never advocate to use it inside the tumor to remove it. This is for surface coagulation. The reason is, this tool has an amazing ability to cut. See, now I am using the cutting. Ramandeep.
Yes, we can see this.
See this, I can remove this so vascular periosteum without a single drop of blood over here. It maintains your visualization, and that is something required in vascular tumors when you are operating endoscopically.
That is the most important thing. If you can see everything, because of the hemostasis, it makes the surgery easy.
So first I coagulated, and then I am ablating. At any point of time, we are not supposed to use it on the bony surface, otherwise that may ruin the wound. Ramandeep,
Yes, Satish.
can you say something about the principle, how the coagulator works? You talk about it a lot.
Right. So coblation is made up of two terms. It's a short form of controlled ablation, which they join together to form the word coblation. It is coblation. The name itself is proprietary of, it was Arthrocare before, but Smith and Nephew now. It works on the principle of creating plasma. Now, what is plasma? To understand that, we need to know that when liquid evaporates, it forms gas. But when gas ionizes, it forms plasma. So coblation is nothing but ionized gas. The advantage of this tool is that it has suction, it has irrigation, it has plasma ablation and coagulation built into one tool. So Satish has an endoscope and just a single tool which is doing suction, irrigation. He can clean his endoscope also with the irrigation, with the same irrigation. He can do ablation.
One magic tool for everything.
So imagine if he had to use a bipolar cautery. Number one, working with a bipolar cautery, opening the tips and closing it is very difficult. Then he needs a suction to evacuate the spoke. Then he needs someone to irrigate so that it doesn't stick. So his space gets very limited. But with this single tool, he is able to work in narrow confines of spaces also. Now the advantage of coblation is that its penetration is just 1000 micron meter. That is about 1 millimeter penetration. Compare it with cautery, monopolar or bipolar, which run into a...
So that adds on to the, the low collateral damage the cobbler gives.
Yes. And the temperature which is produced runs between 40 to 70 degrees Celsius, which is again very minimal and prevents collateral thermal damage.
Now, I want to show two things here. See, this is my anterior limit, the pyriform aperture, you can see very well. Yes. The edge of the bone. This is my medial wall where I remove the mucoperiosteum. And now what I want to see, this separate bone. See this? This is inferior turbinate, which is a separate bone. It is not a part of maxilla. And when we remove the inferior turbinate from anteriorly, we will encounter some bleeding because this turbinate is mainly supplied from behind by a branch from sphenopalatine, which so far we have not taken into control. So that is little bit bleeding expected, and once we have a cobbler in our hand, we can handle that very easily. So I am removing this inferior turbinate. So in my exposure part, as I told you, my 90% of the time will be invested in exposure. With this cobbler in hand, majority of the time, 90% of the time, we get away with a transfusion, any need of transfusion, without embolization. Once you know the vascularity to the tumor, you can catch those vessels before going to the tumor, and you can certainly avoid, in majority of these patients, embolization. Unless are the indication that I have several times mentioned. Once you have a vessel coming from behind, you cannot help. Then you have to do something. Either embolize, go by open approach, you have many options.
So Dr. Ramandeep sir, I have a question for you. Do you embolize your JNAs or you don't?
So standard institute protocol above, depending on the classification, if it goes to PA, we do embolize. But ground reality is many times.
Paramita, they have amazing neuro, interventional team, neuroradiology team, intervention radiology team. Okay. I know the PGI, intervention radiology team is supposed to be the best in the country. You have heard a lot about them, and that's why they have luxury.
Okay.
So that's why, and see, that is a teaching institution with such a good team around. They embolize most of the cases.
Yes.
But that being said, if you do the surgery according to the principles Satish is explaining, number one, you need patience. Exposure. If you have that and hemostasis, this tumor removal is not difficult. The biggest part is people run out of patience and then they start blindly pulling the tumor without, trying to find where it is attached, without having read the radiology, and that creates a lot of bleeding. And then you can forget about removing the little extensions. But if you have hemostasis, you will be able to see even the smallest of extensions. Like going into the Vidian, going into the inferior orbital fissure, the superior orbital fissure.
See what I am doing here? See what I am doing here?
Yes, sir.
I am not using the cobbler here because there was some bleeding coming from the underlying bone.
Yes.
And using the cobbler there is inviting problem. You can ruin the cobbler vein completely.
Yes.
And see, I have almost removed this part of the inferior turbinate going behind toward the tumor.
Yes.
And
So,
see
sir,
my...
yes.
Yes, yes, please.
Dr. Riaz Afridi from Pakistan is asking which extensions are not in the spectrum of endoscopy?
Which?
Extensions are not in the spectrum of endoscopy.
No, no. Any given extension can be removed endoscopically, provided the vascularity to the tumor fulfills your criteria. I have already mentioned, had I been having this tumor with a vessel coming from behind the tumor, I would not take, first of all, directly like this, either embolize the tumor or you go by open approach, number one. Then secondly, in certain extensions, which happen mostly in the revision tumors, rarely in the primary, when the tumor acquires the vascularity from the intracranial vessel, we have seen in few cases, when the tumor has the vascularity coming from the middle cerebral artery branches, the tumor which has gone intracranial, acquired vascularity from the middle cerebral artery branches, we can't afford to remove the tumor, pull from below, leaving those vessels bleeding inside. And those are certain disadvantages, and that really happens with a primary tumor. So by and large, majority of the primary tumors, however big they are, you can remove endoscopically.
Okay, sir.
This CT angiograms helps you a lot. I couldn't show because I was going fast, because we had discussed couple of times. You have to see every time when the tumor is close to the carotid, the cross flow. In CT angiogram, I can show after this case is finished again, how the cross flow at the circle of Willis level is, and that helps in planning your surgery when you work around the carotid artery.
Yes.
Now see, this part of the tumor has come in your exposure. See again the beauty of the coagulator. We have understood by a lot of histological studies, this tumor has a maximum vascularity on the surface, So whatever tumor you expose, keep coagulating. See this? So any inadvertent touch of your instrument handling of the tumor will not start massive bleeding.
Yes.
So whatever tumor you keep exposing, keep coagulating.
Yes.
Keep coagulating.
Yes.
Is it attached
So
to the
Dr.
medical-
Somnath.
Yes.
Dr. Somnath Saha from Kolkata is asking, can you do surgery without a coagulator? I think it will be...
We can, but making our life difficult. See, we have to think of the best. Why we are, what we are thriving for in these academic events, to do for the betterment. And if you have a better tool, why not to use it? If you don't have it, a different thing, and that I say, in this JNS surgery, doing without coagulator is something a disadvantage. See, this kind of, dexterity, the ease, the way you handle the surfaces is not possible with any other tool. With all the time irrigation on, all the time, the suction on, keeping your visualization good. So see, whatever surface now visible to me, the tumor surface, I have coagulated.
Yes.
This will help me. See, this shrinks the tumor as well. I can see right up to the nasopharyngeal level now so well, as the tumor has shrunken because of the surface coagulation. See that? I had shown you how big the tumor in the nasopharynx. That is behind, is going to be the level of the eustachian tube, which is completely compressed. You see this tumor? How big it is going behind. There is hardly any, sphenoid component. So my goal is not going to go into the tumor right now. Right now is to go onto the vessel, expose the tumor from every side, 360 degree. And now what I am doing, this is the level of the pyriform aperture, and now I am elevating this mucoperiosteum from the anterior wall. You can see. This tumor has a significant lateral extension as well. Has a significant lateral extension as well, and this anterolateral extension of this approach will certainly help us reaching even lateral and inferior to the tumor. That is something very, very important. Another important thing in the exposure, see my level of the floor of the nose. Can you see? From both sides, my level of exposure is to flush with the floor of the nose. This is very important. Any bony impingement, any bony overhang here at the anterior margin of the approach will impede your instrumentation in the depth. So always, once you start this approach, always, flush with the floor. Take the full advantage of the exposure. I hope it is clearly visible.
Yes, sir. Yes, sir.
See now the anterolateral wall. See these vessels which are compromised. These are anterior superior alveolar nerve branches, small. See these small vessels which I am severing. You see this? Anterior superior alveolar nerves and vessels. Through their numerous interconnection, there are multiple branches of these nerves. They regenerate in a period of 3 to 4 months, and until then they give some sort of paresthesia on the incisors and the upper canines. See, to me this is good exposure. In case required, I can always extend it.
Yes.
Okay?
Yes, sir.
Now see on both sides. That is my tumor there, the nasal cavity. This is my anterolateral exposure, and this wall, this wall is something I need to remove to enter right into the tumor head on. That is my primary goal, to enter into the tumor head on. As I always mention, our goal is to keep the floor of the orbit as our upper limit so that we don't make an orbital entry unnecessarily. And here, I will show you the level of the orbit by entering through the anterolateral wall.
Yes, sir. So, Dr. Sandeep Karmakar is asking, do you contemplate doing an early posterior septectomy in this case?
Why early? We will do a posterior septotomy. Posterior septectomy we will do later, when we go to the exposure of the posterior part of the tumor.
Okay.
But I will do that after controlling this vessel first.
Okay.
See, this is a sort of entry into the maxilla. Can you see the mucosa of the maxilla?
Yes.
This is just mucosa of the maxilla here. And see, I told you the tumor was pushing from behind. See this tumor?
Yes, sir.
Superiorly and behind. And this is the mucosa of the maxilla giving rise to sort of mucocele here.
Yes.
Mucoceles do not enhance on a contrast administration. See this? I am removing this bone so easily now. Having drilled this part, you can remove it so easily. And this is my head-on entry into the maxilla. See the nasolacrimal duct now?
Yes.
Here, riding up. Can you see very clear?
Yes, yes.
In this Denker's approach, you have to do something carefully to this duct to avoid this morbidity of epipora otherwise. And that I will show you as we always do. We have told couple of times.
Yes.
You have to cut it flush to the
Flush it.
orbital floor.
Yes, yes.
Debrider. Now see, this is just the mucocele inside. Tumor is behind, coming from above. We had seen in the CT angiogram how the tumor was, pushing from above and behind. See this mucocele?
Yes.
And this is right into the sinus.
Satish, can you show everyone the markings on the microdebrider which prevent it from entering into crucial structures?
Marking on the microdebrider for what?
The arrows on the tip, so that even when the tip is buried, you know where the cuttings are.
Yeah. How deep you are.
Yeah.
Where exactly you are. Important point. 40. See, I told you, Ramandeep has a huge insight of the instrumentation, and these things matter. once you're working in the depth drill, you have to be careful how deep you are to prevent unnecessarily damage, give any unnecessary complication. And that's how this micro debrider have, given these markings. Let me show you. First, since I have entered into the sinus, now using this is my favorite tool again for the region on the merit. See this high speed drill. This is coarse diamond. This is just diamond. I am running at a speed of right now at a 60,000 RPM. Debrider.
So see, choice of selection of instrumentation at what point is very important. He could have used a cutting burr also, but he's using a coarse diamond. The coarse diamond will not only remove the bone, it will also cause hemostasis because the diamond pushes the bone into the Hershey system, stopping the bleed off. Secondly, even if it engages a tissue or part of the tumor behind, it will not cut through it. That is why his mucocele, which he was saying, did not get ruptured. Had it been a cutting drill or a rooted drill, it would have gone through.
Absolutely. See, that is the maxillary sinus from inside, and that is the tumor which is pushing from behind and above. I am removing just this mucocele part. My aim here is exposure, exposure and exposure. Cobblator. See, wherever is the bleeding from the soft tissue, give a cobblator, you don't need anything else. That's why we call it as a man of the match tool for this surgery. The beauty of that burr, the stylus burr point is, it has an inherent 15-degree angle. So whenever you see, whenever I am drilling, my shaft doesn't come in the way. That is another advantage to maintain your visualization, so you can be more precise in your drilling part.
And another advantage of the cobblator he is using is that the wand can be bent if he is working into crevices or an area which is difficult to reach head on. He can gradually bend the wand till 40 to 70 degrees and it will still work.
I can go more and more anterolaterally up to the infraorbital. Now if you want, you can go easily without any huge morbidity or anything. But if you really want to go beyond that, then obviously you have to transpose the infraorbital now. I mentioned during the cadaver, if you observed, that how the Paul Casanova described the transposition of the infraorbital now. And still you can go around and work, go around the infraorbital nerve and work without giving any additional morbidity. What I want to know here is full lateral, the exposure required for this tumor, at the same time flushing with the floor and the orbital floor. So here, this is my obstacle. See, if I don't remove this bone over here, this will impede my instrumentation further in the depth. So it is so important to completely flush with the floor.
And did you notice how the diamond drill stops the bleed? His bone
Yes.
was bleeding, he ran it over it, the bleeding stopped.
And it's a...
Have you noticed any long-term facial deformities when you do this extensive Denker's approach?
Not really, madam. I mentioned earlier as well. See this. That happens when you happen to damage this lower lateral cartilage, If you happen to damage this lower lateral cartilage, then you need to, reinforce it with another cartilage. Otherwise, this will droop.
It doesn't.
That is the only thing which can happen.
Sometimes these children are quite young, so that's why.
Yeah, that is important that's an important point you have raised. we are not supposed to go too anteriorly to damage the lower lateral cartilage to give that deformity. See, this completely flush with the floor. And see, the level of the maxillary sinus is below the level of the floor. With the development, the maxillary sinus go more and more deeper down and goes even below the level of the floor. Now the biggest challenge we have is this tumor. See this? This tumor coming right into the maxilla here.
Yes, sir.
I showed you on CT scan, that's why I told you this is a different extension which has some challenge, and challenge is so obvious here, as this tumor is right coming, prolapsing anteriorly into the maxillary sinus. Because there is a thin wall, because of the tumor pressure, it keeps on thinning anteriorly, and that's how this tumor is pushing from behind. What I'm doing is just trying to shrink this tumor a little bit to get more space around. Because we have to go behind this wall. I know my target is the vessel. You have seen, I had already shown you on CT angiogram. I will go behind it and catch that vessel. See how the maxillary sinus is occupied by the tumor that we had seen in the CT angiogram.
Yes, sir. Sir, can we use a long nasal burr instead of stylus system?
Long?
Nasal burr
Yeah.
instead of stylus system?
Yes, you can use long nasal burrs, but this system has an inherent ability to irrigate at the same time, the inherent angle to keep your visualization, the high speed, and such a, very small pencil-like, the shaft of the burr. To hold the burr more effectively, you can use it more precisely. These are all advantages, and these are required when you are working endoscopically. So this is additional advantage. I am not saying you cannot use that.
I think
When you're using a nasal burr,
can be used in this. The answer is no. You cannot use a regular burr.
cannot be used.
Okay, okay.
Have specific burrs.
You can, but you have to struggle a lot. You have to
And you will damage the anterior part of the nose also, near the ala and all.
Yeah, your control becomes poor.
Okay, okay.
See this, how much I am shrinking it to go behind and lateral to the tumor. See, this is the posterolateral wall. And we have to go behind to catch the vessel. See, if you try to go inside the tumor, it will keep on bleeding. So you have to be very, very careful. A little bit of the... See, this is the periosteum behind. Can you see?
Yeah.
And this is my level of the floor. At this level behind, around 1.7 centimeter up, at this angle I am going to find the vessel. I have already told you. See this? This cobbleator helps me shrinking this mass, this tumor coming into the... See now how it has shrunken. How much space I have gained now. See this? Just because of surface coagulation. Now, give me a pack. Now, at this point of time...
White balance the system now?
White balance? Okay. Just a minute. I'll just put a pack over here for this surface oozing. Yes.
And the back of the lens also, if you can clean it once. Thoda sa, I don't know.
Okay. ये लगाना, clean करना. Yes, clean कर. ड्राई से इसको भी कर दे. Okay, boss. Okay. Should be better now. Is it?
Yeah. So sharper.
See now the picture?
Yeah.
Now the first goal, before I go to the vessel, first goal is to take this nasolacrimal duct away. And my point would be to flush it, cut it flush to the level of the orbital floor. Let me show you. It should not project below the level of the orbital floor to get fibros later on. That is very, very important point. And by simply doing this maneuver, keeping this thing in mind, you can almost always avoid an epiphora, post-operative epiphora. And see how I discover my level of the orbital floor. This is the tumor surface. Again, more and more shrinkage. See this? Keep using cobblator to shrink the tumor. And this really helps a lot in reducing the overall vascularity, in reducing the vascularity, the bleeding during handling the tumor. See this? Now, drill. See this part of the bone which is projecting still? I will flush it. And see the beauty of this drill. My shaft is nowhere coming in the way. Can you see? Paramita, can you see this?
Yes, sir, very clearly.
See, it is so good a tool. Now see,
Yes.
this has gone. Now this is the canal of the duct above, close to the orbital floor.
Yes.
I told you I will cut it flush, sharp, right at the level of the orbital floor, not below at any point of time.
Yes. So on what power is your coblation? Dr. Dhananjay from Ahmedabad.
9 and 5,
Okay.
full setting,
Okay.
all the time.
Okay. Dr. Jeevan Vedi from Nagpur is asking, so up till now what you have done is called the medial maxillectomy?
You can say medial, see these definitions are, different.
Yes, sir.
Medial maxillectomy, as the name implies, remove the medial wall. This is not limited to the medial wall. I have removed the part of the medial as well as the anterolateral wall. See the beauty of this burr. It doesn't damage any soft tissue.
Yes.
Even at 60,000 RPM, it is not catching on to the soft tissue.
Yes. And now see the level of the floor. So for him, this is not a true medial maxillectomy. This is removal of the medial and the anterolateral wall, and this was described initially by the Stunman and Canfield. That's why this is also known as Stunman-Canfield approach endoscopically. Now see the roof of the maxillary sinus, very clear?
Yes.
See, very clear?
Yes.
And now we will catch this duct and cut it sharp. See this? Catch it. And we will cut it sharp close to the orbit. See that? It should not project anymore.
Yes.
See this? Hello?
Yes, sir. Yes,
Yeah,
sir.
now this will never come in our way as we have to work behind.
Yes.
So this is one part of our goal. Wash. This surgery, or rather any skull-based surgery, next week we are going to do more and more endoscopic skull-base, as we are following the feedbacks of the people, what they want to see. And now I will remove the rest of the medial wall completely till behind, till the posterior wall of the maxilla. Okay?
Yes, sir.
See the beauty of the cobblator. It gives you amazing, amazing field. While using the cutting, you have to be careful. See, this is the tumor which is additionally extending anteriorly, which you had never seen in the previous cases.
Yes.
That's why it is a different extension I named. I told you when we kept in the list, so you can handle how to handle this. You can see very well. See this medial wall, I have to completely remove it until I flush with the posterior wall. Debrider. दूर कर दूर कर
So you will get some amount of bleeding.
See the both aspects of the tumor, the medial part and the lateral part both together. Can you see?
Yes, yes.
And this is little bit of the oozing from the sphenopalatine coming through the turbinate. See from behind.
Yes.
I told you this turbinate is supplied from behind.
Yes.
With a big vessel that is a branch of the sphenopalatine. And that you cannot control now unless you take the sphenopalatine in control.
Yes.
So I am not going to do anything. I will leave a small pack there. No point in fiddling into that space unnecessarily, as we have not controlled the vessel so far. See this.
Yes. Yes.
एक और दे दे. See, this is, you have to anticipate this once you remove the inferior turbinate.
Yes.
Yes. Now, our key area, now the most important step of the surgery is going to come to go behind this and catch the vessel. To devascularize this tumor to some extent. Back. I hope the picture is good there.
Yes, yes. Very clear.
See, I cannot coagulate this edge of the nasolacrimal duct which is oozing. This is going to stop on its own in no time. I can apply a little bit of the adrenaline over there. Yes, here I can. See this vessel around.
Yes.
So now. Yes. We are not supposed to do any extensive coagulation onto the vessel to give rise to stenosis. Now, coming to the key area. Wash. Yes. See, this is the tumor which is bulging from behind. See this?
Yes. Yes, sir.
Unusual bulge of the tumor, making your life difficult to go behind. What I am going to go now,
So
see
will
this
you
is the
give
bulge.
a- Yes, sir.
Now this is your pterygopalatine fossa periosteum. See that?
Yes.
Our goal is there. This tumor which will devascularize in no time. Cobblator. See this. Our target is here. Our target is here. I have to go behind this periosteum. See, that's the fat inside. Yes. See, this extra tumor bulging into the maxillary sinus is posing problem. That's what I wanted to show you.
Yeah.
Probably we are on to the vessel very soon. We have to do little bit maneuver.
The good thing is the cobblator wand can also be used to dissect bluntly in this area.
Yes, yes. Very well. You're okay.
Normally, how many cobblator wands you use in one angiofibroma such case?
One case.
Yeah,
Single wand is good enough most of the time.
more than.
If you use on the bony surface, it can ruin any time. So you have to be careful not to use on the bony surface.
So Dr. Tapan Kanti from Kolkata was asking, can you debulk tumor by coblation?
Yes, I can, but it can lead to bleeding because we have not taken the main vessel into control yet.
Yes, sir.
Yes.
See now, you have to take the judgment what you had seen. This is the level of the floor, and your vessel was entering into this fossa here and riding up. So keeping that thing in mind, I have to explore this area thoroughly. Challenge is to retract this part of the tumor and keep this area bloodless.
And that is why it is very important how much part of the interior part of maxilla you remove.
Yes. See, without this exposure, it is impossible. Without this exposure, yes, I can see the glimpse of two things I will show you, because laterally we have to be careful about the nerve as well. We are not supposed to damage the nerve, and I can see the glimpse of that, and my vessel is going to be below it. So what I will do, I will improve my exposure. I can see the glimpse of the nerve over here. Can you see this prominence? Can you see this prominence?
Yes.
That is the infraorbital nerve. That is the infraorbital nerve canal. Can you see that now very clear?
Yes.
Clear or not?
Yes, very clear.
Very clear, sir.
And my vessel is going to be below that, and that is the vessel. Now I have seen.
So this is just fat. He's ablating it away. He's eating it away.
Yes. I can see the glimpse of the vessel. See how I identify the vessel over here? Let me give you a very important point. This vessel gives a branch, see this infraorbital artery, going along with the nerve. Can you see this?
Yes, going up.
And if you follow this, you will find the main trunk of the vessel. Can you see the main trunk below?
Yes, there it is.
Yeah, now we can see it there.
That is the main trunk of the vessel. See how you can take into consideration right angle. All these landmarks to catch the vessel. So first give me the, kerosene. I will improve this exposure a little bit more. I have seen my vessel, everything under vision. Now I will take this bone a little bit more to show you better.
Because it's already thinned out. You can see the difference.
See, you have to be careful while using this instrument to stick right onto the bone. Absolutely stick to the bone. Yes, give me cobblator. Let me clean the field. See, these are just periosteal vessels which I have bitten through my kerosene. Just periosteal vessels. That is the nerve above. and that is the vessel below. Can you see this?
Yes, yes.
I will open up everything crystal clear. This vessel I will coagulate, the infraorbital one, Kerrison. This is the most critical part of this surgery, to take this vessel. Make more and more space before you go into the target. See this. Coagulator. More space. More you go laterally, more you clear laterally, more safer it is. And this infraorbital fat is the sign of your limit. To define, yes. To define your limit. I have seen my vessel already. See from where this vessel is arising. Now the issue is to take control of this. Right angle?
So would you use a
Section.
bipolar or clip it?
No, why bipolar? When you have a coagulator, section kar. Section le. No, section. Easy. I want to show you the arcade of the vessels.
So he's going to hook it from behind and get it to the forefront.
पकड़ना. Coagulator. उठा. हाँ. Yes. See, नीचे छोड़ दे. Finding this vessel at this proper plane is so important.
The most important thing.
Yeah, the most important.
Because if he accidentally cuts it here, it is going to retract and continue bleeding.
Like that, no? Give
Then
me
you
a
will
pack
have
for a while.
Wait.
Just 1 minute's time and it will be over. Just to clean the field for you.
See, this is where patience is required, what I was talking about in the start. Normally people would start tugging at the tumor by now.
Using close-up. Remove this fat to open up the space more and more. And that is the vessel behind. See the main vessel. Could you see the glimpse of that? Behind the fat. See behind the fat. Could you see behind the fat? Hello?
Yes, it's very
Yeah,
clear.
you can see, yes, very
Yes.
clear.
I will make it more clear. So what I want to say is more exposure. Give me, no. Coagulator. I am not so keen to catch the vessel early before I expose it thoroughly. I have seen the vessel. Only thing is to tell you how to catch it. Removing this fat all the time.
We can remove a bit of more of bone, sir. Then, sir, Amit case with this case.
Yes, I am planning to remove this little bit of the bone removal as well. I've cut this branch. See, all this fat I am taking away. You can take away with the debrider as well. Whatever, with full control.
And see, he is not burying his wand into the tissue, because if he does that, he can damage the vessel.
Forceps. See, I am making more and more space. Debrider or cobbler?
Yeah, there it is.
Will show you the great picture of the vessel.
So he has the nerve on the top.
Yeah, I have seen the vessel.
You can see a glimpse.
Just to show you.
So he's just going to slowly open up that area.
Retracker. See the vessel there.
Now, yeah. Now it is clear.
वो कहा गया राइट एंगल क्यों मांगना पड़ता है देना रिट्रैक्ट सेक्शन this is my vessel. Pack will show you better. Just a minute and I am right on the vessel. This is so important. Taba?
What is the average blood loss of these cases? And when you recommend blood transfusion in these cases?
Pardon?
What is the average blood loss on all these cases, like angiofibrosis or this average blood loss?
Not much. That is the main vessel. Chhodna. Just for the hemostasis, I put this pack. And now, see the main vessel.
Yes.
Very clear now. Now it's very clear.
Yeah, see the vessel behind. Yes, this one behind. Can you see?
Yeah.
Right.
If you remember in the angiogram, how this vessel was ascending. See this vessel?
Right.
It's amazing, the cobbler.
Cobbler or clamp?
Pardon?
Cobbler or clamp? You will clamp it or?
Yeah. No, I can take the vessel with the clip, I can coagulate it, I can coblate it depending upon the configuration, dimension. Sometimes this is one of the branch of the vessel because it gives branches also. But this is a very clear-cut vessel. You can see the huge one.
Yes.
Can you see here?
Yes, you can clip it.
Our nerve is above, so always the vessel will be below. The nerve is retracted above. See that? Here. And that is the muscle surface behind. Can you see that?
Yes.
And this is our vessel. At first I am cobblating this. See this? I can easily coblate this to improve my visualization. This is the muscles behind in the infratemporal fossa. You can see very clear. See the muscles?
Yes.
This is lateral pterygoid muscle. Laterally, this is temporalis muscle. This is temporalis. See laterally vertical muscle? That is temporalis, and this one is the lateral pterygoid muscle.
Yes, sir.
And on the surface of the lateral pterygoid, I cobblated this artery. I didn't even bother to catch this at this moment because I found this coblation can do this without any issue. This is not such a great vessel, I would say, though we will catch it later when we mobilize the tumor. But this point of time, this will help us reducing our vascularity. See that? What an amazing situation. And this all difficulty was given by this tumor extension debrider. This tumor which is coming in the maxilla. See this? This is the biggest of the problem we are facing. So this is a different extension with different problems. And now I can do my rest of the job. Connect.
Yeah. Satish, can you show the arrows on the debrider, the other side ones, just for the
Is नहीं चल रहा ना?
suction block?
See this rest of the fat. See you more and more picture of the infratemporal fossa. See the entire infratemporal fossa.
Yes, yes.
So good. I can tease out this fat. And
See
this
how
is
we-
all muscles. All muscles. See here. Above is our nerve. You have seen our nerve is here. See this? And that has to be protected. Another thing, this was a branch going up there that I need to coagulate. Below the nerve. See this?
Yeah.
Hello?
Twig. Yes, the twig can be very clearly seen.
So now once I deal with the rest of the tumor, my bleeding will be minimized. My coagulator has done the job. I did not find to catch the vessel so essential. See this, everything is devascularized now. See in this area with no bleeding? Hello?
Yes, yes.
This is, I will tell you how the nerves ascend up.
Sometime with coagulator, it is difficult to find plane in this area. What is your tip, sir?
Yeah, sometimes you may find that issue. But see, all the time coagulator is a suction. It helps you work. See, this tumor never takes attachment to this nerve. You have to be careful. And in any given situation, you have to preserve this nerve. This nerve should never be sacrificed.
The patient has lots of problem afterwards.
This nerve is ascending towards the foramen rotundum.
Yes.
You have seen several times in these webinars. See this, I am separating my tumor from the nerve. Can you see? Hello?
Yes,
Yes,
sir.
yes.
All the way above and below, everywhere, no vessel is coming now. And I can do my other exposure now. This part I did in the beginning to take the vascularity in control so that when I mobilize the other parts, the bleeding will not bother me much. So this is not the only source of bleeding, but the major source of bleeding for this one. Now I will leave this field. See this part projecting into the maxillary sinus, how much problem it creates.
Yes, yes.
This is what I was trying to show you. Yes. Now, we have the anterior exposure, we have the lateral exposure, you can see. Now I will go up and take the superior exposure of the tumor. I will go behind to get the posterior exposure of the tumor. This is the turbinate I am cutting through. This is middle turbinate. This tumor almost always have an attachment to the middle turbinate. Almost always. Like Ramandeep said in the beginning, this tumor doesn't take attachment in the sphenoid. Similarly, this tumor doesn't take attachment in the onto the nasal floor, but turbinates, yes, niche suction. See now, My simple job, this is my unseen it. Can you see?
Yeah.
What I intend to do now, to do ethmoidectomy to see any tumor going up. See, this is my ethmoids. And here my lateral limit is going to be my lamina papyracea. See, this is lamina.
Yeah.
And there is no tumor at all. We knew from our radiology also, there was hardly any tumor going up into the sinuses. But you have to, blocked. But you have to ensure that no tumor is going up to the sinuses. That's why I remove the part of the middle turbinate going behind. See the tumor behind.
Yes, yes. Going up.
This is all tumor section.
The lower part of the filter sometimes supplies the tumor.
See, this is tumor, all tumor. I told you this tumor has a huge luminal component as well. But right now I am showing it from above the tumor. I am above the tumor into the sinuses and open up all these sinuses quickly. There is no point in wasting time here, we all know. This is for exposure and we have to dissect through all these sinuses to define the superior border of the tumor. I am staying right onto the superior surface. See this?
Yeah.
It's all the time irrigation by my assistant. See, all this is bony septation which I am removing with my forceps like this. Data, pieces data. And see all my ethmoid sinuses behind. All good?
Yeah. Looks good.
We know this tumor was going into the sphenoid a little bit from the floor, which I am going to show you. Now see the overall picture. Hello?
Yeah, yeah. Laterally we can see.
This is below, this is above.
Yeah.
Dish, is it taking any attachment from the septum also?
Always, almost always. I will show you and we will segregate that. Give me the cobblator to show you.
And just show with the cobblator how you lift it off the periosteum.
Yeah, see this. Medially, this tumor almost always takes an attachment to the septum. See here. Can you see here?
Yes, yes, yes.
What you can do simply, go and separate, coagulate the periosteum and work in the subperiosteal plane. See the subperiosteal plane? You can easily segregate from the periosteum. Wherever this tumor takes attachment, it acquires blood supply. See, this is separated from the septum. And this tumor surface now being coagulated again. Whatever the tumor you expose, keep coagulating. And this is a huge component like a cricket ball, I told you. This is superior turbinate. This is the sphenoid ostium, you can see. Can you?
Yes, clearly. Come into it.
So what I mean to do here is superior exposure, posterior exposure. Just stay above it and remove everything above that. All bone pieces, you have to ultimately expose this tumor, removing all bone from all around. That is the goal. See this cobblator, tumor surface from above. Now see, this is below and this is above. Entire tumor surface you can see this. And I can coblate. Wherever the surface comes in the picture, our goal is to coblate. See this? Entire surface being coblated.
And another advantage of opening the sphenoid is that it gives you a sense of anatomy. Many times you can get lost in large tumors if there is bleed. So this will also show you where exactly you are. You will know.
Yes, it will keep orienting you. Keeping the sphenoid in the field is something to orient you much better. See, that's a remnant of the middle turbinate below, which I am removing. And this is all tumor surface now. Very clear?
Yes.
So does the part of the
Debrider.
blood supply?
Pardon? Funny.
The lowermost portion of the middle turbinate give the blood supply to the
Yes, to the tumor. See now, I am widening the sphenoid sinus to show you. See? See the sphenoid from inside? And
Yes,
see
sir.
how this tumor has come in the floor. Can you see very clear now?
Yes.
Here it is. See, here it is. The small component in the sphenoid. Hold knife. Goblet. I hope you are oriented. This is the small component which is rising in the sphenoid sinus. See this? Goblet.
Yes.
Again, this is the superior surface of the tumor. Coblate. Always keep coblating. See this. You can completely coblate the surface to minimize the bleeding.
You just tell them what area you are working in right now.
Yeah, this one is the, see this, let me orient you.
Because
See
many-
this, hata. This is the nasal cavity, this is the maxillary sinus. Can you see?
Clear.
Oriented? Now I am above the surface of the tumor as I have dissected the sphenoid, the ethmoid sinuses and the sphenoid sinus. See this? Wash, yes. Wash will remove the staining and improve your visualization. See, this is the sphenoid sinus behind.
Yeah, very clear.
Very clear? This is the sella above. This is the clival recess. This is the surface of the tumor which is projecting. This is laterally the tumor. And here we went laterally to coagulate the vessel. And here, this is the nasal part. This is the floor. And this is the entire tumor. I hope you are oriented.
Very much.
Now this part of the tumor is the one which was bulging in the sphenoid sinus. See this? And I will keep coagulating the surface again. This is very important. Otherwise, it can keep oozing a little bit and spoiling your field.
This part is in the pterygoid.
Yeah, this part is in the pterygoid, we have seen. Now, this bone projection, I can always remove to flush this bone.
And you can get some annoying bleeding here many times.
See this projection of the bone, you need to remove, expose it more and more, and see this entire sphenoid component is in our view. Can you see?
Yeah.
Find all. See, this is the sphenoid component which is in our view. Now it is completely under view and the control. See now?
Right.
Now what exposure is left behind before we start delivering the tumor? Now only posterior medial exposure is left behind. And then I will divide the tumor and remove it. See this surface. Whatever surface, keep coagulating. Don't go into the tumor, just surface coagulation. It will keep devascularizing it, keep compressing it. The tumor will keep shrinking. Only one tool is working since beginning in one hand. That is coagulator.
So better.
I hope the picture is good.
Yeah.
Yes.
It is also very clear.
This is the level of the medial end of the maxilla where we are going to divide this tumor. See this? Later. That is. And that is the bone in between. Little bit of the bony piece left.
Where it turns into the sphenopalatine foramen.
Yes. See this bone.
And some bleeding can occur here once he pulls the bone.
Yeah, little bit. Now my last part, that is very, very important, to expose posteromedially. And then I will divide and remove this in no time. Like what you said, a little bit of the bleeding, it was expected.
That's why his suction was already there. Otherwise, this would have filled up and then you would spend time again cleaning this.
Yes, exactly. See, now the rest of the tumor I have pressed this side. Okay? Now, coming to the medial aspect, as somebody asked about removal of the posterior septum. This is the remnant of the turbinate. Now, this tumor has an important attachment in the roof of the nasopharynx, and it has gone across, because nasopharynx is a common cavity, and we don't have any visualization of the posterior part. See, now this tumor will behave so good.
Yes.
Surface everywhere devascularized, vessel we have coagulated at 2 places. See, this is nasopharyngeal surface which I am coagulating. Now, I will remove this medial wall. That is the posterior part of the septum a little bit, to expose my tumor in the nasopharynx up to the lateral limit completely. Okay?
Yes.
And for that I will remove this posterior part of the septum. The limit is generally till where the tumor comes. This is simply for taking the control in the roof and visualizing the tumor in the nasopharynx across the midline to the lateral limit, opposite side.
Yes, sir.
Completely.
Sir,
Then this tumor will be 360 degree in our control after this.
Yes, sir.
We are going as per our plan. Yeah, Paramita, you were asking something.
Sir, posterior septictomy and cross-code dissection, what is, can you comment on it? Dr. Papalanapan is asking.
Yeah,
Posterior septictomy and cross-code dissection.
that's what I am doing now. See this? To enhance our 360 degree control over the tumor.
Yeah.
I don't have at present 360 degree control. I don't have any information about the posterolateral extension, the posterior control, the control in the roof of the nasopharynx, not yet taken. Once I remove this part of the septum and go behind and across the tumor, I'll have a complete 360 degree in control. See this? The bony septum I am removing. This is a part of the, you can say,
The tail.
rostrum.
Ostrom of this.
Though in this it is not going in the opposite sphenoid, so it is not so important to go high up, so high up coagulator.
In large tumors, opening the other side of the sphenoid will also give you orientation.
Yes, yes. See this, the opposite sphenoid. Absolutely clear? And now this is your septum, which first I will coagulate.
Of the other side, he is doing it from the right side.
See this all. And now I will take away this mucoperiosteum up to opposite side. This is opposite side mucoperiosteum, you can see.
Yes. Now that space has opened up.
And see now in the opposite nasal cavity. And see the tumor prolapsing to the opposite side. Could you see?
And sir, it also takes blood supply from the other side.
Yes, I will. Before I remove the tumor, I will devascularize it. See how? Simple now. With this exposure, it becomes child's play. Believe me.
Okay, everyone.
See now?
It is not child's play.
See now the opposite side, very clear? Now first of all, to prevent the opposite blood supply coming, I will draw a straight line at the site of attachment to take away or disrupt the blood supply coming from the opposite side. There is no question now. Could you see? I have disrupted, completely disrupted. And see, this is the adenoid surface, this one where my cobbleter is.
Yes.
This tumor never takes an attachment onto the adenoid surface, never. See, this tumor is free below. See this. See, this tumor is free below. See, it is taking attachment only here in the roof. Can you see?
Right, Satish, it's clear.
See, the lower part is absolutely no attachment. That's why I came now posteriorly and opposite side to take 360-degree control. Now see, I have a complete 360-degree control over the tumor. This adenoid surface should be spared. It has no attachment of the tumor. See this?
Yes, sir. The sphenoid sinus and the adenoid do not have.
Yeah. See this? Opposite side is absolutely crystal clear.
This is remnant periosteum.
Yeah. So now it will help me removing this tumor.
Another reason, Satish, I think septectomy is important is because the septum will usually be pushed to the other side because of the space.
Yes.
And there is no space on the other side for you.
If you don't do this septotomy, believe me, your life is very difficult once you remove this part of the tumor. It can make your life very, very difficult, you know. You mobilize the tumor from the other areas and here you stuck behind. It prevents you from pushing the tumor down the oropharynx. And that is something you have to do before. That's why.
And then this is one area where many of us would struggle with an elevator.
Yes. Now there is no question. It is free. See now the posterior part is completely free. Absolutely free with no bleeding. I remove this remnant of the septum to give me common entry into the nasopharynx. Behind.
He's doing surface coagulation again.
See now completely elevated, lifted to ensure that my tumor is not attached anywhere, inferiorly, laterally, superiorly, posteriorly. Can you see everywhere? Now, as I told, this is huge, like a ball. So what I will do now, if I try to remove my lateral component at the along with this primary component in the nasopharynx, this lateral component would be difficult to accommodate. See this lateral component if I bring, unless I remove this medial one, how will this be accommodated? Can you understand? So what I will do, I will divide. Remove the medial component first, Anupam, and then remove the lateral component. Now my 90% of the job is done for everyone. Now my last part is tumor removal, which I have come to. Okay? So first the division, see this at this level. That is the bottleneck. That is the medial wall of the maxilla. Can you see very clear?
Right.
That is the medial component medial to it and the lateral component lateral to it. Okay?
Right.
I will just coagulate the surface and remove it.
You are using coagulation mode right now or coagulation mode, sir?
In between both. Cool. First coagulate, then cut. First coagulate, then cut. इसको इधर रख.
Wherever there is bleed, start coagulation, otherwise continue.
Yes. I expect a little bit of the vessels still because this is the pterygoid region here. See this very clear now?
Yes.
I showed you earlier in last two cases also this division. See with the coagulator.
Satish cutting his birthday cake.
Yeah. This is literally cutting like butter, you know. See, this is my medial component which I want to segregate at this point of time. See this? Intentionally I am leaving my lateral component. Yes, off karna. See now, no bleeding?
No.
Imagine, had we not taken the vessels into control, how would it allow? Next to impossible, believe me. With that much of vascularity coming, now I have to just pull this tumor down. Pani mat dal.
Tumor into pterygoid
For sure.
marrow.
Yes, remove. See, this is the sphenoid part, a little bit here. This is the sphenoid component. I will pull it down. See this?
And the bone behind it will tend to...
See this? Completely pushed down, 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 and it is free. Can you see? My lateral and medial component got free, except this little bit of the periosteum. It is free now. Very clear to everyone?
Very clear.
See, no time. I told you my 10% job is tumor removal. 10% time is tumor removal. 10% time is tumor removal. I am just coagulating these surfaces to improve your visual. See, this is the tumor in the pterygoid process. See this?
Pterygoid marrow is invaded.
Yes, this is pterygoid and this is the region of the Vedian canal I will show you. Now, first I will remove the medial part. See, now it is completely free.
Right.
Now the lateral part removal will take 5% of the time. Just we'll leave this gauge piece over here. Yes, press. Just to avoid unnecessarily oozing from the surface here. Now, mouth opener. Mouth opener. Can you see this lateral part and the medial part segregated?
Right.
Gauge piece.
Yes.
And no bleeding. I will leave this, so push this with the gauge piece so it doesn't jump back when I remove from below. Just to keep it pushed for a minute. This is now the lateral part which is dying to come out. ये मेरे को दे. Now see the cricket ball. See this?
Yes.
Oh, beautiful.
It's difficult to
Hold it. And many times you end up damaging the
you
uvula.
kar. Retract kar. You retract.
Make
हाँ,
the
देखिए
uvula
कर.
is
इधर.
out. See how
This-
they have taken the soft palate up?
Yes. See this component?
Beautifully done. Beautifully done.
Huge one. Now the medial part. What are this? The medial part is removed. So now the lateral part. Okay? Wash. Wash, wash. Give me a good wash. And no time. We'll remove it now. Straight away without wasting any time. And finally we'll drill the pterygoid bone wherever it is involved. See this component?
Yes, yes.
The principle is pull. I told you without wasting any time. Orle, आगे से पकड़. That is the nerve above and the tumor is here below. And see this. Let me separate the muscles from the tumor. Catch, catch, catch first. Now there is no point in wasting time. Can you see the tumor?
Yeah.
Yes, very good.
See, I am using this coagulator as something to separate. नीचे से
And the
पकड़ो.
surface has to be smooth. If it is unsmooth, that means you have left part of the tumor or you have
Yes,
cut.
yes. So this is advancing part of the tumor, which is always smooth. See this. See this lateral part dying to come out. However big it is, sometime if it is too big, again you have to divide this lateral part also in components. See this?
Right.
पकड़ नीचे से पकड़ नीचे से पकड़ 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 रुक 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 See this traction and counter traction. Give me a रुक रुक रुक.
And you might have small vessels here also. And again,
Yeah. I'm waiting. Okay, चल क्यों नहीं रही?
Maybe.
Yeah, some small vessels here. Small
must be from the ascending
small vessels. I'm dividing. The fibrous septation holding. I'm dividing. See this? See this? All fibers. Muscle fibers sometimes. See, I'm just dividing them. And this is traction and counter traction. It's entirely a matter of traction and counter traction now. Taken away.
so had he not removed the central part, this traction would not be possible.
Yes. How? Where would I push this part? And I remove. Yeah. This is the part of the vessel again. See this? No. Hold this. Chalo, ek baar pakad. Clip. See, that is the main vessel. You can see again.
Right.
We had not clipped earlier. I told you. So, as a safety measure,
So he is using a 3 millimeter clip to clip the vessel.
छोड़ के वापस पकड़ना. Yeah. See, taken care of. Hello?
Yes, sir.
Right.
This is pterygoid venous bleeding because there is some tumor in the pterygoid bone. फेंक देना यार. सोचता क्या है?
From that stump of the artery.
Yeah, let me show you. Let me show you a minute. Let me pack this area. I have taken the vessel in control. I have shown you with a clip. The final part with the clip. I will show you that clip again where I put. See now the lateral part is completely out.
Right.
See this. Absolutely clear. And this is our nerve going up. See that? We have been able to separate from the nerve. Very clear. See that? And now we know some tumor is there within the pterygoid process. See, this is the component, lateral component. Can you see?
Right.
Wash. Give me. Straight laga. Now I will give it a full wash and show you something. So how much time did my tumor removal take out of the entire time? Less than 10%. Agreed?
Agreed. 5%.
90% of the time, more than that, is in exposure. See, we removed the tumor. There was hardly any bleeding. We didn't embolize, we didn't transfuse. Now the last part and the most important part is the pterygoid that you have to take a wash. Separately, give a huge wash. I want to remove all this blood staining. एक ढंग से लगा के दे यार. All this blood staining, I don't want to see any bleeding now.
And it is also important because red color absorbs light, it will darken your camera.
Yeah. Now first give me the cobblator. See now, no bleeding.
Yes, sir.
I kept this case purposely to show as a different extension the problem posed by the maxillary component. You know,
Yes.
it can, for a beginner, it can pose a big problem. So now you can know, taking into consideration how you can manage it. Now this is the periosteum which I cut. See that?
Yes, sir.
See the adenoid surface, absolutely innocent.
Yes.
Nothing to do with this tumor attachment. This is all periosteum above. Adenoid surface has nothing to do.
Will you drill the pterygoid now, sir?
Yes, yes, yes.
Yes.
So I am taking, just ascertaining what areas I need to drill away. Any possibility of tumor anywhere. This is my, see below is the Eustachian tube, absolutely undisturbed. You are not supposed to disturb both Eustachian tube, you can see now.
Yes, very well.
Sometimes this anterior wall of the sphenoid bone, this basic sphenoid bone is, affected. On a slightest doubt, in this case it is not. On slightest doubt you can remove this bone. You can drill away completely. It is the drill. It is the Haversian system of this bone which becomes the site of a residual tumor. See now, just to show you, just to flush this bone completely without thinking twice.
Median area, sir? You are drilling?
Pardon?
Median area we are drilling, sir?
The median area I will show you. I am removing all this septation to show you a clear picture. There is no tumor. Still I have a tumor in the pterygoid process. I told you. I showed you in the beginning, if you remember.
Yes.
Later.
It is very important to read your CT scan well. So you
Yes.
know where the tumor is hidden.
Very important.
I will show you. I have a tumor in the pterygoid fossa. बंद है यार ये. Section. Get me good section. Yes. See, this is pterygoid fossa. देखा. Can you see this?
Yes, yes.
This area I need to completely.
So sometimes the pterygoid marrow itself goes into the greater wing of sphenoid and
Yes. And see, to know the best information about this marrow involvement, the MRI is the answer.
Also, Satish, when drilling, can you tell everyone what areas you have to be careful in so that
Pardon?
once you are drilling here, just explain how careful you have to be so that you don't go intracranial or.
Yes, from here, if you know this pterygoid region good, I mentioned in my cadaver dissection about 1.5 inch, 1 inch, square inch area. बंद है यार ये. See, this is 1 square inch area where I am coming to.
Yes, sir.
And the last time the tumor was going into this critical area,
Yes.
again this starts with the pterygoid. This is my nerve which is going in the foramen rotundum. You can see. पकड़ना इसको. पकड़ना. For sure. See this. This is the nerve. Let me clean it, separate it. See, this is my clip on the vessel. Separated. You have to completely clean this region. Completely means completely. पकड़ आगे से. Remove all this tissue and see how the nerve is going to the foramen rotundum behind. Can you see the foramen?
Yeah, very clear.
See, that is the foramen rotundum, and above this bone is the maxillary strut. Can you see?
Yeah.
Yes, sir.
And above that region is the area of the superior orbital fissure. Okay?
Yes, yes.
हटा दे इसको जो कर. See, now the nerve is clear, preserved. I told you in the beginning, this nerve must be preserved.
Yes.
Now this invasion of this bone, which I always keep it for the last, as you can focus better by clearing all around. See now, if you leave this tumor here, it is bound to come back. Moti wali there. I will take a different burr, not this one now. The same from the stylus, but more bigger one, stouter one, and a pure diamond now. Chalo, dal, section. See now? खोलिए उसने क्या पूछ फाइंडिंग
This area bleeds a lot, sir. But, you showed us last
yeah
time.
but this using this diamond will take care. Diamond gives you best opportunity. See, this is the pterygoid fossa below. I have opened up.
Yes, yes, yes.
Permanent can be seen now.
See that? Now,
sir.
this is the entire pterygoid process. See now, completely drilled off. Above with a normal bone. Can you see?
Yes, yes,
And see, that is the Vedian canal.
yes, sir.
Give me the cobbletter.
This is the invaded part of the.
Yeah, that is the vessel in it, the Vedian artery. Can you see the small Vedian artery?
Yes, troublesome bleeding. Always.
See this. See this.
Yes, yes, very well.
This is the Vedian canal, which now looks good now. The nerve looks good without any tumor into it. And I am coagulating this. See this area now. Give me the drill again.
Now,
You have to completely, if you have a slightest of the doubt, eliminate the pterygoid completely rather waiting for a recurrence. See now, completely means completely. My carotid is behind. This median is leading to the carotid at the foramen lacerum.
Yes.
This is one of the best landmarks.
You can just follow it.
See this area completely clear? इधर दबा इसको उसको
Yes,
इसको
yes.
इसको यूं Yes. Now this is my tumor here. See in the pterygoid fossa, can you see the tumor?
narrow.
Yes, yes.
Absolutely within the bone. And I told you on CT scan that we have a tumor in the fossa. Can you see?
Right.
Yes.
Very clearly seen.
See how one can easily miss this.
As soon as he pulls it, there will be some bleeding.
See this tumor.
Oh,
From the
but in fact, that's why drilling is must.
See this tumor is separate from the muscles now. Can you see?
yes.
That's it. See the muscles below. And now it is out. Had I left this, would have been a disaster. See how important is to read the CT scan. Now there is nothing in the pterygoid fossa muscles.
Yes, yes.
There are two muscles in it, the medial pterygoid and the tensor pallati.
Yes.
Microscope ले जाओ. So our next big case would be the CA parotid mucoepidermoid carcinoma, and before that our next case is opened up. My colleague has opened, that is a stepidotomy. He has already raised the flap, so will not take time, will not take long, and before the CA parotid will finish off this stapes. Now see, can you see the pterygoid fossa now much better?
Yeah, very good, very good.
With muscles below, no tumor at all. Had we not noticed this on CT scan, one would easily leave the tumor behind. See
There
that?
is a small component up above. What is that?
Yeah, that I am drilling, the bone. That is nothing, not the tumor. That is a part of the Vedian canal. Now see here, this is my V2 going in.
Yeah,
That is the foramen rotundum. Above that bone, rukna. Above that bone is the maxillary strut, and above that is the superior orbital fissure. This one, which goes behind to the cavernous sinus where the carotid is. That is the carotid prominence.
Yes, yes, sir.
Satish, point out for lateral CSF leaks. Is this the area that you also drilled?
Yeah. Lateral CSF, from the lateral recess forms at the expense of pneumatization of the pterygoid. So the area I am drilling, in the lateral recess leak, this area is pneumatized. That's why you have to see the Vedian canal.
Yes, very well, sir.
Clear? So this pterygoid fossa component one could easily leave behind had not noticed the CT scan. That is most important. See the pterygoid canal. How important it is to drill away this canal until you find normal. If I have a slightest of the doubt, I will keep drilling until I get the normal. Okay?
Can you show the relationship of median with medial pterygoid, sir?
Median with the?
Medial pterygoid.
Median pterygoid is the muscle below. You know, in the pterygoid fossa, I told you there are two muscles here. The medial one is the tensor palleti and the lateral one, this big one is the medial pterygoid. And median canal runs above. This is V2, completely preserved. This is your infratemporal fossa cobblator. Now see, I told you in the beginning, this is infratemporal fossa.
Yes.
This is lateral pterygoid plate. Idhar la force.
Right. Clear, very clear.
This is pterygoid plexus.
Right.
See, these all horizontal fibers are lateral pterygoid. Lateral pterygoid has two components. इधर क्यों रखने को? ये retract करके रख ले बस.
So also show us the optic strut.
Optic strut is above the level of the superior orbital fissure.
Yes.
Below the superior orbital fissure is the maxillary strut, separating from the maxillary nerve.
Maxillary, no. Yes, sir.
Optic strut is separating from the optic nerve.
Yes.
I'll give you the landmark again. See, this is just simple pterygoid venous plexus from the deeper part in the lateral pterygoid muscle. We'll just leave a small piece of surgicel over here. There. See now the infratemporal fossa completely opened up.
Yes, yes.
Beautiful.
छोटा था यार इतना बड़ा.
All in one single vision, everything is.
Everything is visible. So see Denker's, with Denker's approach, you can remove any given extension. Let me enumerate. Last time we went above the maxillary strut, if you remember.
Yes.
This above this region to go to the superior orbital fissure and then to the cavernous behind.
Yes,
Last time. This time
sir.
it was not required. Chota gauge piece.
Yes, sir.
Now, if you have a tumor extension, let me show you in our upcoming webinars when we have a huge parapharyngeal extension. See, this is the infratemporal fossa. So, where is the parapharyngeal space now? Suppose this tumor had an additional parapharyngeal extension, what would I do additionally? I would remove this pterygoid completely from here.
Yes.
And just behind this would have been the parapharyngeal extension going towards the carotid. Just behind this, see this right angle. Here. See this. My pterygoid process, this process is ending here. See where my instrument is going, dipping in. Just anterior to the eustachian tube. Where the cartilaginous eustachian tube behind is going posterolaterally. That is the parapharyngeal space. If I remove this little bit of the pterygoid left, 1 centimeter, if I drill away, I will be right in the parapharyngeal space. So if you have a tumor extension to the parapharyngeal, don't worry. It requires additional 5 minutes to drill away this remaining pterygoid. Nothing. If you know the Denkers, you can remove each and every extension of the angiofibroma easily. It is unnecessarily terrifying that we have a tumor extending to the cavernous sinus, we have a tumor extending here and there. All it needs is a Denker. This week, it was so gratifying to know, almost 8 people called me that they did their JNA for the first time.
Yes, sir.
And it is so gratifying. Really you can do it. There's no hassles at all. You have to simplify the work rather than terrifying.
And I think one of them has used the word Satization. This some new term has come up.
He published a paper.
Yeah. He's published a
Satishization.
paper.
Huh?
That amazing guy. And he gave me a birthday
Where
gift.
is he from?
He's from Andhra Pradesh.
Andhra Pradesh.
Yeah, he's
So
Maharaja,
that's
he is
the.
very punctual. He is always.
yeah, very regular with the webinars.
So now we'll
Come
watch
out
for.
with this term. Yeah.
Yeah.
Satishization.
That paper is accepted. See now, finally, no bleeding. We'll just pack, wash for 5-10 minutes
Yes, sir.
and pack it. That's it. We remove the pack for after a day or two and train patients. See this, all 5-10 minutes you keep washing. Everything will come under visualization. See this? See this panoramic view. With this
Brilliant.
V2 here, as long as you stay below the V2, you are safe from the skull base laterally, paramedial skull base. If I go above the V2, suppose here, if I go and drill this bone just above, I will be in the temporal lobe. This 1 to 2 millimeter thick bone is separating from the temporal lobe.
Yes.
You had shown it in the dissection. Yeah.
Yes, this one, see this bone.
Yeah.
Yes.
But it should be above the V2. So as long as you stay below the V2, you are away from the paramedian skull base. See this bone? Here is the temporal lobe of the brain. And this is how this tumor ascends to the temporal lobe. We'll show you in coming webinars the temporal lobe, intracranial extensions and the foramina through which it extends inside. So two common areas. See, this is your supraorbital fissure.
Right.
The inferior most part is the V1, ophthalmic nerve.
Yes.
Out of the supraorbital fissure, the first part is V2. Between this V1 and V2, if this bone, the tumor goes in between these two, this is anteromedial extension into the temporal lobe. This is very common extension. Mostly tumor extends from here into the temporal lobe. And similarly, what you have to do, suppose in this patient, had I been having additional temporal lobe extension, I would not do anything much. I would drill away this little bit of the bone around to widen the, excess, and simply just traction and counter traction, and I would have pulled the tumor out, because the enlarging surface of the tumor is always smooth. You have seen in the infratemporal fossa how smooth was the surface. Similarly, there intracranially it is smooth and you can literally pull it out. But without struggling, if you want to do, you have to, widen the excess. So this is simple temporal lobe. Sometimes in the temporal lobe it extends behind in the middle cranial fossa between V2 and the V3 here behind. This is the lateral pterygoid plate where it ends up and behind is the site for V3. And between V2 and V3 is the anterolateral axis where my, this periosteum is going up. This is the anterolateral triangle where the tumor ascends into the middle cranial fossa. This is another site. So these are two areas for the temporal lobe. So almost all extensions we have discussed, and you can really remove each and every extension of this tumor simply by means of dankers. So if you know dankers, you can remove any tumor with little bit of the extension as the tumor dictates.
Yes.
Any question, Ramandeep? Any comment, madam? Anything you want me to show?
I would just like you to show me once again how you go to the parapharyngeal space from there.
Okay. Again, yes, it's important. Parapharyngeal space is besides the pharynx. This is pharynx, nasopharynx.
Right.
Parallel and lateral to the nasopharynx is the parapharyngeal space, the upper parapharyngeal.
Right.
So what is there in between? This pterygoid process. Completely drill away. It won't take more than 1 minute. See, this is the end of the pterygoid behind. See, this is the end.
And you never damage the eustachian tube over
No,
there?
eustachian tube is behind that. See, eustachian tube is behind that. If I remove this bone, I can follow the entire eustachian tube cartilage up to the bony eustachian tube down there.
Okay.
Like this. The eustachian tube is inclined like this.
Okay.
So the moment I remove the pterygoid process, I will be right into the parapharyngeal space. Okay. And tumor which are going from anterior to posterior, that is an advantage. They push the medial pterygoid muscle behind. As the tumor progresses, it keeps on pushing the medial pterygoid behind. So there is always a plane between the tumor and the carotid artery, and that is the muscle. So you are always completely protected when the tumor is growing from anterior to posterior in the parapharyngeal space. Got my point?
Okay, fine.
And that makes your life so simple. So parapharyngeal, believe me, is the simplest of the extension of this tumor one can remove, and I am going to surely keep this parapharyngeal extension, intracranial extension in the coming webinars. We have today one more JNA for the junior colleagues. That is the minimal, spread of the tumor. the huge medial component, but hardly any lateral. And I will keep this case in the end to finish off all cases. So we have number of...
Satish. Really a visual treat.
Thank you. And Paramita, any questions? We can move on quickly. Here we will take the CA parotid, and before that I will just join the stay piece which is already opened up. I'll take 5-10 minutes. Just the video game with the laser and the piston. That's it. Nothing else.
Satish, we have joined with our two super talented surgeons, Maruti Kalyankar and Dr. Gaurav.
Maruti and?
Both have joined. Maruti and Gaurav both have joined now.
Oh, Gaurav Chaturvedi.
Gaurav Chaturvedi, the talented surgeon from
Yeah, Gaurav is amazing.
Maruti is from Dr. Kalyankar, very, very talented surgeon from Nanded.
Yes, yes. Maruti.
Welcome both of you.
You see
They
the
have been
Maruti.
following Satish also for ever, I think. Yeah.
You know, if Sunil है ना उसका नाम नाम पूछ So Maruti, I know him for long, amazingly talented guy, and you know his pictures, his surgical pictures are something I could never take.
Amazing. I have seen his pictures many times.
Just amazing how he records, absolutely bloodless work. His otology, endoscopic, simply amazing. And I had an opportunity to visit his place, Nanded, once. His center in our workshop conference, probably it was MentCon, was amazing.
2014 we went, Satish.
14, yes, yes. Sir. When we were doing that pituitary, if you remember.
Ah, yes.
So now, the next case is ready, and is Gaurav there?
Gaurav is also there, he joined, yeah.
Oh, Gaurav is a young champion.
Smartest guy.
Yeah, smartest,
The
young
handsome ENT,
champion, full of
Besides,
energy.
Chandigarh wala Ramandeep, other handsome guy is Gaurav.
And you know, Gaurav is heading, he's the director of ENT at the prestigious Jaslok Hospital in Mumbai. And he has a keen interest in endoscopic. I've done a couple of cases at Jaslok with him. And his interest is something, you know, is deep interest in endoscopy is something so enlightening. Amazing, Gaurav, welcome.
Thank you, sir. Thank you for your kind words. And sir, whatever I'm doing, it is all because of you.
No, your own work. Gaurav is an AIMS product. He is an AIMS Delhi product. He is highly academically oriented, and before the Jaslok, he was in the faculty in the Jaipur in the Mahatma Gandhi Medical College. So we had a lot of interaction that time here in Jaipur with him, and he had a lot of publications, a lot of interest, in academics.
I can see the stapes here.
Yes, can you
Right
see?
side, yeah. Yes,
So
very
quickly,
nicely,
the case is already opened up. He has curated the posterior overhang. We don't want to show again and again the same
But
thing
the
we have.
footplate,
We
you want
have
to comment on the footplate?
Yes. So here we don't have this cone beam. Otherwise, I would measure you the exact thickness of the footplate in a fraction of millimeter. This is, you know, multi-slice scan. But yes, I can see the entire ossicular chain. This is stapes incus malleus. Can you see?
Yeah, yeah.
All together, what I want to see here, any inner ear abnormality which may lead to problems, intra-aortic canal, the cochlear aperture, vestibule, the vestibular aqueduct here, the cochlear aqueduct here, down.
Satish, can you just slowly show for everyone, you know, the important points you have to see for a HRCT temporal bone for all of us?
Yes, yes. I didn't show here for the reason we have discussed several times in our stapes webinar. But since you have asked, quickly I'll touch upon from above downwards. Above, number one, the superior canal. I need to see whether it is dehiscent or not. So what I will do, I will go to the coronal. See, this is the best scan to see the superior canal dehiscence. You can't assess on the axial. And how you can assess? See, this is your vestibule. Can you see here?
Yes.
This is your superior canal, and follow the superior canal. See this. There's a thick bone over it. Why it is important, since Ramandeep has asked, because we have to rule out a third window lesion, which may mimic this kind of otosclerosis, early otosclerosis. This is intra-aortic canal dimension, the cochlear aperture dimension, the vestibule size, then the vestibular aqueduct, Then as you go down, this is cochlear aqueduct here. All should be normal. This is a little bit high jugular bulb. This is little bit high jugular bulb because this is the level of the round window, and just below the round window the jugular bulb appearing, but it is not going to bother us. Then the ossicular chain, then any anterior or posterior, you know, bony attachment. See, this is the superior malleolar ligament. Looks little ossified. Can you see anterior malleolar ligament?
It is little prominent here.
Anterior malleolar ligament. In stapes, it is not uncommon to find hyalinization and calcification of anterior malleolar ligament. And if it is, you can pick up on a CT scan. See this. I will go and check the malleus mobility. On a slightest doubt, I will extend my incision anterior superiorly and go to the anterior malleolar ligament and cut it away. That's it. Similarly, on the coronal, you need to see the superior malleolar ligament if it is ossified. Suppose if the superior is ossified in the, see this here. See now, the level of the malleus superiorly in the atic. We have seen in our series some cases having conductive hearing loss, everything normal, and this malleus was fixed in the atic, in the roof. You can rule out. You can rule out on CT scan. Then the facial now, again, for the facial now, whether it is prolapsing down, upside down, anything you want to see, you have to go to the coronal. And now see here again, if I go to the coronal, see my ossicular chain, the malleus incus, can you see? Going to the oval window. See this stapes suprastructure going to the oval window here. And see just above is the horizontal facial. Had this been coming down, it would have been overlying the oval window. So all these things, quickly you need to rule out. You have to see the dimension of the facial canal to rule out any persistent stapedial artery or anything. This is foramen spinosum, which is present there to rule out persistent stapedial artery. This is the carotid artery and the cochlea. There is no dehiscence. That is another third window phenomena if it is. So you have to see all this. Our case is already opened up, so I will straight away go to the case. And the next case is ready, that parotid. See a parotid.
Are you planning to do the things that I suggested to you? Stapedius and posterior thrust?
Message down. Anybody, any questions you can direct to Ramandeep, his favorite topic, stapes. And we have Ashish also. Gaurav also has a deep interest in stapes.
Yes, yeah. Raman, you can speak a little about your embryological strength about the stapes.
I think that will be a little too much, but let's start with the basics here. Why NCT temporal bone is important? Because you will come across various things in literature that no, it is not mandatory. Then there are articles which say it is mandatory. In many countries, it is done purely because of medical But for beginners, it is very important because the things of the things Satish showed, that third window phenomena can be there. You don't want as a beginner to have a CSF or a perilymph gusher because to manage that itself is an art, number one, and number two, you need to have some experience in stapedotomies to effectively manage a gusher and not get alarmed by something happening in your career. The number 3 point why a CT is important is because you can rule out, actually you can prognosticate how well the patient will hear post-operative. If you see a round window osteoporosis, you know your results are not going to be perfect, you are not going to have a perfect AKA. So you can actually tell the patient that this is what you expect. Then of course in far advanced sclerosis, there's actually an algorithm which is supposed to decide when to do a stapedotomy and when to do a cochlear implant. I can come back to that in a minute. And the most important part is, like Satish said, a dehiscent or an overhanging facial or persistent stapedotomy. So these two scenarios for experts like Satish and others on the board, they are relatively easy to manage. And for the persistent stapedotomy artery, we have been always taught that if you damage it or if it The
Why?
patient is not going to wake up with all fours moving, paralysis on one side. But
Scale na.
if you start the literature, and in the repeated publication, it has been said that even if you bipolar or cauterize the persistent cerebral artery, there is no case report in literature
Scan la de yaar. Jitna go kar.
paralysis can occur or stroke can happen. So that being said,
Wash. Thoda wash.
cauterize the persistent cerebral artery in many cases which
Picture जा रही है?
conductive barrier loss because it is not getting the state to move. So it presented like a
Conductive loss,
conductive loss. But people have
So I think through this, I think webinar forum, I think it's, I think let's make it every case of otosclerosis CT should be done. I think let's just make that.
Ashish.
Yes, I think there are 4 destinations for the persistent stapedial artery, but regardless of that, you can cauterize it.
Ashish.
Yeah.
You have seen us all through all cases. I have been telling you for years.
Yes.
Always for a scan.
Yeah, absolutely. So I'm saying through the webinar, the influence that it has, I think let's through this preach that yes, every otosclerosis CT is important.
You know, it prevents you from surprises, number one.
Yeah, and there is no junior senior. I think we're all
Yeah.
till the end of the case.
State
All beginners.
And you know, out of all otological litigations you see worldwide, otology, maximum otosclerosis surgeries.
Acha.
Yeah, this is a fact.
This is not the thinnest of the foot plates, but not very thick either.
Yeah, but it's not bad.
Even.
Now, first of all, give me a gel form. But the oval window is not so, widely opened up area. It is looking like the area is looking congested, overcrowded, yes. So in stapes, one thing, the most important thing is prevention of complication, because the patient comes with a conductive hearing loss and there are n number of reasons to give sensorineural hearing loss. And this is something which is never acceptable, not only to the patient, the surgeon also. And many times when you get surprises, you have to cut a sorry figure. So CT definitely helps you. There is no harm in getting a CT scan done. And with the cone beam, the cost and radiation factor is overcome. Now, first of all, let's check the mobility. Oh, good. Can you see? Hello? Hello?
Mobility, you check it in the incudostapedial joint. Look at the plane that is happening.
See this?
Between the
Very good. Very good. I was expecting there could be some restricted mobility because of the malleolar ligament, but it looks good. Yes. Ashim has several times emphasized the value of the malleolar ligament. Now let me check the mobility at the foot plate level.
This is very important, especially in hypermobile. Sometimes you have a spontaneous resorption of the both pleura.
Absolutely fixed.
Incus, fixed. So he's gone as low as possible on the pleura and try to move it.
I remember Gaurav was doing stapes, we were together. We had 3 cases, and all 3 cases he came across the malleolar ligament fixation. I told you, are the most unfortunate guy today. Getting all 3.
This must have come from they must have at least gone once to Ashim. Because he gets these fixations more.
Yes.
Gaurav, I have not kept somebody sitting in Ashim's waiting room.
Now, see this. Let me check where the IS joint is. See that?
Yeah, it's not centralized.
Okay, let me realign. Now? दूसरा दे, white वाला, बड़ा दे. Okay, let me.
We should have a picture like Maruti Satish.
Oh, that cannot be.
Maruti, you can please give some hints.
Difficult, boss. I don't know how he shoots. I tried several.
Surprising, he has a striker camera and such a beautiful photography and video. Of course, it's a surgical skill also.
See this.
Yeah. See, there is a play within the incudus, the joint of the incudus.
Yes, you have to be right at the joint. See this? If you are not at the joint, you may damage or end up damaging the lenticular process. That is something not warranted. See that joint clearly now?
Yes.
I have opened up. So mobilize the incus antero-posteriorly and look for the joint.
That is for a short time, because there are 4 ossicles and the lenticular process is considered as a 4th ossicle.
Really?
In literature, yeah. Just for a very brief period in the history of this anatomy, they went through this. And then finally, after a few debates, they concluded, no, it is a part of the disease.
I hope the picture is better now.
Very nice, yeah.
Yes.
Now it's a bit better.
How often you get malarial success in your cases? Like, as per study as literature, as per experience.
You are asking to Satish?
Pardon? Pardon?
I don't see it.
Pardon, what is the question? What is the question?
Manual fixation in otosclerosis. I use a technique or a term which I call hypermobilizing the pancreas. It's a little bit extra than what Ashim does. I remove the anterior superior overhand with my Gaussian. But that's mostly I do in tympanosclerosis and other things.
See, now I am focusing right to the tendon. Can you see?
Yeah.
Yes, sir.
And now I will bring my laser beam, you can see. Hello?
Yes, we can
Yes, sir. Clearly see.
And see, besides Ashim, Ramandeep is another guy whom I could able to convince for the laser. And he is having the luminous laser.
In the last 7 years, only lasers capable. And
I have the KTP laser for many years now. And,
see now, simple.
This is larynx surgery I just identified today. Okay, so this is finished.
Yeah, see this? Gone?
Yeah.
Same, one more shot. Give me a gel foam. See, I have already weakened the posterior crus.
Yeah.
But I don't want to overshoot now. Don't want to.
Audibility is not good, Satish. Audibility.
Really? Is a problem? Is the issue? Can you check the mic or the battery? Okay. See, now I am just pushing an extra gel foam underneath. This may overshoot. See that?
correct. So many times what happens, fire at the cruda gets charged and burned, the laser penetrates into the foot.
Really?
Yes. Yeah. See this? Now the next step.
Like Robin Hood's arrows.
Now see his gel foam, what does happen to that? Otherwise that shot would have hit the foot.
Yes. See now? I have gone through the crust. Can you see completely?
Yes, the entire bits of the cruda is gone. Yeah.
So it has, see now I have mobilized it. Now anterior crust being fragile, assuming I can easily break this. Fracture this and remove it completely. Forceps?
You were supposed to show different techniques, if you remember.
Oh, you told me.
Next one. You
Next.
keep the anterior cruda intact.
Yes, sir. See, Ashish, with this laser, why to make your life so difficult? But yes, for the audience, yes, I will.
Yeah.
See, once you break the anterior crust, in the floor of the anterior crust is little bleeding, always. No, there is a plexus. There is a plexus at the base of the anterior crust.
That is the area, no? That fistula antifenestrum, whatever. That's where the,
Yeah, close to that
yeah.
section. कहाँ रहता है तू?
That's the birthplace of otosclerosis.
Yes.
There has been a lot of echoing actually. I'm getting a lot of messages.
What?
Ashish sir's voice is echoing and all the very stuck. Even my panelists, everyone's voice is echoing. Dinesh, can you have a look on this?
Please look into
Do you
Dinesh.
want us to shut up? Paramita, you politely
No,
telling us to do that?
no, not at all. It's messages that I'm getting constantly.
No, you can be blunt with me. and-
Gel form.
I already sent message to this. He's doing. He's correcting it.
क्या यार चलो दे see this small plexus at the base of the anterior crest. You have to be little patient. अरे यार ये फोकस क्यों हटा दिया इसका वीरेंद्र क्यों चेंज करता है
Satish, the other advantage of doing the anterior fluorotomy after the piston is in place is exactly precisely this bleeding. Then you have that fresh blood coming and sealing it going around the piston.
yes you can say that but see this bleeding is hardly an issue.
No, I know it's not an issue.
Yeah it's an added advantage. I got your point. You don't need to bring the blood from the vein. See now right angle. My fenestra would be in the center of the foot plate inferiorly. Not now. First, this is the posterior crust, stump of the posterior crust, which was coming in the way.
Many times it is very close to the facial, so you can't shoot the laser at the base.
Yes.
A little above, then just
If the facial is decent, again is a big issue. You have to be careful. 0.5. 0.5 ऊपर
0.5, 20 watts, depth of 2.
depth of 2 watts. I want a good exposure time. The 2 is the adequate one. We have observed. See now. Let me give. I have the piston measuring. Before that, let me.
Just pack that area so that we get a clear field for the audience.
I will mop that.
You're doing it locally.
Always under local. See the malleus there.
Yes.
What I want to see, I always measure. As I always told you, these two steps I have shown the tendon and the crus with the laser. The crus step is very, very important to prevent complications. And here let me keep at 4.25 and check. Let me check. This is my.
This morning I inquired about another CO2 laser. This is from a company called 3G, which is based in Chennai. So they have a micromanipulator CO2 beam for 39 lakhs. And with the additional fiber, it is 49 lakhs. So we are going to have a machine installed in Satish's place for a trial for a month. And if we like it, we will probably, hopefully promote it.
They had come to us also when we ordered.
Yeah. How much is the luminous one now? Raman, any idea?
$125,000.
बाबा रुपीज में बोलो डॉलर पर अच्छी बात नहीं
Over 1 crore.
Almost 80 lakhs.
अच्छा so this is good 40 lakhs में अगर
Boss, the quality, it's the quality which matters, boss.
And it is 30 watts, it is not 60 watts.
does it matter?
Yes, depending on what you are buying it for.
No, for
Yes, light jalana.
and for the vocal cord.
Light jalana.
And minimal work.
4.25. Hello?
Yeah.
Gel form. What I was working at, measuring the length of the piston, and to me, it turns out to be 4.25, section first. I will clean the oval window for you before making the fenestra. So my last part of the video game is fenestration and piston.
Yeah.
See the beauty of the laser. Again and again, what I want to emphasize is the safety concerns. Without mobilizing anything, without passing on mechanical energy to the inner ear during these maneuvers. अरे बंद है ये.
Raman, you should develop a laser guided measuring device. This nonsense.
Working on it with
खास होता रहता है.
and Ravi and Anulan from SGPGI. Project.
So it will give us a digital display of the lens?
Gel foam.
Of the lens, and it will use the same beam as the CO2 aiming beam to measure.
Oh, so
Gel
that
foam
is
दिया तुरंत. Look.
Because the CO2 is invisible, it has a aiming beam, right? So they will use the aiming beam only to measure.
Okay. But otherwise, some other separate handheld device can be made, just like a measuring rod. Which
we went with this because we already have a CO2 machine and it will already be on the patient.
Ashish,
yeah.
Our next case is ready. So last two steps, see the laser beam onto the foot plate inferiorly and in the center part. Yeah.
Now you have to say boom curve. Yeah.
Yeah. अरे बंद है सेक्शन यार.
सेक्शन बंद है. छोटा भी दो. He did not give enough attention to the anterior crust. It is bothering and seeking attention again and again.
Yeah.
I don't want to say.
Section. See now, this is my point 0.5 mm fenestra which I am going to make for a 0.4 mm piston. This you have to reassess again and again to make the fenestra at a proper step. I hope it is under vision.
Yes, nicely seen. Yeah. Except the okay now. No, so going on to the promontory.
No.
No, it's okay. Yeah, okay. Yeah, okay.
Pick. क्यों आता है चूरन तू? Pick.
What piston are you going to use?
Actually,
It's पतली. बता आज के बाद.
0.51.
Yeah, no, 0.5 हुआ ना?
Yeah.
It is pure 0.5. See the fenestra.
Yeah. Perfect.
See the issue. See the advantage of the laser is I don't want mobilization at all. See that fenestra. And now last part of this video game is piston.
That also no crimping because there is a clean.
Yeah,
मजा निकाल दिया स्टेपस का.
दूसरा लगा, मोटा लगा. Give me some instrument, right angle or anything.
Do you want to recheck the
दे दे यार,
mobility
instrument.
if you put the piston?
Pardon?
Do you want to recheck the mobility of the malleus and
Yeah. I will show you.
also another good time when the suprastructure is out. It's again
Yes, yeah. That's a good idea. See now,
seen on this
incus, malleus.
malleus. Yeah.
Just
Oh, very nice.
fantastic. I was not expecting this much. I thought I would show you anteromalleolar ligament resection.
Yeah. It's quite a thick malleus.
Yeah. And see the fenestra below, full of perilymph. Now, once it is full of perilymph, whatever blood trickling into the whole window is not going to go inside.
It will float on it, yeah.
Because pressure inside with the fluid is more than the pressure outside piston.
Yeah.
Just a question, what would happen if blood goes?
Parotid ready? Pardon?
Nothing. You just get a bloody vestibule, but nothing else. What if the blood goes in? That is the question.
What if the blood goes in? First of all, you are not supposed to suck it out.
Okay, so leave it there.
Yes, obviously. If you suck, you will rather worsen the situation.
So dry labyrinth हो जाएगा ना.
And secondly, it is bound to give some sort of problem,
But we don't know that. We presume it because we think that,
No, I don't think because when in a sunken foot plate, any relative finish is beautiful step. Yeah. So
See what I have done. See the last part of the video game. I kept the piston at the fenestra and this mouth which is opening onto the incus. See that?
Yeah, yeah, we can see.
This is the bar and this is roughly 0.5 millimeter above the lenticular process. See this?
Yeah, yeah, yeah.
And this is just gently pushing in. See this medial? See the middle slot of the piston is taking on the incus now.
Yeah.
And that is all. See this? Absolutely, there should be no play between the piston and the incus. And it is not at all.
Yeah. It's one rigid assembly now.
See now the piston at the lower end?
Yeah, yeah.
Blood.
It's perfect. There's hardly any gap also. So
Yes.
it's good. Yeah.
It's good. I already measured it was the 4.25 required. So in stapes surgery, what all required is, this patient, and believe me, these two things have changed the life in our stapes surgery, the laser and the titanium piston. The uncertainty has gone to certain extent, the fear has gone, the possibility of the footplate complications have almost nullified. See that?
Perfect. Beautiful.
And now lastly, a drop of blood.
There, Raman, that answers your question. What if the blood goes in? It's not going to go.
It cannot go. It cannot go.
No, I know.
So many things have just been stuck in teaching because
बंद है यार.
and never learned to question what was.
So blood can never go in for that matter. If the vestibule is full of perilymph, no worries. That's why the single thing which we always emphasize, not to suck on the fenestra. See this blood in the whole window?
When they were saying that blood should not go in, for a sunken foot plate, they were saying put the blood there, let it clot.
बंद कर देना. बंद कर देना.
Which is a very ridiculous term.
Yeah. Are you will close for me?
I think it was more of a hypothesis rather than.
Blood cannot clot that much for it to be holding.
ये टूट रही अगले हफ्ते. नहीं. ये क्या? हेलो. माइकल लेके आओ. Yes, Paramita.
So what is the role of hearing aid trial pre-operatively to give the idea to the patient what benefit will he have? Dr. Girish is asking.
See, rather than best you get the speech discrimination score. That is most important to predict the hearing outcome in a practical way. SDS should be good. It should be good to give good serviceable and good, hearable hearing, you can say. If the SDS is poor, you are not going to give good hearing to the patient anyway. So that is must. Like audiogram, we must get speech discrimination score done. इधर का माइक चलाओ ना. Pardon?
Sort of knows that much better is going to be his or her hearing.
Yes.
Yeah.
It's still a sense of confidence. It's not so much science, but the art of medicine that it comes.
Yes.
लाइट इधर लाओ ना माइक. जब मेरे साथ रहो ना, मैं क्या चाहता हूँ. चलो यार. चलो.
So first of all, you have to increase your incision more anterior.
Okay.
Then there are
बात हुई क्या?
ways of managing it.
दोनों आगे.
ABR and Ashim do, they just take a single knife or a short pointer and just run it.
उधर जाता हूँ. उधर जा रहा हूँ.
So, just like you cut the stepping case, sort of you cut that.
मेरा फोन देना. क्या अभी कर लेंगे उसको, रोक यार। क्या करता है यार? हेलो,
then how will you manage?
So I've had this case we were operating at AIMS Patna. I was mentoring Dr. Kranti. So it happened, and later on it showed a dilated.
I remember that case.
Yeah. So what we did was, number one, mannitol was started immediately. Number two, the opening was already made, but the flow was so much that the speculum was also filling up. And
Hello?
Was getting tough because of the parallax effect of the perilimb filling the middle ear. The middle ear kept on suctioning out the perilimb, and we put in a piston.
How long did it take for the thing? How many minutes did you have to drain it out?
It kept
10 minutes?
It was a CSF gusher.
Yeah.
And more than that actually, and it was just not subsiding. So once we put in the piston, we got a tight fitting piston. That area around it with fat, and put in the graft back, we were able to stem the leak.
Hello?
Yeah, Satish.
Yes, Ashish, can you hear me?
Yeah. Hear you, yeah.
So, ये computer. We are ready with the next case. As I told you, this patient is a middle-aged patient, male patient with a diagnosis on core needle biopsy pre-operatively having a parotid swelling of a low-grade mucoepidermoid carcinoma. And ये क्यों हटा देते हो उसको? And this is an important pathology, very common pathology. And for everyone, it's a pleasure for me to introduce few people who have joined us for this case. And let me introduce Dr. Shiva Kumar Thiagarajan from Tata Memorial Center, Mumbai. Boss, can you put the picture? क्यों हटाते हो बार बार यार? Why are you irritating? क्यों हटा रहे हो? What is the problem? Hello?
Yeah, Satish, we can hear you.
Yeah. So you can see on his screen, and it's a big pleasure to have him. Why the picture going here? What the hell you are doing?
You're not on mute.
Now, are you getting the picture now?
Yes. The scan picture very well.
Yes.
उसको कुछ समझ नहीं आता कभी भी.
दिख रहा है सतीश, go on, carry on.
It's going?
Yeah.
So it's a pleasure to have Dr. Shiv Kumar Thiagarajan from Tata Memorial Center, Mumbai. And what a fantastic surgeon he is, believe me. I've been to Tata, I keep going there. I am a product from Tata. And you watch him operating, believe me, it's a treat to watch. What a fantastic surgeon he is, what an accomplished academician he is. He has published number of papers in head and neck oncology. And for everyone, he is ENT surgeon. He is amongst us and he is doing head and neck oncology as a career in Tata Memorial. He is associate professor there. Last time you remember, we had Dr. Devendra Chokar. So Devendra and Shiva are working in the same unit. Devendra is heading the department. And it's a pleasure watching these people operate every time with new things to learn. Thank you, Dr. Shiva, for being with us.
Yeah, thank you for those kind words. Pleasure is mine to join.
Thank you.
And I was enjoying the staphylectomy also.
Oh, thank you. Thank you. And and the next person, and then we have our own Dr. Archana Parikh on the screen. She's our pathologist. I've been eating her head day and night, in Jaipur. And she's the one I always mention who provides us round the clock frozen section facilities. Round the clock. and she is amazing. You know, I've been working with him in association for last more than 15 years. She has worked in Mumbai, Tata with Dr. Borges and many stalwarts in Mahavir Cancer Hospital in Jaipur, and now has her own center, and has an extremely, accomplished pathologist. As far as the oncopathology is concerned, she has a special interest in oncopathology. And today also for this patient, and I will ask Dr. Shiva as well, we got the ultrasound guided core needle biopsy, and we got this information of, low-grade mucoepidermoid carcinoma. For everyone in parotid, it's unlike thyroid, the FNAC is not always so conclusive. Owing to the regions, I will ask Madam, I know because of the varied, cell types in the parotid as compared to the thyroid, it is difficult to distinguish the lesions. Parotid is one gland which can give diverse histologies. Only one gland can give more than 20 kinds of cancers originating from the parotid. It is amazing, and to classify into distinct pathologies is a difficult task, particularly pre-operatively on the basis of FNAC alone. So we have now made a habit of, getting USG guided core needle biopsy to get more information. It gives you a proper core of tissue. So many a times if you have a doubt of lymphatic malformation, lymphatic, tumors, you can get the material for immunohistochemistry as well. So first of all, Madam,
Yes.
how do you build?
Satish, thank you so much.
Thank you for coming.
In the introduction, I don't know whether I actually deserve it or not.
Oh, amazing. You deserve much more. You deserve much more. You are the backbone of my oncology practice.
Thank you so much.
And this case, we have three experts now. Madam Farida Wadia, Dr. Shiva, and Madam Archana is here. So, Madam, just one question.
Yeah.
How do you rate still FNAC? Or when do you advocate core needle? Or to all core needle, or to selected, and when?
See, in 80% of the cases, we can have a diagnosis on fine needle aspiration cytology. But if you want to have a higher accuracy, it's always a core needle biopsy which is better, because then you preserve the tissue for further studies. If you need molecular testing later on, if you need IHC later on, then it's of course a tissue core which is more important. And more importantly, in an FNAC, you are just going into a single track. So you may miss out the other cell types which are there in the tumor. So for that matter, we need true cut or core biopsies.
But this is not a similar trend you see everywhere. Let me ask Dr. Shiva. Shiva, what is the current trend at Tata?
So we would generally get an FNAC alone. So we would not do a core biopsy it's not a routine practice, maybe once in a way, but we would definitely always recommend doing an FNAC. And it will be always better if you can get an ultrasound guided FNAC for a better yield. But whatever you get it, I think the most important person here is your pathologist. So your pathologist should be able to tell with whatever yield you have, and the pathologists mostly do report it pretty well with an FNAC itself. But I think, Madam can correct me if I'm wrong or add to this. Mostly they will be able to tell you whether it is benign or malignant.
Yeah, that's a certainty we can say whether it is benign or...
Can I ask one thing, Dr. Shiva? How many times, how often your FNAC diagnosis is corrected by frozen and final histopathology, and how do you, handle this?
So the thing is that many of the times we do get some sort of a tissue diagnosis because patients are operated from outside and come to us. So we do have a fair bit of idea as to what the malignancy is. And if the patient comes, treatment naive to us, we usually go with an FNAC. Now, working in an oncology institute, our suspicion is always high. We always think in terms of a malignancy than not thinking in terms of it. So our approach is always like as though we are dealing with a malignant tumor and not a benign tumor as often that we would like to do. So we always go with an FNAC, and our pathologist definitely will be able to tell us whether it's a benign malignant. If it is malignant, it's a low grade or high grade.
Okay.
So it's difficult for a pathologist to tell with an FNAC if it is a mucoepidermoid or a salivary carcinoma or whatever it is, for which you need more tissue, for which a core biopsy might be useful.
So that is the only indication for core biopsy for you?
No, we definitely, I mean, we don't routinely do a core biopsy. If you could look at any guideline.
If your imaging dictates like lymphoma or something, then?
Yes, if an FNAC, I mean, a pathologist again are the key person. They'll tell you it is likely to be a lymphoma, right? In which case we can consider a core biopsy or maybe a superficial parathyroidectomy for better staging of the lymphoma.
Any time you advocate open biopsy in this era now?
No, never. We totally condemn open biopsy, and if at all, a core biopsy, that too in certain circumstances. But if you have a good pathologist with you, FNAC is good enough.
Okay, that's important. Madam, Farida madam, you do anything different?
No, Satish, whenever we have observe a parotid tumor and the repeated FNSA is that it is from a lymph node, then definitely that patient goes in for a core biopsy after having missed out a lymphoma like that about 3 years ago.
Achha, can I ask?
If there is anything of the lymph node in a parotid, it's always a core biopsy.
Any reservation against getting core biopsy done? Because it has been proven by several studies it is as safe as FNSC. It doesn't lead to any implantation in the tract or anything because you use a bigger needle. Then, but it definitely gives you a much better tissue than FNSC. The FNSC gives you just morphological idea. It gives you correct tissue histopathology as such. And it has definitely distinct advantages. What is the reservation in not getting core biopsies done so often?
So if I can just take that question, it's not the implantation theory is not first thing that comes to mind. The problem is damaging the branches of the facial nerve if at all. Now with your ultrasound, you never know how the nerve is placed in relation to the tumor. Sometimes it can be superficial, sometimes rarely, and many times it will be deeper. So the chances are that you could damage the.
But I think that is remote because most of the tumor are in the superficial lobe, and most of the time the nerve is deeper.
Agreed. But then it also depends on if it was not that common in incidence. I won't be able to quote literature on this as to what is the incidence of facial nerve damage after a core biopsy, but that's a theoretical risk that you run. But I don't see an added advantage of a core biopsy because again, the minimum surgery that we do is a superficial parathyroidectomy. So we don't practice a nodulectomy or anything of that sort. So we would rather do a superficial parathyroidectomy and send it for frozen rather than do a core biopsy. Because if pathologists tell us that it's a low grade or benign malignant, and if it's a low grade or high grade, we will counsel the patient accordingly. And then we would run it for frozen, and in frozen, a pathologist will be able to tell you more certainly as to what it is.
See, this is the biggest advantage in Tata with the backup of frozen facility for every case, and that too with the experts. Tata is the place, I call it like Mecca for oncology, and the frozen backup is amazing. The pathology department probably the strongest one in Tata. So I displayed a slide with a low grade and high grade malignancy, by and large distinction. Yes.
One second, boss. Does your decision regarding the FNAC and core biopsy also depends upon the consistency of the tumor? It's a solid or a...
Not really. Actually, when we do core biopsy, first FNAC, number one, many times imaging findings in hand before FNAC or core biopsy. And according to the imaging, we take a decision of core biopsy. Sometimes you have a solid cystic lesions, and then we need always direct with the ultrasound guided to take the biopsy from the solid area, and then sometimes you suspect a malignancy, like we always take a core biopsy. Our protocol is like this, but Tata is a good backup. Now that's why I'm asking Dr. Shiva again. This is a list of low and high grade tumors, and in parotid you have to take decision accordingly with the pre-op finding of a lower high grade tumor what you are operating. Your extent of surgery, your extent of post-operative treatment, everything, your extent of neck dissection, everything depends upon the distinction between low and high grade. How do you cope up? Because this pre-op diagnosis of FNAC may not always exist correct regarding the low and high grade. How do you take the advantage of frozen or what?
So that's right. So as I already mentioned, FNAC is just to have those differentiations that I already mentioned. And then our main decision making regarding the other thing that I also mentioned
Connect.
minimum surgery that we do is a superficial paratectomy, nothing less than that. So if you have to do a total conservative paratectomy or anything beyond that is when the frozen comes into play. And your core biopsy may not change that decision because that's an intraoperative decision that you take. And also to some extent your imaging that you have. And so our decision making and also the next dissection, if you would tell us, again because of the lack of a frozen, we always do a level 2 sampling when we have a diagnosis of a malignancy.
Whether it is low grade or high grade, whatever.
Sorry?
Whether it is pre-op, low grade diagnosis or high grade, you'll always take level 2 sampling?
Yes, because anyway you'd have to be there to get your posterior digastric as your landmark. So we would always sample.
Yeah, if it is malignancy. If you have a pre-op diagnosis of malignancy in hand.
Yes, because we are doing only FNAC, right? Even if your FNAC may say low grade, but you can have surprises on table when you send the full specimen.
But you must be having imaging all the time in your hand.
Absolutely, we do. As of today, we do a minimum of the minimum workup that for a parotid is an FNAC and an MRI.
MRI. So can I ask at this place to Archana madam and you all, what do you expect from a frozen section from your pathologist? First Shiva and Farida madam.
So again, see, you already started the session by saying that
In parotid, yeah.
That's what I'm saying. In parotid, that it has a plethora of diagnoses.
Yes.
Plethora of diagnoses. You know, a benign can be malignant, a malignant can turn out to be benign. Unlike parotid, where you have only 4 types of differentiated thyroid cancers and a good reporting system, we lack one in the parotid, unlike the thyroid. So here you need a high HC backup to come to an actual diagnosis. The morphological structure of what you see under the microscope can guide you to some extent, but then with your IHC, the diagnosis totally changes. I think madam can correct me if I'm wrong there. So
No, what I mean to ask, what do you want from pathologist? Your margin, your grading.
Exactly. So that's what I'm coming to.
Now if it's got a lot of cystic component, you can think in terms of low-grade malignancy. If it's a core biopsy, the pathologist is always very happy because he has more tissue to diagnose. And with my pathologist, when I give him a core biopsy, very rarely he has sprung up the post-operative tissue diagnosis of it being a highly malignant tumor as compared to a low malignancy. So
Okay.
here I'm blessed with a pathologist who can tell me definitely whether it is high or low grade. And we take it forward MRI findings also.
Yes. Dr. Shiva, madam, I am coming to you. Dr. Shiva, you mentioned the minimum operation for a malignancy superficial parotidectomy. So when you send the superficial parotidectomy specimen for frozen, do you expect any information on the intraparotid lymph nodes on frozen?
No, I don't expect any. That's difficult to tell for the pathologist in limited sections that they would take on frozen to tell exactly whether the intraparotid lymph node is involved or not. So that's why we always send a level 2, sampling for the lymph node. So in the parotid specimen, what I expect my pathologist to tell me is whether it is a low grade or high grade. And if they can tell me if it is mucoepidermoid or sebaceous or salivary duct, I'm happy to have that diagnosis as well. But the moment they say it is high grade, then I tell myself that we need to do a minimum of a level 1 to 3 neck dissection.
And a total parotidectomy as well.
Yeah, that depends on your finding. If you have a good cup of tissue around the tumor,
You'll be happy with that.
From the nerve, then we are okay with that. So
Even if it is high grade.
Yeah, even if it is high grade, if the tumor, it depends on the tumor size as well. High grade alone may not dictate the extent of parotidectomy. It also depends on the size of the tumor.
You know why I asked this? I've gone through a lot of papers recently showing the intraparotid lymph nodes in the superficial lobe dictates the need of elective neck dissection even if the neck is N0, number 1. Number 2, since they are in connection with the deep parotid lymph nodes, if you have any single intraparotid lymph node positive in a superficial lobe, it dictates you to do a complete parotidectomy, total parotidectomy, and an elective neck as well. Now, can I ask Madam, Archana Madam, can you give us information about the intraparotid lymph node in that particular given period of time?
Yeah. If it is okay, I can just add to what Dr. Satish Jain has already said. The intraparotid node, the majority, there are about 15 to 20 nodes, and majority of the nodes are in the superficial lobe itself. You would hardly have 3 to 4 nodes
Yes.
in the deep lobe. So doing a deep lobe paratectomy for the nodal clearance is a myth, I would say. And also the involvement and the literature is divided, and whatever literature is there, it's probably a sporadic case report and things like that. So that is why, and the first tickle on from the intraparotid that it goes to the neck is to the level 2. So that is why the other strategy is, because the pathologist may not be able to sample within the
level 2 sampling.
Level 2 sampling is done because that's the first tickle on of the parotid, apart from the intraparotid nodes. Madam, you can take it.
Yeah.
So I would like to comment on 4 things over here. The first is FNAC. The second is a core biopsy. The third is the lymph node which you mentioned, and the fourth is intraoperative cytologies which we can do. So intraoperative cytology is a complementary technique to frozen section. So while we are doing the frozen section, what I do is I take scrapes and imprints from the cut section of the gland which you have sent to me, and that gives me additional material to study. That is why FNAC becomes the basic test. But if you are able to differentiate whether it is a benign or a malignant, it's fine. Benign, you don't need to go for any other test. If it is malignant, then of course you need to go in for a frozen section or a core biopsy, whatever as a surgeon you decide on the basis of imaging modalities. And then if you decide to go in for a frozen section rather than a core biopsy, then as I just now mentioned, we have an advantage of doing an intraoperative cytology with the frozen section, because we have a limitation of the number of frozens that we can take, because that would lead to a loss of the tissue. But when you do an intraoperative cytology, you are cutting multiple sections which you would in any case need for your permanent sections. And from those intraoperative scrapes or imprints, we can always give you a diagnosis whether the lymph node, because you can identify the lymph node and tissue and an imprint. The lymphoid tissue is surrounding the cells or whatever, that's the studies that we have done over a period of 10 years. So if you send it for a frozen section, of course we can diagnose, detect a lymph node in that. There are techniques, if we put it in the formalin with more of water and less of formalin, and that helps us identify the lymph node, because it's slightly pinkish in color, and the remaining gland, it is grayish white in color. So number 1 is we can detect the lymph node on that. Number 2, we can do an intraoperative cytology. Number 3, we can give you a diagnosis on frozen section. And number 4, when the permanent section comes, we can send it for further studies, which is IHC, then you need for a prognostic workup. And you can do the various antibodies, prognostic antibodies and progressive tumor markers.
Yeah, this is something I have always observed. Madam is sending most of the specimen for immunohistochemistry, particularly in the parotids, because of the diverse histological, tumors. So the immunohistochemistry has a big role in prognostication post-operatively. I remember, particularly in the mucoepidermoid, if you have a MUC1 positive, that is considered to be one of the most aggressive cancers, and then you have to take the adjuvant therapies in action accordingly. So the markers has a big role. Yes, Madam. Farida, Madam.
No, I'm saying Dr. Archana has really given us a lot of information. Some of it I was not even aware of.
I am so blessed.
About the imprint that she does from the frozen, very informative.
I am so happy to have a pathologist like her giving me complete information, not only pre-op or post-op specimen. The way she frames the detailed report is something amazing, and this is really useful in planning the post-operative adjuvant therapy. Now coming to the next part, imaging. Like Dr. Shiva had already mentioned, for the parotid malignancies, he would minimum have an MRI. And this is a very, very important, information coming from him. It is really important. MRI can give you lots of information, and that has a big role in surgical planning. It has a big role in improving your pre-op diagnosis as well, whether it is benign or malignant, because there are certain features on MRI on the basis of which you can reach to the level that this patient has a benign or malignant lesion. Let me take you quickly through some of the sequences we get done in MRI. first and the most important sequence we get done is a T2 weighted sequence. Let me put T2 weighted here first. This one. This is T2 weighted sequence. T2 weighted sequence, if I run this, you see this tumor here to be a hypodense lesion. More the cellularity is, less the density on T2 weighted, and that goes in favor of many a times in malignancy. Not a specific sign in all cases, but number one, information you can get like this. Number two, the location of the tumor. See, if I take both the coronal and the axial together, let me put it again. This is axial, and now I will take the coronal here. Now the help of these two sequences, I can reach to the level of involvement in the parotid. See this. This is the parotid lesion which is here on this T2 weighted with some cystic spaces in between. Can you see this? This has a strong relevance in your planning. And see, this is lying in the upper part of the gland, the lower part is relatively free. See, this lower part of the parotid is not involved. This lesion is mostly in the upper part. This gives you complete information about it. Number two, you can see the cup of normal parotid tissue around. See, this is mandible, this is retromandibular vein. Can you see? That dictates you whether this tumor is in the superficial lobe or a deep lobe. This tumor is truly in the superficial lobe, and in the superficial lobe as well, the facial nerve being in a close proximity to the retromandibular. In this particular tumor, we have no concern with the facial nerve involvement as far as the, the cup of normal tumor taking around the lesion is concerned. Because we have a good cup of tumor around which is completely normal, involving the completely normal parotid, and the facial nerve is no way close to the tumor. Had this tumor been coming close to the facial nerve, would have been a big concern. On imaging, there are a lot of publications saying, in spite of a normal functioning parotid, the facial nerve, if you have a tumor involving both superficial and the deep lobe, that too a malignancy, the chances of preservation of a functional facial nerve are very dim. So that's how you can prognosticate as well. Now the number two sequence I would put up here is the contrast. Let me put up here, this is the axial contrast and this is the coronal contrast. Now once it comes to malignancy, the contrast imaging is very, very important. This is axial and this one I will put the contrast. Because the malignant tumors are supposed to take up contrast avidly. Now see in this. This particular tumor being a mucoepidermoid carcinoma. See this tumor here? Right in the upper part with avid contrast enhancement and some cystic spaces. This is very, very important in prognostication, particularly in mucoepidermoid. Because mucoepidermoid can be low grade, intermediate and high grade, and this is decided on the basis of histology. Whether it is more of mucus secreting, more of epidermoid component, the cellularity. And this patient with the cystic spaces, it is more likely to be a low grade epidermoid carcinoma. Though it is a histological diagnosis, but you can corroborate well in the imaging as well. Had this been a completely cellular dense tumor, I would label it as a high grade on imaging and corroborate on histology. So this is corroborative, not hard and fast. You can have a fairly good idea. Number three, when I put up, when I put up the diffusion MRI along with, this gives me another information about the malignancy. Maybe this tumor is containing. Let's see, this is diffusion. And what I want to show at the same level of the tumor, see this, the lot of mucoid content in this tumor, lot of mucoid content, and there is no restriction, high diffusion. That means it cannot be a high grade cancer. See what diffusion weighted MRI is. Diffusion weighted MRI is a bioimaging. It truly gives you a complete information about the cellularity of the lesion. More the lesion cellular is, more will be restriction and more it will be darker. Less the cellularity, more water content, and there will be more diffusion. So you can have a fairly good idea, particularly in parotid malignancies, particularly in larger malignancies, if it is a high grade or a malignant tumor. So on imaging, you can have a fairly good idea whether it is involving superficial lobe or deep lobe or both lobe, whether it is diffusely involving the soft tissues around the muscles or the axon-artery canal, mandible, anything, you can have a good idea. On MRI itself, you don't need a CT scan even for the bony involvement these days, because MRI gives complete information. And third, on diffusion, you can have additional help. And fourth is the extent of lesion in planning your approach. And fifth is a lymph node. See this. This is the level 2 lymph node here. This is the parotid. I am going down. I am going down. And this is the level 2. Yeah, I am going down here. This is level 2. There are some lymph nodes, very small, not looking like any level 3, level 4, no lymph node. No lymph nodes at all. So I don't see any classically malignant lymph node which looks like malignant on imaging in this patient. To me, this is N0, not only clinically but radiologically as well. And this is a good information I need to have pre-op. Dr. Shiva, Tata has an amazing radiology backup. I know from the times when Suprita Arya was there. She's not in Tata now, but radiology is a huge department there. And anything else you get on radiology, any more information on it, dynamic or any studies you get done there?
No, as much as what is required you already alluded to. So the other thing that probably, the other imaging that we would get done other than the local imaging is, if the pathologist tell me on FNAC that it's a high grade tumor, then we would do a minimum of a CT thorax, or just to see if there's any distant metastasis. Especially if they say it's adenoid cystic, we will get a NCCT thorax just to see if there is any lung mass, because
so in advanced lesions,
adenoid, even a small adenoid cystic, I mean it depends.
Okay.
Adenoid cystic definitely has a tendency to have
Yes.
more lung mass.
Yeah, here.
Just a baseline. Even one information I want to pass in, even if they do have a metastasis in the lung, in an adenoid cystic, that's not a contraindication for surgery.
Yes.
It's at a baseline and the lung lesion can be observed.
Yeah. Adenoid cystic is generally a slow growing tumor. In spite of what the Dr. Shiva is saying, in spite of a distant metastasis, we need to treat primary to improve the survival. And that is indicated in those tumors.
But if it is anything else other than an adenoid cystic, even if it is a high grade mucoepidermoid or a salivary duct carcinoma, then if it's a distant metastasis, then we would, and if by chance you get a pre-op diagnosis of a salivary duct carcinoma, we would definitely do a PET scan to rule out a distant metastasis.
Okay, can I get a clarity on one thing, like you mentioned about distant metastasis?
Yes.
In parotid malignancies, for audience, when would you order a PET scan?
That's exactly the point. But if it is a high grade tumor, like for example, if you have a pre-op diagnosis, like for us, as I already said, patient come to us with some sort of surgery being done outside. So we have a tissue diagnosis. And we have a tissue diagnosis of a salivary duct carcinoma, a high grade tumor, a high grade mucoepidermoid carcinoma. That's when we would get a distant metastasis workup done. For an adenoid cystic, only a CT thorax is good enough, because adenoid cystic going beyond the lung is very, very rare. But if it is a high grade mucoepidermoid, or if it is a salivary duct carcinoma, anything of
Yes, those are, yes, that is very.
Pathology, that's when we do a PET scan. And rarely you do get patients who come with multiple neck nodes with a high grade tumor, and that is another indication when we do a distant metastasis work.
Oh, great. So another thing, like Dr. Shiva mentioned here, I would like to mention in imaging as well. If you have an adenoid cystic, which has a high propensity to give perineural invasion, you can pick up best on MRI. MRI can give you complete information of the perineural invasion of the facial nerve. Many a time we have seen the perineural invasion extending along the facial nerve into the mastoid. And you can pick up very well with the enlargement of the enlargement and enhancement of the facial nerve on parotid, right from the parotid to the mastoid along the facial nerve, and that is a sign of perineural invasion. We must keep in mind, particularly for adenoid cystic, like you mentioned. I can see on his screen Dr. Deepak Dalmia. Deepak, before we start surgery, you want to add on something?
Yeah, I want to ask two questions, Satish. Hello?
Ask Shiva. Yes.
Can you hear me?
Yes, yes, yes. You are audible.
One thing is about relationship of the tumor with the retromandibular vein in imaging. Is there any role to study that, whether the retromandibular vein is lateral or medial, so that we can make the diagnosis the tumor is in the deep lobe or super?
Yeah, I have already mentioned, Deepak. See this, retromandibular, as the name applies, is behind the mandible. See, this is mandible and this is the vein. As most of the parotid tissue, we all know, 80% of the parotid is superficial to it. It's an imaginary plane. The facial nerve runs along the depth of the retromandibular nerve, vein. And this minimal 20% of the gland, less than 20% is the deep lobe. So this is an imaginary line, and on imaging we can't pick up the facial nerve so easily. So what we take into consideration is the retromandibular nerve, which runs in close proximity. That's why it is important.
One more thing I want to know, if the patient, as you said in the imaging, we can make some diagnosis if it is a malignant or not, and if it appears to be malignant, and FNAC is showing benign, and the patient is not having facial palsy, in spite of appears to be malignant, then how you count?
Yeah, that's what I asked Shiva before. He has already answered. Yes, he has answered twice. Number one. Yes, Shiva. Yeah, come on.
You can later, I don't mind repeating it again.
So, he has answered twice. Number one, the surgery for the parotid, whether it is benign or malignant, the minimum is superficial parotidectomy. And even if it is malignant, you have a doubt, your superficial parotidectomy is an answer, complete answer, number one. Secondly, he said, they always follow with the frozen section. Always follow with the frozen section. And that substantiates your diagnosis. If it is a malignant, if some change is needed, if some change is needed in your surgery, you can accordingly take steps intraoperatively. Anything you want to add on, Dr. Shiva? किसी की आवाज आ रही?
Sorry.
My question is regarding sacrificing or saving the patient.
So that sacrificing the facial nerve. So that's where the pre-op FNAC is very crucial. So based on what your pathologists tell, whether it's a benign, malignant, and malignant, if they are able to tell you if it's a low grade or a high grade, then accordingly you can counsel the patient as to what will be the extent of surgery in terms of a parotidectomy and the need for neck dissection. And also, if the patient doesn't have a pre-op palsy, then we want to counsel that your
on करा.
What they can say is the relationship of the tumor to the retromandibular vein, which already has been mentioned. So if the tumor is anterior to the or lateral to the retromandibular vein, that means it's probably away from the nerve. If it is involving the retromandibular vein, which is encased, or the tumor is going medial to it, that means probably your nerve is at risk. And also the stylomastoid foramen area. If the tumor is extending towards your stylomastoid foramen area, then that again is an indication that your nerve would be at risk. So it's very difficult task again for the radiologist to pinpoint as to where the nerve is in a parotid. So it's just based on the relationship to the retromandibular vein.
Satish, just one more question I want to ask you and Shiva, that suppose if the tumor malignancy is just involving superficially the facial nerve, not grossly involving the facial nerve, so you sacrifice it or shave it or post-operatively by radiotherapy you manage it, because the function of the facial nerve is normal.
Yeah, let me answer while washing up, Deepak. First of all, facial nerve is important for the function, we all know. Yes. But if you are operating on a malignant lesion and leaving some tumor for the sake of preserving the nerve, assuming that you will control with the adjuvant therapy, is something not acceptable. Number one. Any primary malignant tumor you are leaving behind, assuming that your adjuvant therapy will take over and control this is just a joke, I tell you. Adjuvant means adjuvant, that is not primary treatment. For primary treatment, for a malignancy, it should be a radical surgery. For facial now, if the tumor is closely adherent to it, not involving the nerve per se, still in a low-grade lesion, I can preserve the facial nerve. But looking at a high-grade histology and the tumor is adherent to the facial nerve, which requires sacrificing, even if it is pre-op functioning, I would not think twice to give a good oncological clearance. Adjuvant therapy doesn't mean you leave the primary tumor behind and take control with the adjuvant therapy. Let's take Dr. Shiva's opinion.
Yes.
Boss, can you unmute? Shiva.
Yeah, I do agree that we have to get an R0 clearance as far as malignancy is concerned, no doubt about that. But your roundtable decision as to whether to save or sacrifice the facial nerve is very crucial as to when you would save it and when would you, go on to sacrifice it. You rightly mentioned that the grade of the tumor has a role to play in this. And also if it is totally, and also whether the patient's nerve is functioning or not functioning. If the patient's nerve is not functioning, and if there is a tumor all around the nerve, there's no point saving that, nerve anyways. But then the question comes that when it is functioning and you have the nerve in close proximity, what do you do with the nerve? Now the question here is when you can get an R0 clearance, meaning to say that you have some amount of cuff of parotid tissue that you can, remove, saving the nerve. That should always be an effort. The effort is that whenever possible, we have to save the nerve. That is the basic dictum. Whenever possible, a functioning nerve. Now, that is not at the cost of R plus resection. No, you cannot leave behind the disease, as rightly said. So that is a very fine balance that you have to make. So that will vary on case to case basis. There is no right or wrong.
Can I add on one thing?
Yeah.
Deepak, you can take for this decision 2 investigation into consideration. Number 1, your imaging. Your imaging will tell you how close you are on the facial nerve. And that will require an intraoperative decision, number 1. Number 2, a pre-op electroneuronography of the facial nerve. There are so many publications we have done in our practice as well. The nerve which is abutting, where the tumor is abutting right onto the nerve. Pre-op nerve absolutely functioning. Pre-op electroneuronography showing 50% reduced response. That means that nerve when you are going to handle is going to go. Keeping an anatomically intact nerve is not so important as compared to a functional nerve. And regarding this idea of the functionality, idea of the possibility of preservation, this pre-op electroneuronography is a great tool along with the imaging. These two can help you taking your decision better.
Yeah. So again, just extending what was said, instead of the pre-op neuronography, which you can get it done for academic reasons, but if you have an intraoperative nerve monitor, that will be of good use. You can put it to good use.
Very important.
So that is what is going to actually guide you as to if you've saved some anatomical structure, whether it is actually functioning on table or not. That will be a good thing for a medical legal purpose also, that you have saved the nerve and it's functioning. Even if you've saved and it's not functioning, whether it's worth leaving behind, especially if you have this doubt of whether you have had a good oncological resection or not. So intraoperative nerve monitoring definitely will help. Yes.
Coming to the surgical steps, are you getting any picture? This is microscopic picture. Dr. Shiva, I always do parotidectomy, thyroidectomy, all these under microscope. And there are certain distinct advantages doing under microscope, which I am going to enumerate. Some people use loops as well. I've seen you doing naked eye as well, so good. So it's a matter of, how you are used to. But microscope definitely has a, advantage. Secondly, coming to the surgical steps, the first step, the incision, to me is the most vital step. We have discussed during the facial nerve session when I demonstrated one parotidectomy, all these. But here again, the initial incision has a lot of bearing in terms of, this thing, cosmesis, in terms of preservation of the posterior branch of the greater auricular, in terms of preventing Fraze syndrome, and in terms of when you raise the flap anteriorly, you can injure the facial nerve branches as well. So in terms of protecting all the nerve branches. So the incision and the flap raising has a lot of bearing, which I am going to share with you. So the first part regarding cosmesis. See, I am showing with the microscope. My picture, the area may constrict, I will keep changing. So the first step, what we do, we make this pre-operative, pre-auricular incision And then rather than going on to the preauricular region, we take the incision behind the tragus to make it more cosmetically acceptable, number one. And then around the lobule, see this incision by and large, it is hardly any visibility, you know. This is more cosmetically acceptable. Then obviously this occipital component and then this cervical component according to the need. As in this patient, I am going to do a classical superficial parotidectomy by and large. Number two, as I mentioned, besides the cosmetic part, the number two, please feel free to interrupt me anytime. Dr. Shiva, madam, please. We need your input for the benefit of everyone. This is a pure academic session and we want to learn more and more from everyone. So
if I can just add to the point of the magnification that you'd like to use in a parotid surgery.
Yeah.
So there's often a question, debate, discussion as to what you should do. So if you have to, so what is the advantage of using magnification? One is to have a good
let me tell you.
No, I'm just asking. I mean, I'm just speaking as though I'm speaking to a postgraduate, so that as you said, it's for the benefit of all. So just telling you. So of course, you need to have a good vision so that you don't damage crucial structures, right? So that means to say that you to have a lesser amount of complication. So that is the crux. So if you look at literature, what sort of magnification has given rise to what sort of complications? If you compare naked eye with loupes, with microscope, with endoscope, 3D, hand holding endoscope is also there, which people use. So the complication rates are pretty much similar. So it all depends on the expertise of the surgeon, of course, and what they're comfortable with. So I want the audience to take home the message that if you're comfortable doing the surgery with the naked eye and your complications rate are pretty less, so be it. And if you're comfortable doing it with a loop or with some other magnification, fine, as long as your complication rates are good. But we cannot be, let the youngsters not go with the understanding that you have to use some magnification. This loop is better or microscope is better. We don't know that yet. Any sort of magnification which helps you do the surgery well, you can do that, right?
Now, can I add on one point, Dr. Shiva?
Yeah, please.
This is the reason you have mentioned about the need of magnification is fine. The other reason for which we emphasize this magnification is the better appreciation of the facial nerve branches and sub-branches. You know, by and large in oncology, the facial nerve is supposed to have 5 branches in the parotid. By and large, the oncologists believe. It's not 5 branches. I am going to show you with the microscope n number of interconnecting branches. Number one, those small branches are difficult to be visualized naked eye, number one, and those are important in case you happen to damage, you happen to give neuropraxia, you happen to give neurotmesis and sort of damage to one of the branch. If you preserve consciously all those interconnecting branches, your chances of spontaneous recovery are much better. Number one. This is the biggest advantage for which we use the microscope, besides the other reasons you told. And this is what, we always emphasize, and here I am going to demonstrate as well. See,
I do agree with what you say. The intercommunicating branches have been mentioned in literature, and the importance of preserving the intercommunicating branches of the facial nerve has always been emphasized. But what I'm just trying to say to the youngsters is that let them not go with the idea that this is this magnification is better than that. After all, by saving those intercommunicating branches,
it's all relative. Nothing is hard and fast. It's all relative.
Yes. So you're going to reduce the complication. That's exactly the point at the end of the day. So by saving the intercommunicating branches, you probably would reduce the amount of paresis of the nerve. That is what it helps in. That was my point.
Yes, exactly. Now the second thing at this point of time, the second advantage or the important thing I mentioned about the incision is the prevention of Fraze syndrome. This parotid region is covered by a special tissue, we call it SMAS. That is this, this fibroaponeurotic tissue lateral to the parotid region is known as some mucus, I would say,
musculoponeurotic system.
Submucous aponeurotic system. So what is this? Why this is important and why this concept is important? First of all, what the Fraze syndrome is. We have seen in our cases earlier, in couple of cases, when you remove the parotid tissue and some part of the parotid after the superficial parotidectomy, some part of the parotid is left exposed. And when you replace your flap back, if your flap is so thin, your subdermal plexus can come in contact with the postganglionic fibers of the parotid and can lead to stimulation while swallowing, while chewing, while having food, and that can lead to Fraze syndrome symptoms. So idea is to elevate this thick flap. Complete SMAS should be elevated here to prevent Fraze syndrome, and that can be taken care of during this part of the flap elevation surgery only. See here, what my depth of the tissue is staying just superficial to the parotid. Staying just superficial to the parotid, this entire SMAS I am elevating. Why this SMAS is named like this? This area is special because here in the deeper part of the face are muscles of facial expression. And those muscles of facial expression are connected to the dermis through this fibrocollagenous tissues to pass on the facial expression movement from muscle to the skin. This is specialized area in the body as compared to the other areas where the muscles are used to mobilize the bones. Here muscles are not used to mobilize the bone, but for a special function of facial expression through the movement of the skin, and that is how it is conducted through the SMAS. So
if I can just, for the benefit of the postgraduates, just how do you identify the the SMAS? Is that in the neck we are always told go subplatysmal, below the platysma. Whereas when you come to the face, you have to keep the again you should follow the same plane. Initially it was like we were taught that go subplatysmal in the neck and above the platysma in the face, right? So you have to keep the platysma with your flap so that when you put it back, whatever the tissue does not come straight in contact with the skin. So some amount of muscle layer should be there on the flap that you raise. So that is very crucial and important.
That is very important. That is exactly what the SMAS we talk about.
And
so,
Satish, even when you give this incision, you please tell us for the sake of postgraduates, when you give this posterior incision over the mastoid tip, so you have to take care that it will not go too posteriorly, so that
exactly. That's a very great point, because the Blair's incision, what the name of the incision is, modified Blair incision. So you may ask, what is the Blair's incision then? So initially, when it was described, it was an acute, angulation of this incision going all the way up to the mastoid tip. So when you have that acute angulation, then the vascularity becomes questionable, and that's when this, it's more or less like a lazy S-shaped curvilinear incision. And to avoid this acute angulation, which goes way too posterior towards the mastoid, to avoid this, necrosis of the skin. So that is very, very important to avoid.
So the second part was to prevent the Fraze syndrome, and we'll raise this flap all the way. We'll raise this flap deep to the parotid fascia to protect our, to prevent the Fraze syndrome.
Yeah, and just for the benefit of the postgraduates, again, if anybody wishes to do, they can do this superficial parotidectomy even with your rightidectomy incision. Instead of going anteriorly, you can just go along the hairline. And if you take the incision along the hairline inferiorly, you can as well do the neck dissection also with that particular incision. So that's a retroauricular. Nowadays, many of us do a retroauricular neck dissection with a retroauricular incision. So you can as well do the neck dissection. You can do your parotidectomy with the same retroauricular incision. That's just another point.
Dr. Shiva, are you using this retroauricular and do all this robotic work there in Tata?
Yes, some of our colleagues do it. I personally don't use robotic for this, for a neck dissection as such. But then we can just do a retroauricular neck dissection just without any, gadget, just an open retroauricular neck dissection. Many of my colleagues also do it.
Satish, please tell us, when you raise the subplatysmal flap superiorly, what care you take to avoid injury to the mandibular branch?
Mandibular branch, I will show you. That will come later.
But for mandibular branch, you have to stay right in the, subplatysmal plane, not going deeper to that plane. Stay in the right plane, and I will show you the mandibular branch. Now, the most important thing what I am doing here is trying to preserve the posterior division of the greater auricular, which sometimes is has proven to be difficult, but most of the time we are able to preserve it. Now see what I am trying to show you. Can you see the greater auricular now?
Yeah.
Yes, yes. Can you see this?
Yeah, it's here.
There are many tips to identify this now at this level. Number one, see this. This point I have already mentioned so many times in the webinar, that is Gonian. The posterior inferior edge of the mandible. Can you see this? This greater auricular nerve comes out of the McKenzie point here. McKenzie's point here, where a lot of nerves, sensory nerves comes out, then running over the sternomastoid. In this part, where it runs over the sternomastoid, is right in the line of the Gonian. Can you see the Gonian here? Right in the line of the Gonian, you can easily pick up. Number one. Number two, 1 centimeter inferior and parallel to it, many a time we find a branch of the retromandibular vein. So if you find the retromandibular vein, sometimes you can have a very good idea about the level of the greater auricular nerve. That is inconsistent, but many a times you find 1 centimeter below and parallel. Here I can't see.
So this point in the neck where you're talking about, I'm not sure if you were mentioning the Erb's point. Is that what you're...
We call it McKenzie's point. A lot of people call it as a Erb's point. Erb's point to me, Erb's point is to me, is the point where brachial plexus comes out.
No. The Erb's point is a classical description of where the 5 branches that comes out along.
Yeah, a lot of people call it, but this was classically described by Professor Sarnia. You must be knowing Professor Sarnia from Brazil, in his book as well. Yes. And this was initially described by the McKinney, who described this point where the 5 points are coming. A lot of people call it as a Erb's point, but actually the initial description of the Erb point in the Gray's Anatomy was referring to where the brachial plexus comes out. Now people differently describe this point, so we still maintain that region and call it McKinney's point. You can call it whatever is convenient to you, but this is how it was described initially by the McKinney. Now see, considering I am not raising my flap so easily, I would have raised by now. What is restricting me is preservation of this nerve. Can you see this?
Yes.
Now this nerve, as it goes towards the parotid skin, divides into 2 branches. The anterior one going to the parotid skin has to go, and it regenerates most of the time because that supplies the parotid skin, and it has numerous interconnection with the trigeminal nerve branches, and most of the time it regenerates. But the problem comes with the posterior branch supplying the auricle, the lobule. Don't leave it. The posterior branch supplying the lobule is something difficult, and it has its own morbidity if not preserved. And in our series, over 90% of the time, we are able to preserve this. And here again, the microscope helps you a lot. So because if this branch is gone, the resultant anesthesia of the lobule is sometimes not acceptable. It gives a morbidity, particularly to the females wearing the earrings and the people who live in the cold climates. Even if you get a burn with this in the lobule or anything, you can't appreciate once this nerve is gone. So this posterior branch, our version is to preserve it whenever possible. It may not be 100% of the time to save this branch, but we must attempt. It may take your 5 minutes extra, but still we can preserve it. And I have always demonstrated in our series, over 90% of the time we have been able to. Sometimes you have a tumor coming behind, and you literally then you don't have to think twice before resecting it. But this is important. See this? It restricted me in raising the flap for last 5 minutes. That is the extra time this takes away. See this branch? I hope it is visible. The greater auricular is visible, I suppose.
Yes, sir. Yes, sir.
And see here, I am taking you to the branches. See the branch, posterior one is a smaller one, the anterior one is a bigger one. See, this is the posterior branch.
Right.
Can you see this?
Yes, sir.
This is going to the lobule. And this we try our best, and unless the disease warrants to the clearance of this region, we always try to preserve it. Just additional 5 minutes, and see this nerve branch going to the root of the auricle.
Very clear.
See this? Now having seen this, I can easily transect the anterior branch. See, it's staying in this region.
Wonderful, wonderful.
Completely taking this cup of tissue around the nerve. Now the anterior one is completely gone. See this? And this way I will elevate this tissue and separate this branch. This is how you can easily, now once you have seen, mop. See, this is the posterior branch going to the root of the auricle. Can you see all very clear?
Yes, yes, sir.
So that was the third advantage in the flap raising, I told you. And to complete the second one, to prevent Fraze syndrome, see my elevation of the flap will go in the plane of SMAF. Here, I have to keep in mind my tumor, which is coming laterally, so I have to be careful, you know, to leave a good cup of tissue lateral to the tumor as well. छोड़ा मत कर यार. Can you see the level of the plane?
Yes, sir.
Immediately lateral to the parotid, so that I don't want to leave any tissue, or on the other way around, I want to keep a thick flap to prevent Fraze syndrome. Now the fourth and the most important part in flap raising, whatever good work you have done can be ruined in no time if you are not careful, is the anterior extent of the flap. See, this is platysma, what Deepak was asking.
Yes.
See, stay absolutely subplatysmal. Uta. Now the fourth important point here, till what limit anteriorly you are supposed to raise the flap. If I cross the limit of the parotid and go into the masseter, I will end up damaging all the branches running on the surface of masseter. So this is a very, very important point. While anterior flap raising, you are not supposed to go beyond the parotid margin. See this?
Yes, sir.
The moment you find your platysma started coming, can you see the masseter started coming? Can you see this?
Yes.
Can you see all these branches?
Yes, yes.
See this. See this, all these branches on the masseter. If I keep raising flap further beyond, I can easily ruin everything without much efforts. Dr. Shiva, can you see all these small branches?
Yeah, seeing that.
If I have seen people doing good parotid surgery, and this flap having raised beyond that. See, this is my limit of the parotid. This is my, this masseter. And all these small branches, all these branches running here on the masseter surface. You can see all these, and number of branches. Forget about this concept that the patient now has 5 branches. And number of innumerable small branches destined for this complex spontaneous expression of smile. All these branches, see in magnification. See how amazing these are. Can you see?
Yes, yes.
All these,
Yes,
see, this
sir,
is
very
masseter.
clearly.
This is masseter. So this flap raising, always instruct your junior not to go beyond the limit of the parotid, otherwise he can ruin everything in the beginning. Whatever nerve preservation you do during surgery is as good as useless once you have cut the nerve distally. And this is very, very important. So this flap raising to me with 4 goals in mind: cosmesis, prevention of face syndrome, preservation of the posterior division, and preservation of the facial nerve branches distally. If you raise the flap properly, you can achieve all this goal. And otherwise, if you give this task to a junior colleague, not taking care of any of these, and considering this, somebody will elevate the flap for you, not taking care of all this can ruin everything in no time. Whatever good work you do in parotid surgery, to me this flap elevation is one of the most important steps.
Satish, what you said, the anterior limit, like how much is the superior limit? What are the landmarks for superior limit?
Superior limit to me for such tumors, I have already palpated the zygoma here. My SMAF is inserted here and fused with the temporoparietal fascia. And this lesion particularly, you see, this is little superiorly placed. We saw on the MRI as well. So superiorly, our limit is generally zygoma, and depending upon the condition, depending upon the situation, you can extend your approach. Sometimes, you know, I demonstrated last time, Deepak, if you remember, the mesenteric nerve anastomosis.
Yes,
And in case you have a pre-op facial nerve palsy and you are planning some immediate anastomosis after the surgery, after the resection of the facial nerve, I generally go little above to go in the region of the mesenteric nerve and do a anastomosis intraoperatively. It has been proven, even after anastomosis, if you subject the patient for the radiation therapy, it doesn't affect the anastomosis at all. So it is always the intraoperative reconstruction which is most important. So this is about the...
Now that you make that point, that again for the postgraduates, whenever if you are in a situation that you end up sacrificing the nerve, it's very important to reconstruct the nerve at the same point, during the same surgery itself, because you will not be able to get the planes or the the surgical field that you desire for a secondary reconstruction.
There will be a lot of fibrosis.
So, and even if irrespective of whether the patient goes for radiotherapy or not, and usually the fear in mind is when you go, send the patient for radiotherapy, the healing, how much will the healing happen? So it's been shown beyond doubt that the healing happens and the nerve starts to function, in a good amount of time. So it's very important that if you happen to resect the nerve, reconstruct in the same surgery.
Yes, that is very important point you have emphasized again, that we need to reconstruct the facial nerve at the same time, otherwise we lose the opportunity for the future. You cannot come back in the same field that efficiently with lot of fibrosis incurred after the previous surgery and then followed by, if possible, radiation and other things. Now what I am doing, I am working at the level of, I am opening this plane of the anterior border of the sternomastoid. That will give me 2 advantages. Number 1, that will give me, keep my this nerve behind, further behind. Number 2, that will help me see my digastric. And number 3, that will open up my level 2 as well. Now, the parotid surgery revolves around one and only thing, that is facial nerve. There are n number of techniques you see in the literature mentioned for the identification and preservation of the facial nerve. And if you trying to go to all, that will be more and more confusing. I have demonstrated several times that the technique we use, see, so far I am using monopolar. I will tell you the reason. The simplest way, we have named this as a convergent approach. I don't need to look for the facial nerve. Facial nerve will come automatically where my 2 landmarks are going to converge. That is convergent approach. So I will take into consideration 2 landmarks and my facial nerve will automatically come over there. This is microscopic picture. Hope the picture is good.
That's good.
It's good.
Hello, Paramita, how's the picture?
Very good, very good.
Okay, fine. Let me do little bit of the hemostasis and then I will come to the convergent approach for junior colleagues. I demonstrated several times. It is the simplest of the thing one can understand how to identify and preserve the facial nerve, and that is convergent approach.
Yeah, I just would like to caution the juniors as well. This is Dr. Satish Jain operating, so don't try to do this in your first surgery. So you can, once you become experienced, you can do that. So the general teaching for the residents that we always say is that once you raise the flap for the parotid with a cautery, then go switch over to your monopolar, because for the novice surgeon, bipolar, sorry, switch over to the bipolar, sorry. So for the novice surgeon, it becomes difficult as to understand at what depth you get the facial nerve. So if they use the monopolar, like how a conversant surgeon would use, like how he showed, you might go and damage the nerve. So till you understand the depth, and once you gain the experience, then you can use your monopolar. But then that's what we usually tell our residents, that once you raise the flap, switch over to your bipolar.
That's an important point of caution. And see, to overcome this issue, this convergent technique is the answer. I tell you why. My convergent means I will be using two landmarks which are going to converge on the facial nerve. So my first landmark, see, this is tragus, and this is the cartilage of the tragus which ends medially. Can you see this pointer?
Yeah.
Everyone, can you see this pointer or not? Let me
yes, we can
remove the perichondrium. See this, this is the pointer. So this is the tragal pointer. Can you see? This is going to be my superior landmark, assuming my facial nerve is going to be 1 centimeter inferior and 1 centimeter medial to it. Number one. Now, as my facial nerve is going to be 1 centimeter deeper and 1 centimeter inferior to it, if I use my monopolar cautery in the line of the tragal pointer, I will be still 1 centimeter away from the facial nerve. That is number one. Number two, I have a safe distance now for working, that is 1 centimeter. But this is only one landmark. Give me another retractor here. Now my
Satish,
yes.
Sometimes, as you said, as Dr. Shiva already said, here you just remember Satish is operating, but sometimes even the imaging, all are not so expert in reading the imaging. Sometimes the tumor is in the deep lobe and the tenting of nerve.
Then you have to be careful. Yeah. See, deep lobe tumor can push these structures laterally.
Yeah.
Then the situation is altogether different.
Yeah.
Then you have to stay.
Yeah, sorry. So the other point I'd like to make here is that as you're dissecting here, of course, the convergence of the cartilage and the posterior of digastric is a very constant landmark to identify the nerve. The other thing that you would we find it very useful is that before you see the nerve, you'll have a spurter. You'll have this branch of the stylomastoid artery which is accompanying the facial nerve as it comes out of the stylomastoid foramen. So once you see an active, a well-delineated vessel going in the direction of the patient nerve, be aware that you're going to face you're going to come, across the nerve just below that, somewhere in the tissue. So this artery is also a very good,
that is a point of caution again, that you have to be careful. You are close to this.
Yes.
Now, what I am trying to say, after having seen the anterior border of the sternomastoid in the depth, what you see, this is digastric. See this? Digastric is a natural landmark given by the god. We know the stylomastoid foramina, at the medial end of the foramina, at the stylomastoid foramina, we always take in mastoid surgery the digastric ridge as a landmark. And if we follow the digastric ridge, the facial nerve is exactly anteriorly and just medial to it. Now follow the same thing. This digastric, if you follow where it goes, see, this is my mastoid process. This is my mastoid process.
Centralized.
Yes. See, this is my mastoid process. This digastric is coming to the mastoid process, and where it inserts, my facial nerve will be absolutely just superior to it, where it inserts, and deep to the anterior border. Now, what does it mean? See, I am running my artery forceps here, Kelly's, is right on the digastric surface. As I said, the facial nerve is medial to the digastric. Keeping this artery over the digastric, any tissue coming in between I can easily cut away and open like a book. It's not this surgery, lot of people perform with making a, well into this region to look for the facial nerve, made many a times end up damaging the facial nerve. See, I can remove any tissue lateral to the digestic. Can you see now? So the biggest advantage is you don't develop a well. You don't develop a keyhole. It is like an open book. This is my superior landmark and this is my inferior landmark. And now see what I am trying to see. My digastric is inserting here on this, in the digestic process, in the mastoid process, and immediately above this level.
You need to center the picture a little.
Yes, 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 madam. Yes, yes, please. Thank you. See this. Now where my digestic, wash. Keep this, this is a very important step. See what I told you in the beginning. Just above my digestic where it inserts here. 1 centimeter below and 1 centimeter deep to the tragal pointer. Just above my digestic insertion. Can you see the facial now?
Yeah, beautifully.
Can you see?
Very good.
Dr. Shiva.
Yeah, seen.
See, this is the digestic which insert over here. Just above the digestic insertion. See, 1 centimeter below and 1 centimeter deep. At this point of conversion is the site for facial nerve. Now, what I mean to say, coming to your point, what you mentioned, which is very, very important, the depth perception. Depth perception is important.
That, keeping in mind what I was going through as a postgraduate. I never.
Yeah, very, very important point. You raised a very important point.
I started getting that hang of it as we started doing more and more surgeries, assisting, and then doing.
Yes.
Then that's when we really understood. Otherwise,
Yeah, that is very important point you raised. Otherwise, if somebody is not careful about the depth, can end up easily injuring the facial nerve. Now, what I want to make point over this point of time for that particular region, as long as you stay above the digestic like this, anything coming over the digestic, anything coming over my artery forceps, I can easily remove. My facial nerve will always be medial to it. And this way, I will never create a tunnel, a well, or a keyhole. It is like an open book with one landmark from above, one landmark from below, and where they are converging is the facial nerve. I didn't have to look for the facial nerve at all.
Yeah, that's because Satish Jain is operating the surgery. No, the nerve is looking at
our goal is to simplify for everyone.
Yeah. So, but when a new person is operating, so the way they use the mosquito will not be the same like what Dr. Satish Jain is using it. So they will not. What the usual tendency is, that's what I used to do when I was a postgraduate, is to dig in and then take it out. So when they don't, respect the plane.
Use the term TLC.
Yeah. Tender loving care. So I would not cut any tissue that is coming in the direction of in the direction of the nerve till I see the nerve. So what we teach the postgraduates or the residents here is that first see the nerve and then cut any tissue that goes in the direction of the nerve. Because if they're not careful, if they don't know how,
yes, that's a very good standard teaching. I absolutely agree.
So you see the nerve and then cut any tissue, whatever you want, because you might cut that nerve and then it's too late. And then once you gain the experience, of course, your approach changes.
But the thing is, we have to simplify rather than terrifying people.
No,
the reason is...
This is not terrifying. This is
not what about what you said.
No, Dr.
Yours is
having done a lot of parotids naked eye, and now with age using the loop and the microscope, this is where the loops or the microscopes help, When you learn to identify the tissues which look like a facial nerve and which is exactly the facial nerve.
Agreed, ma'am.
I agree with you. Experience is the best thing. And another thing which I would like you to observe is that when you're using the microscope, this thing which you feel that should I, Dr. Dalmia, whether I should sacrifice this now, whether I preserve this now. So when you're using the microscope and when you see that you can peel it off, malignant tissue of the perineurium, you will be able to save that now.
Yes, you get a better...
With a microscope, you can make out definitely.
Yes, you get a...
Even if you preserve this now, after some time it's going to go and it's going to cause a facial palsy. So
exactly, madam. You get a better picture.
That your microscope helps.
you get a better picture of the
Raising the
tumor
flammar, you are
nerve
very correct.
interface.
But regarding the nerve anatomy and all, I think identifying the nerve, and when you have this doubt without a facial nerve monitor, whether it is involved or not, this is where the microscope helps me at least.
Is there anything like this that there is a medical legally needed that you should be having a facial nerve monitor?
Not really.
So far, it is not come in India.
It is better to have, I would say. Shiva can tell you better.
If you have it, better. If you don't have it, I'm not sure if anybody can, sue you for that reason that you don't have it.
Okay.
Yeah, it's better to have.
There's a question from Mauritius. Dr. Chandra Prakash is asking, any precaution to avoid first bite syndrome?
Yes. First, let me tell you what is first bite syndrome.
Yes.
First bite syndrome generally doesn't happen so easily after the superficial parotidectomy. First bite syndrome happens to occur due to denervation of the sympathetic fibers, postganglionic sympathetic fibers, which run along the external carotid artery. So that happens to occur, that may happen, that is not so usual, but when you do a deep lobe dissection or a parapharyngeal dissection around the carotid artery, and if you injure the parasympathetic, the sympathetic fibers along the carotid artery, so that because of the over denervation, sympathetic overactivity, and when patient takes the first bite, which involves the parasympathetic stimulus, it adds on to it, and that gives the excruciating pain to the patient. So that happens only when the sympathetics along the external carotid are denervated. Yeah. That too when you do either in the deep lobe where the carotid is or in the parapharyngeal space, but it never happens with a superficial parotidectomy. Yes.
Just adding to what Dr. Satish Jain has said is that it happens more so after doing a carotid body tumor.
Yes, that is parapharyngeal space.
That's what. So most of the time in literature, when you just go through it, most of the time because you denervate the sympathetic system, which is there embedded around the carotid system, so that's when you tend to face the, the patient tends to develop the first bite syndrome rather than in any of the, parotid surgeries.
Absolutely.
Even if you end up doing a total parotidectomy, and even if you end up handling the external carotid vessels, I won't be able to categorically say that never happens, but it may not happen as often as it happens after doing a carotid body tumor surgery.
Yes,
because you're totally removing the adventitia of the carotid, and
sometimes you ligate the external carotid during the carotid body surgery. Now see what I want to show under microscope. Can you see the upper division?
Yes.
And I have dissected all this tissue of the upper division, and nowhere I am close to the tumor as far as the nerve dissection is concerned, and that we saw in the imaging as well. I showed on MRI the tumor is away from the nerve where the nerve is passing through. That's the value of MRI, and that's the value of reading MRI yourself. The radiologist is not going to give this information unless you ask for it. This is something important. Now see the upper division. This is so important. And lots of branches from the upper division. Under microscope, I can see them all.
Yes, sir.
There are not 5 branches only. There are number of branches.
Sir, can you focus a little more, sir?
Yes. It is not focused. Oh, why?
Better.
Why didn't you ask earlier, Rukna?
It's okay, but make it more focused.
Yeah, I will focus it better.
The other point is that while retracting the parotid tissue, we usually tend to use the cat sperm. So that gives you more space, and you can actually give a proper, traction, counter traction for dissection. That's what we would use. I'm not sure if it helps.
That is important. What Dr. Shiva has mentioned is a very important point, because most of the dysfunction of the facial nerve are not because of facial nerve resection. Most of the dysfunction you will see in your practice even after keeping the nerve anatomically intact, and the reason is traction. So you have to be very careful in, giving traction in the region of the nerve. That's why what we do, we give traction to the superficial component, not the nerve and the part deeper to it. So you automatically prevent the nerve coming into the traction. That's a very important point, Dr. Shiva, you have raised. Yeah. See now, This tumor is here. See, this tumor is here.
Yes.
And my nerve is there, and I am little conscious here, preserving all these small branches coming from the upper division.
And
And
what we remember, the TLC term we use, Satish.
Pardon?
TLC means just tunneling, lifting, and cutting. This is the way we remember. First we have to tunnel, then we have to lift, then
Yes, that's good point.
And the other, message for the, younger, colleagues is that, or the residents, is that if at all, even, the nerves are accompanied by small vessels, and as you're dissecting, there'll be some amount of bleeding that keeps happening every now and then. And sometimes you might get frustrated and, try to go and catch the bleeder. And you have those nerves which are close by. So if you don't give, proper attention, you might go and cauterize the branch of the nerve. So it's also okay that if you're not able to, cauterize it one go, just apply some gentle pressure with a gauze, wait for a couple of minutes, the bleeding will settle. And then you'll be able to see that whatever the bleeder is, and then you'll be able to precisely go and coagulate. So you don't have to be in a hurry to go and catch the bleeder, and in the bargain, you might go and damage the vessel.
Yeah, that is one of the regions of damaging the nerve, common regions.
Sometimes just apply a gauze piece and just wait for a couple of minutes. The bleeding will settle, and then you can proceed again.
Now see, I have changed to the lower part first, so that I can turn around my specimen. I want to preserve all the branches here, taking the advantage of the microscope. Now you see the retromandibular vein here?
Yes, sir.
Can you?
Yes,
And see the close relationship of the nerve to the vein. That's why this nerve is a bigger structure, easily identified on imaging, and we assume the level of the nerve where the retromandibular vein is. That we could see on the imaging how the tumor was lateral to the vein, staying in the superficial lobe. Okay?
Yeah.
Now see the lower division. See my traction. That is what Dr. Shiva was mentioning. See, my traction is elevating the tissue lateral to it. It is not putting any traction on the facial now. Can you see?
Yes.
This is the indirect way of preventing the traction on the facial now, and that is most important.
Yes.
Now see, there are two branches here, major branches. The one go along the nerve, that is cervical branch, and one which emerge anteriorly, that I am going to show you. Give me the artery. See that? The microscope gives you, confidence that you are not going to miss anything, and that is how.
Other point is, important point is, sometimes when you raise these plates, you cut this external jugular vein. So it is not required at all, because the facial nerve is also one of the good landmark, and there is no need. If you cut this in the beginning, then the venous ooze will be more.
Exactly. So some of them teach that as soon as you raise, you ligate the external jugular vein, which is counterproductive. So your surgery tends to become very bloody. The oozing becomes
congestion.
Yeah, it becomes congested. So it's better not to do that unless you're forced to do it because of some other reason, like by accidentally you've damaged it, or the tumor is close to it for reasons such as that, but not as a routine step.
See now this now. Can you see all these small nerves?
Yes.
See, let me just for the sake of demonstration show you under magnification. See this? All small nerves you can protect. And see number of interconnecting branches. Branches. See, our goal is to preserve many of them. It is not the facial, preservation of the facial now. It is the synchronous, spontaneous smile, which is such a complex function of this nerve with 34 pair of muscles with innumerable branches in the normal individual. To keep that intact after this surgery is a big task. Keeping the facial nerve intact overall is not that a big task, believe me. Keeping that coordinated, spontaneous smile, and that is the end result of these 34 pair of muscles coordinating together for a complex function of smile.
What
should be the minimum margin around the nodule? Means I know all we advocate total means superficial parotidectomy, but if suppose we want to do limited work, then what should be the minimum sleeve of normal tissue around the nodule?
Shiva.
Yeah, what would be desirable will be a 5 mm, but then this is the margins in parotid is a bit
difficult,
controversial topic.
At the tail of the parotid, you have no margin.
No, that's exactly the point. So the concept of margins in parotid is a kind of a controversial topic. So at the base, if you can just get a soft tissue of, there's a publication from Tata Memorial in mucoepidermoid carcinoma, and they've seen how in the retrospective series how patients have done well. So when the margin was more than 1 millimeter, soft tissue cuff around the tumor, so and when the patient received adjuvant whenever it was indicated, the locoregional control, the disease-free survival was better. Now, if you ask me, this is just by a statistical method which showed that when it was more than 1 the disease-free survival was better. But then this concept is, it's controversial. There is people may agree or disagree in this. So, ideally speaking, if you can get a 5 it's good, but you're not going to get that on the nerve. But if you can get a 1 of cuff around your tumor bed, you should feel satisfied about it. If you're not even getting an 1 on the nerve, then you should think of doing, and if the grade is high grade tumor, is when you need to think of converting it into a total conservative parotid.
What is the is there any difference in the management of high grade mucoepidermoid carcinoma or squamous cell carcinoma?
The thing is that it's a very good question, interesting question that you ask, because the high-grade mucoepidermoid carcinoma and a squamous cell carcinoma is very difficult to differentiate. Your pathologist, if you ask whether they can 100% rule out a squamous cell carcinoma, they probably may not be able to do it.
Can I make a point, Dr. Shiva here? Can I make a point?
Yeah, so they are differentials. So you probably will have to treat a high-grade mucoepidermoid like a squamous cell carcinoma maybe.
We had a patient like this. And it was difficult to differentiate, And then the ISC sample was sent to Mumbai to Dr. Anita Borges,
Yeah.
What marker she did to differentiate between a mucoepidermoid and a squamous cell carcinoma? We consider generally MUC1, MUC4.
Cytokeratin is what you would have done.
Yeah, she considered and mentioned the MUC5AC is the marker to differentiate the squamous cell carcinoma from the mucoepidermoid.
That's exactly the point.
The MUC5AC is the marker.
Correct.
That is the only thing which can, by means of which you can confidently discriminate between the squamous cell carcinoma and the mucoepidermoid. See these small veins bridging?
Yes.
See why I am able to do, Dr. Shiva, why I am able to do and preserve all these small nerves, intercommunicating branches. See this. What is intercommunicating branches?
I appreciate the images and all that.
See this.
It's one of the good methods to do it.
See this. This is the intercommunicating branches. See this.
Yes,
These are the main branches, and there are n number of intercommunicating. See this intercommunicating now?
Yes.
All these are important because this facial nerve function is so complex a function.
Yes. So the point again I would like to emphasize is that you can use whatever magnification you want. It can be a microscope, it can be a loupe, it can be anything. So you can consider using a magnification for sure. There's no doubt about that.
Now see, I am lifting my specimen from below and see my all lower lobe branches are absolutely intact. Lower pole branches, can you see?
Yeah.
Along with the nerve, vein and all the number of branches. It's not 5. There are more than 10 branches, main branches from the lower division. We always think of 5 branches in total.
Juniors are asking this question that how safe it is to use diathermy, the bipolar near these branches?
You have to be very carefully in using,
So the other point is that you have to keep using a lot of saline. That's another point. While you're using the bipolar, just to reduce the thermal damage, the collateral damage that might happen. And also the main point is that catch the point of bleeder and not a clump of tissue to
that is again the microscope as a value. I can see the smallest of the bleeder here.
Yes.
Yeah.
See again the smaller lower buccal branch. Very small, if I have a slightest doubt of this branch, any of the branch, regarding tumor involvement, I will not think twice before sacrificing that.
Yes. So
Because
Dr. Praveen from Aurangabad has a question. Is it better to use nerve monitoring used by the anesthetist for nerve block? Is it cheap?
It's the same nerve monitor that you use for the thyroid, you know. The
Yeah.
same nerve monitor can be used for any surgery in the
yes,
in the
yes.
human body.
I showed you, you see, this is the cystic wall. See, I am going around the cystic wall.
Yes, yes, yes.
Can you see?
Yes, sir.
And this is right on the muscle here. So here I will not take a chance in preserving one of these two branches, you know. These are buccal branches, or not main buccal branches, but branches of the buccal branches, you know. And here I will take a radical course, you know. See this?
Yes.
I will take a radical course in removal of the tumor. Here the tumor is adherent. You see this? See my all the lower branches intact. Again, all lower branches intact. All the upper branches. See this here. Now I will follow my zygomatic branch, the main one. See this? Preserve this, and I may have to, only thing left to sacrifice to give me oncologically sound clearance is the upper buccal branch sacrifice, you know.
Yes.
I will not think twice because rest of my all branches are intact. This is a mucoepidermoid carcinoma, supposed to be low grade, and I don't want to take any chance because I have the best possible chance to give a cure to this patient.
Yes.
Because of one or any buccal branch, I will not compromise with the oncological soundness of the surgery. See this? The zygomatic branch?
Yes, sir.
Completely preserved, away. See this?
Yes, sir.
And then I will round off, totally round off. Because I saw at one place it is going deeper. One
It was
place.
evident in the scans as well that at one point it was just sitting on the masseter. So
Yes,
probably
yes,
you'll have to-
that is the point.
Yeah, exactly.
Sitting
You've
on
reached that
the,
point there.
yeah, sitting on the masseter means one of the branch is going to be in close relationship.
Yeah. So
That
actually,
is-
looking at the scans, I had this fear to begin with itself, because whenever your tumor is placed higher up, like what it is here, even though you wouldn't have problem tracing your main trunk of the facial nerve, your zygomatic branch automatically comes at risk. But here, lucky for the patient that the zygomatic branch is just above it, you can dissect it. But many a times the disease might be so bad that you might have to sacrifice the branch that you're really worried.
See this now.
And
How
you
I am
have to
going to do round off in no time.
Yes, sir.
See, that is my level of the masseter. You can see below.
Yes, yes.
Yes. At this point, always.
I have taken all the branches, saved on this side. On this side as well, I have saved most of these branches, the major branches. Here, this upper buccal branch is something at risk, and I will not take a chance. I can see my tumor here, and I don't want to go close to it. I really want a good cup of tissue around it, and here I can get by just sacrificing a small buccal branch. This is something you should not think twice.
Yes. So there's a
So just-
question from Iran. What
Yes.
about using peanut soaked in adrenaline for control of small bleeders?
Yes, adrenaline we generally don't use. I don't know. Dr. Shiva, do you use adrenaline
No,
peanuts?
we don't use it for parotid surgeries for sure. But they can use it. There's no harm in that. Until and unless your anesthetist is okay with it.
Yeah, see now. This is the masseter muscle below. Can you see?
Yeah.
Yes.
And see now how it is being elevated out of masseter. See, it is so adherent. And see, all around I have cleared. So I will take it as a, en bloc. And here I am going little radical. See this?
Yes.
Can you see the plane below?
Yes.
A little radical.
So there is a question. Yes, sir. There's a question from Dr. Shiva, sir.
Yeah.
Dr. Girish from Billai wants to know if tumor is localized in the tail of the parotid. Even
No,
then-
no.
You do classical superficial parotid.
Depending upon the, kind of malignancy it is.
No, if histopathology, if it's a Warden's tumor, let's say, that's the most common location for a Warden's tumor, then we can do what is known as an adequate parotidectomy, wherein you just remove the tumor with a cuff of tissue.
See, this is the branch I am dividing.
Yeah, but you'll have to, do a proper steps of parotidectomy, but then you don't have to do a textbook classical superficial parotidectomy. You can do what is known as an adequate parotidectomy.
Can you see the branches I am dividing now?
Yes, yes.
See these two small buccal branches, because here I don't want to take any chance compromising.
The minimum surgery is superficial parotidectomy.
Yes, yes.
I think that answers the
Both
question.
of you, Dr. Shiva and Dr. Satish, please enumerate the, you can say, points in the revision cases. What precautions you should take radiologically, how to assess it, and what the during surgery, post-operative, like in revision cases, like.
I tell you one thing. In revision cases with whatever previous surgery done to expose the facial nerve, it is damn difficult to preserve the facial nerve. Functioning facial nerve, number one. And if it is a malignancy, forget about it. In a malignancy,
I do agree. Take the point that the chances of preserving the facial nerve in a revision surgery is that much lesser compared to an upfront, treatment naive. But then the effort has to be to identify the procedure steps remain the same.
Yeah.
But it might be difficult to identify the main trunk because the plane is already violated. So you can just maybe understand from the previous surgery as to how much of a surgery they've done. Sometimes it can just be a nodulectomy or a biopsy, wherein you might have your planes intact, the usual planes that you want. But if they've done some sort of a parotidectomy, raising the flap and all that, then tracing the nerve becomes difficult, and that's when you have the intraoperative nerve monitor becomes handy. And the other thing is, you can, in those situations, the retrograde approach of tracing the nerve becomes helpful. So those are the steps that you can use. But I do agree with Dr. Jain what he says, that the chances of you saving the nerve, especially when it is malignant,
functioning now,
much more
functioning now in a malignancy is difficult, because in malignancy you have to do an adequate clearance, that to minimum superficial parotidectomy.
Let me warn the. I understand what Dr. Satish Jain is saying, that for oncological clearance you have to get an R0 clearance, you have to be radical. Point taken. Yes, agreed. But then let the youngsters not go back thinking that if it is a malignant tumor, you have to just go in and remove everything that is there on your way. No. So the decision will be on-table decision. You will have to take the decision on table depending on your tumor on the case-to-case basis. So yes, it's a malignancy. You have to get an R0 clearance, but you have to go with the case-to-case basis. The decision will differ.
Now, can I show finally the field?
Yes, sir.
Hello?
Yeah.
Yes, sir. Yes, sir.
So, this point, again I enumerate what Dr. Shiva has mentioned about the retrograde approach. That's a very important point he has mentioned. The reason is, the surgeon may not have gone far anteriorly. He may not have given fibrosis far anteriorly, and you can pick up the nerve easily and trace retrograde. That is the idea behind it. Because in the area where the surgeon has already entered, it's difficult to get the nerve so easily. So that is a very important message for everyone. Dr. Shiva, your points are so amazing, important. 8,000 people logged in right now.
Wow, that's great.
And you have been so instrumental in each and every point. Now, lastly, before I go to the next case, what is the next one?
Sir, I have a doubt. What about this adequate parotidectomy that you had mentioned? Can you elaborate something more about it?
Adequate parotidectomy is that you raise your flap like how you would raise for a superficial parotidectomy. You identify the trunk like how you would identify. And you would probably, depending on the location of the nerve, let's say it's located in the tail of the parotid, you just trace your lower branch of your facial nerve and then round it off with one of the branches, let's say the lower buccal, and then you don't have to go to the upper branch at all.
Okay.
So you understand. So that is what adequate parotidectomy is. So that's done mostly for benign tumors like Warden's tumor or a pleomorphic adenoma that might be located in the lower pole. So that again, you cannot do it for all cases, but for select cases, which is benign.
Okay.
Satish, you please tell us how you do the retrograde dissection, because all the nerves are visible.
See, I tell you, we have discussed several times in the facial nerve course as well. Deepak, You can go to the marginal branch, you can go to the buccal branch, you can go to the zygomatic and come retrograde from the virgin area to the operated area where the identification and following the nerve is difficult. That is what Dr. Shiva is saying, and that's an amazing thinking in the particularly in the revision situation. In the primary situation, we do that retrograde only when the tumor is centered right on the main trunk here or towards the mastoid. So in that situation, we come from anteriorly because the identification of the trunk is little difficult, as you may have to go across the tumor. That are the two indications we use. Now coming to the final picture. For everyone, the landmarks again, I'll re-enumerate. See, this is my tragal pointer here. Can you see?
Yes, sir.
1 centimeter below and 1 centimeter deep is the nerve. And this is where the the digestic is attaching. See, just above, this is the digestic which is attached to the mastoid process here. Just above and deep to the anterior border of the digestic is the facial nerve. These are the two landmarks. This is your posterior division of the retromandibular, this thing, greater auricular nerve. Then your facial nerve main branches. This is the retromandibular vein. This is the cervical branch going. This is the marginal mandibular. These are the two lower buccal branches and a lot of intercommunications. See this going and intact. Now superior division. See, this is the frontal branch going with lot of numerous divisions of the frontal branch as it ascends over the zygomatic arch. It becomes more and more superficial. This is important. If you go above the level of the zygomatic arch, it comes to the level of the temporoparietal fascia. This is more important in a subtemporal skull base approach we do. Here it is not so important to go above that. Then your zygomatic main branch that you have to preserve going to the orbicularis there. And then the upper buccal branch I have sacrificed, and see how radical I have been here in this particular region. That is the masseter, and I stayed, over being overconscious, over radical in this region, sacrificing the upper buccal branch. That is the only thing I have done. Now what will happen to the upper buccal branch? See this. Since I have preserved the lower buccal, all lower buccal branches, these buccal branches, as you go anteriorly, they have a plexus here above the zygomaticus major muscle, where more than 50 numerous filamental branches join together to form a plexus above the zygomaticus major. And whatever upper buccal branch loss you have given here, that is automatically recovered because of numerous interconnections. We have seen, observed in many of these patients, I have shown in cadaveric dissection several times. And this is how I don't mind resecting this branch for the oncological safety.
Satish,
Anything?
just for the sake of all, just in a revision case, you said retrograde dissection. So what steps you do after while raising the flap? Also, there is risk of damaging the facial nerve.
Yes, Dr. Shiva has already mentioned the invaluable role of nerve monitor. Number one, for the identification. Sometimes identification is difficult. Or more than that, in revision, there is a lot of fibrosis, lot of traction on the nerve when you try to dissect around it, and your nerve monitor will warn you every time that your nerve is under traction. You have to stop, and that warning is so important from the nerve monitor. Dr. Shiva, you must be doing most of the revisions in being in the Premier Institute, Tata. And what is your experience in the revision cases? How often you are able to preserve a functioning cranial nerve? And what are your tips to prevent facial nerve injury?
After raising the flap, you identify the masseter muscle or the buccinator. What are the steps? You please tell us in that way.
Yeah, masseter is something you don't need to look at. While raising the flap, if you go anterior to the parotid on the masseter, it's a disaster, I tell you. You will end up all these branches running anteriorly beyond the parotid are going on the masseter. If you look at the masseter, there is nothing to prevent injury to these nerves. So that is a very important point. That's why I've included in the flap raising. That is so important.
So the one way of identifying the nerve in a retrograde, in a redo case, that is, in a redo case, is that many times they are high grade. You probably will have to do a section, or at least you're going to go into your 1B area or in the level 2 area. So one way to do is to do it like a SND, just look into the level 1B, identify the submandibular gland, just go above, then you identify the marginal mandibular nerve as you would often do it in a neck dissection, and then trace it posteriorly.
Yes.
That is one way to go about it. If you have a nerve monitor, then again, you can use the nerve monitor at each step whenever you're doubtful that you're having some tissue, which is neural tissue in your, which you're going to cut. You always use the nerve monitor, touch the tissue, look for an activity, no activity, then cut. So it's a step-by-step approach that way.
And someone was asking about that nerve monitor used by the anesthetist. What we do, we just use that needle, and they use for brachial block. Then we just use that needle and put on the nerve area, and we see the twitching over the face.
Yeah, usually for the parotid also it's like that. So you
same.
The electrodes in the the mental area and in the forehead area, and the angular. So you put electrodes in electrodes in 4 areas for the representation of all these branches, and then which is connected to the nerve monitor, like how you would connect it for an for a thyroid intraoperative nerve monitoring. So it's essentially the same.
So will you combine the level 2 neck dissection?
See, this patient I had seen on imaging was absolutely clear at the level 2, and looking at the, mucoepidermoid carcinoma, the low grade. Dr. Shiva had already mentioned it is better to take lower level 2 once you are going into the neck. Yes. I could take, but what I believe, there was nothing in the lower pole and nothing towards the level 2, so I didn't take, but there is no harm in taking, I would say. No harm in.
What do you do for cosmetic, to prevent the cosmetic depression in large tumors that you resect?
Yes, so many a times.
Abdominal fat, you rotate
Yes, there are many ways. In a small defect, I can rotate the sternomastoid antegrade up. I can bring in the platysma also. I can bring in the temporoparietal fascia and a part of the muscle as well. Or you can put in free fat as well. Many things you can do.
Which works better in your hands? What do you prefer?
Free fat. It works very well. Why to unnecessarily, rotate the muscles? Number 2, coming back to the previous question, had this been still our frozen section report is awaited. Had this been a known high-grade carcinoma, not only level 2, I would do at least a selective dissection of level 2 and 3.
Yeah. So that's fair enough. So any elective neck dissection in a parotid is one of the indications is high grade or a T3 T4 tumor
or T4 yes sir.
Clinical radiologically suspicious node. So even T3, so T3 T4 high grade, clinical radiologically suspicious node, you would end up doing an SND.
The only negative point I found in this patient, the way it was adhered to the masseter, it I would say as a focal extraglandular extension, and this is only negative point in this low grade mucoepidermoid carcinoma. Otherwise it is all favorable tumor as far as the resection and everything was concerned.
So probably that is hinting towards some sort of an the grade may not be low, it may be something.
Yes, yeah. So I'm awaiting the frozen report. And in the meantime, our next case was already taken.
Yes, sir. Before you move on to the next question, next case, there have been few questions on the Frey syndrome. How will you how will you treat if there is Frey?
Okay, Frey syndrome is a difficult to treat. I think in the easier to prevent. Number 1. Number 2, lot of anticholinergic local ointment and all those things are initially tried to cover up. But mostly, once it is a classical phrase, it is better to open up. We have done. Better to open the wound, rotate the temporoparietal fascia and interpose between the tumor bed and the skin. That's it. That is the final answer. To segregate the nerve endings going to the skin, going to the dermis. That is one and only final answer. Lot of people do tympanic neurectomy because ultimately the stimulus is going through the Jacobson's nerve to the parotid. To the postganglionic fibers to the parotid are going to the Jacobson's nerve. A lot of people are doing transcanal tympanic neurectomy as well, and it works. A lot of people are giving botulinum toxin, so many things. But best is, if it happens to occur, confirmed by the starch iodine test. If it is classical, interpose some fascia and get away forever, rather than doing this monkey business of some or other thing. Something works for some months and again the patient comes back, and it is going to give problems later on.
Okay.
about fistula? How you manage the fistula? You develop later on. after
Fistula mostly conservative by means of pressure dressings. Sometimes nowadays what we are doing, your parotid fistulas are not uncommon. So what we have been doing now, injecting hot hypertonic saline to induce fibrosis. They are easier to do. That is simple thing. And nowadays we have been using the platelet-rich fibrin, to induce fibrosis at that place, and that works well. But most of the time, where the pressure dressings works, you can ask the patient to avoid more of sore things to stimulate the residual parotid and all that, and it settles down. It's no longer a long-lasting problem.
And if the patient has to receive radiotherapy, that will take care of it.
Yeah, radiotherapy itself will take care of it. The patient. Dr. Shiva, can I ask one thing?
Yeah.
If you have not done elective neck dissection,
Yeah.
and you have not done elective neck dissection, and your tumor turns out to be a high grade with intraparotid lymph nodes positive, would you go into the neck and dissect it, or would you irradiate with the primary?
See, that's why the policy in our hospital is to do a level 2 sampling. Now, with the level 2 sampling, I mean, of course, you would, again, the same question comes as to whether you have the facility for frozen or not. So to be safer, we do a level 2 sampling and then move accordingly. So if you don't have a frozen, if it is anywhere intermediate to high grade, I would recommend a level 1 to 3 neck dissection. That's because for a parotid, if it is intermediate to high grade, radiotherapy will not be able to take care of the nodal metastasis. You must understand that the parotid tumors are radio resistant. What is more effective for parotid tumors are neutron beam radiotherapy.
Okay.
Whereas what we give is then photon or electron based radiotherapy, which will be a mop-up kind of to take care of a microscopic disease that is left behind, but not for a disease which is grossly left behind. It's not going to work. So a neck dissection will be better. So you have to plan that pre-operatively just to get things right as often as possible.
Okay.
Paramita.
And sir, one more last question. Yes, sir.
We are moving to the next major case. Is a large parapharyngeal vagal schwannoma.
Yes, sir.
With an intact vagal nerve function.
Yes, sir. Yes, sir.
That is our next case, and I have already washed up.
Yes, sir.
Before I go to the vagal schwannoma, the small case, the stapes is ready, the flap is raised, the overhang is curated. So I will spend 5 minutes there and go straight away to the vagal schwannoma.
Okay, sir.
So I would like Dr. Shiva, if you can stay for the vagal schwannoma case, if he can spare some time. It's up to you, boss.
Yeah, sure. I'll just take a break in between and then come back.
Okay, great.
You. And thank you again.
Last question. Yes. What about pressure dressing on the drain in these cases? Do you...
So the other most important point actually, even though it's the last point, is we don't keep a Romavac drain. Please do not keep a Romavac drain. Because if you put it on the nerves that you've dissected, and then you put a Romavac, the constant negative pressure also can contribute to the post-op palsy.
Yes.
So we just put a glove drain.
Negative pressure gives you a bad cosmetic depression.
Okay. Yeah. So then glove drain.
Just the glove drain, and then dressing the glove drain can come off in 48 hours max, and then it. Yeah, and again, that is when you don't do a neck dissection. Now, if you do end up doing a level 1 to 3, you will have to put a drain and see to that the drain does not go into your parotid region and stays only in the neck.
Okay.
And your parotid region, you can maybe have a couple of switches loose so that you can just drain it out.
Okay, sir.
Or this drain can take care. But then the most important point is the drain shouldn't be sitting on your nerve branches that you've dissected.
Yes, sir. Yes.
Okay, for the audience, I am going to the stapes for 5-10 minutes. Then the vagal schwannoma is ready. And after the vagal schwannoma, we have cases lined up, like 2 cases of CSF otoria and a glomus tympanicum before we move on to the other.
Yes, sir.
I am ready with the stapes now.
Okay, sir.
And hello?
Yes, sir.
I have already washed up, so I am not showing you the scan of this patient. Our colleague Dr. Ayub has already opened up. He has raised the flap, curated, and let me see what is there inside.
Yes.
Can you give the microscopic picture there? Chalu? Hello, are you getting microscopic picture?
Yes, sir. Yes, we are getting.
इससे बड़ा दे.
So in the previous case from Dr.
Sakshan.
Parekh madam from sir, we
बड़ा दे.
learned a lot. Isn't it? It was a great discussion on parotidectomy.
Yeah, it's a, I'm so grateful to them for enlightening us. And the Dr. Shiva was amazing, the kind of knowledge he has, the kind of commitment and the surgical hand, it's all amazing. And there is never a no from his side for any, academic work. That's a great gesture.
One doctor joined shadow from Australia. He just messaged me. He did one gastric neuroma last week. After a long time, he did.
Oh, great.
I did it, and then it took a lot of time, 40 hours, but I think it was a good thing.
Now, are you getting the microscopic picture?
Yes, sir.
Now see the thick posterior crust.
So we can't see, sir, to focus.
Okay, पकड़ना इसको. Yeah, I will change the focus.
The previous case was the microscope was different. I think.
Is the picture better? Yeah, different microscope. The same vario. We have two vario. Okay, we have already checked the mobility. See the malleus, the incus. So good. And the stapes is fixed. See the foot plate. Completely fixed. So what I want to show again, it's like video game. My first would be to disarticulate the joint. See the joint? See, keep an eye where the joint is.
Yes, sir.
Joint space is medial there. See this? If we go with a false impression laterally, you can injure the lenticular process. That is something you are not supposed to be. See, this way, not showing the flap elevation in the every case. I told you we organized an event in Jaipur in 2013, the Stapes Carnival with Ashish and Ashim. We did 50 stapes in 2 days. We had a great discussion with these two people. See now, the joint is disarticulated. Can you see?
Yes.
The next is, I will take the, laser now. पकड़ना पकड़ यार जोर से. हाँ. Great. Yes, this is my laser beam, and I will first vaporize. Next case is already induced, ready, and that's an interesting one, vagal schwannoma. See this?
So this case in a different manner or the same manner?
Ready करना. Same parameter. There are posterior crest. You see how thick it is.
Yes.
These are ideal cases for the laser. The reason is,
This if you giving just to suck the vapors or to
yes, to suck the vapors, And now my posterior crest is there in front of me. See this? To additional cover. The beauty of the CO2 laser is it is absorbed by the water. Now, the next is to vaporize the.
What is the setting of the laser?
For this 8, the power is 8 watts. For the tendon, it was 4 watts. For the posterior crest, it is 8 watts. See now, it is being hollowed out.
And the beam diameter?
Beam diameter was 0.3. And now the anterior fractured, it is being fragile. and now I am taking it out forceps. Can you see very clear?
Yes, sir. So centralized, sir. Yes.
This is one of a very common surgery we are doing at our, at our center, the otosclerosis surgeries. See now the remaining posterior crus. And now your foot plate is completely in front of you. Okay? Now give me the pakadna. Give me the measuring gauge. You can remove if it is bothering you. A stump of the posterior crus, if it is not bothering you, it is not meant. Yes. Why to unnecessary? It was 4.5, little longer. Yes, this is fine, absolutely fine. Clarice, Savachar. 4.25, but it's variable. I have seen one patient requiring, 5. One patient requiring 3.75. It's like, you never know. 0.5. थोड़ा बड़ा लगा इस एक साइड. Now is the time for shot.
Yes.
Fenestra.
Yes, sir.
And ready? Let me focus. The focal length of the microscope and the micro manipulator should match. Yeah, give me, see now, with my 20-watt shot, it didn't go completely through. I can see the glimpse of the bone. Now what I can do, I am not going to fire it again. Can you see now?
Yes.
It is already thinned out. If I try to fire more, I can end up giving more energy to the labyrinth, and that will be a disaster. See that? I could easily, do it with my... Now, give me. See now? And finally, I am putting my piston now. So 5 to 10 minutes. And the simplest part is the piston now. Because this piston doesn't need any crimping. With laser, you have a sense of security that you are not going to mobilize anything. See how can you improve your outcome simply. See this? See, this movement is very important. In one go, I left my piston in the fenestra. Can you see?
Yes, sir.
At the same time, the loop of the piston taking on the incus. At the same time, at the right place, roughly 0.5 millimeter above the lenticular process. Can you see?
Yes, sir.
And then last thing left is, yes, that's it. Can you see?
Yes, sir. Perfect.
So that's why I call it always like a video game.
Yes.
See this? Very well in fenestra. Absolutely atraumatic. And I will just use a micro drop of blood or the fenestra. If your piston is not overlong, believe me, nothing will happen. All post-operative issues, major post-operative issues are related to an overlong piston.
It throws some light on round window otosclerosis. In how many of your cases you have seen round window otosclerosis?
Not common, but yes, round window or cochlear otosclerosis, for us now, a lot of cases, which require cochlear implant. You have to do cochlear implant with all difficulties and all. It can happen, you can get, you have to be careful. So all those patients having a mixed hearing loss, you have to be careful. You must assess on radiology properly, See this? See the blood
Yes, sir.
in the oval window, and since the vestibule is full of perilin,
Yes.
with the more pressure inside the vestibule than the pressure in the middle ear, this blood is never going to trickle into it.
Yes.
That's it. Are you band kar do na?
So Dr. Girish is asking from Vilaikan, 1 is to 8 lakh xylochem adrenaline we use in stapes surgery in the ESC for better hemostasis.
We use 1:2 lakhs.
Okay, for better hemostasis, asking can we use 1 is to 8 lakhs.
I generally, avoid using
I think he's gone offline.
Yeah, I think there is some issue with his internet.
Okay.
Dr. Ramandeep is back. Dr. Ramandeep, sir, you're back?
Yeah, I'm here.
Okay.
Yeah, Ramdeep, what is your opinion about that? Why I am asking this question? Sometimes after putting piston and even the mobility and everything is okay, when you see in the post-operative period, the patient may have persistent conductive hearing loss. What may be the other causes? In spite of right assembly, everything is right.
See, assembly is one part, then the patient can easily have a third window phenomenon.
Yes, so you have to rule out all this on scanning first.
We scan.
So,
a lot of them.
and you are asking about the frozen report. Is it come?
We are waiting.
Okay.
We have not closed that case.
So Dr. Jeevan Vedi, okay. Yes, sir.
Yeah, we are ready with the imaging of the next case.
Okay, sir.
That is vagal schwannoma, and why I will tell you why it is vagal schwannoma for us. We don't have histopathological evidence,
okay,
but the radiological evidence which I want to share with you. And we have madam here, Farida madam must, the madam is a head and neck surgeon by and large from heart. And madam must have been doing a lot of parapharyngeal tumors. In head and neck, parapharyngeal have their own place. Vagal schwannoma is not so common. Schwannomas are very common everywhere. We have seen the vestibular schwannoma surgery, that is acoustic neuroma, we call it, in the CP angle. Then we have schwannomas along the 7th nerve, facial nerve schwannoma. Schwannoma can occur anywhere along any nerve. They involve more often the sensory nerve. One sheath of the myelin from the sensory nerves, and this particular schwannoma, why it is schwannoma first of all, and why it is vagus, and this answer can be given by one and only thing, MRI. Otherwise there is no way pre-operatively to distinguish this from any other tumor. So there are a lot of questions why it is not. Are you getting the picture?
Yes, sir.
MRI picture?
Yes, sir.
So the questions are why it is not vagal paraganglioma. We had a vagal paraganglioma last week. Why it is vagal schwannoma, number one. Then if it is a schwannoma, why not other nerve schwannoma? There are so many nerves in the parapharyngeal space. Why not sympathetic nerve schwannoma? Why vagal nerve schwannoma? So all these answers can be best given by MRI. Is Dr. Shiva logged in again?
He is logged in. Yeah, he is logged in. Dr. Shiva, sir, are you there?
So, number one.
Satish, besides imaging, can we make the difference whether it is sympathetic trunk schwannoma or vagal nerve schwannoma?
There is no way other than MRI. As simple as that.
Horner syndrome is not there when we arrive.
Very rare. Very rare. If there is a pre-operative Horner syndrome, this could be a sympathetic nerve schwannoma.
But it is not always there.
Not always. In very few patients, very few percentage of patients, Sometimes pre-operative vagal palsy could be there. But again in very few percentage of, because these schwannomas, they arise from the epineurium of some nerve fiber. And then they keep on displacing the other fiber. That's how they grow. And yet the facial nerve function is preserved. Even if the few percentage of the vagal nerve fibers are working, clinically you may not appreciate a clinical vagal nerve palsy. That is how somehow we have seen more than 70% of the nerve is involved by the tumor with displaying all fibers, yet the clinically nerve is normal. So clinically there is no definite way of, distinguishing between the vagal and the sympathetic nerve fibroma. So my coming to the MRI, number one question, why it is schwannoma, why not paraganglioma? See this is T2 weighted picture. On paraganglioma we saw last time, paraganglioma is a vascular tumor having flow voids, having a classical salt and paper appearance because of the vessels. Salt means white dots, slow flowing vessels, and paper means large black hollowing dots, bigger dots because of the large vessels. And here in schwannoma, that is conspicuously absent. That clearly distinguishes the schwannoma from the paraganglioma, number one. Okay? Now here see on the T2 weighted, what you will find instead of that, there could be some internal necrosis because of the large size, hypoxia, necrosis, cystic changes in the schwannoma, giving them heterogeneous appearance. That is classical of schwannoma, for any schwannoma. So that is classically a picture of schwannoma, number one. Number two, white cannot be a other nerve schwannoma. Why I am saying vagal? Now see, in the parapharyngeal space, how the structures are oriented. Anteriorly is the carotid artery, and the laterally, anteriorly and medially the carotid artery, which divides into external and internal, and laterally is the internal jugular vein. And deep to that, posteriorly, medially, deep to the carotid artery is the sympathetic chain, and between the carotid and the jugular deeper is the vagus. Okay? So, if a schwannoma arises from vagus, would displace these vessels anteriorly. What my point? And since it is between the vagus and the carotid, you will find classical displacement of the carotids medially and the vagus laterally, and all anterior to the tumor. Now see, in this tumor, see both the external and internal carotid anteriorly, and the jugular is completely compressed. I will show on the coronal. The jugular is completely compressed. Let me put up the coronal together. See this. This is your schwannoma, where the jugular is going and completely compressed laterally, and the carotid, you see, is medially. See here, the external carotid and the internal carotid and the jugular is collapsed there, and all are displaced anteriorly. That means the lesion is coming from behind the vessels, number one. Dr. Shiva has come back. Hello. Boss.
Yeah, hi.
So this is classically a vagal schwannoma, what I was discussing. It's not a vagal paraganglioma. Last week we did a vagal paraganglioma, and that had a classical flow voids. And since there are no flow voids in the parapharyngeal space, with the carotids both displaced anteriorly and the jugular displaced laterally, it cannot be anything else than vagal schwannoma, number one. To rule out a sympathetic nerve schwannoma, what would have been the picture had this been a sympathetic schwannoma? As I mentioned, the sympathetics are just behind the carotid artery in the neck. And as they ascend towards the bifurcation, they come exactly behind the carotid bifurcation. In the lower neck, they are little medial to the carotid and deeper. So what happens if a schwannoma arises from the carotid? It will displace both the carotid and the jugular laterally, number one. And if the schwannoma is at higher up at the level of the bifurcation, you will have a classical splaying of the internal and external carotid, like you see in carotid body tumor. That is classically a radiological sign of a vagal nerve, the sympathetic nerve schwannoma. And this vagal nerve schwannoma is classically something different than the sympathetic schwannoma. Now, we have this, since we had MRI, so we got the MR angiogram as well. Now see, this is the carotid artery here. This is the carotid artery. This is the tumor. The carotid has been displaced medially anteriorly and medially. Had this been a sympathetic schwannoma, both carotid and jugular would have displaced laterally, never medially. Number one. Then as you go up, this is the internal and external carotid, and as you go up, see, I am going up at the level of bifurcation, and you see a classical splaying of the internal and external carotid artery, which you, in a case of schwannoma looking like carotid body tumor, which has a flow void which schwannoma doesn't have, is a classical thing you can find in a sympathetic, which you will never find in the vagal schwannoma. Now, let me reconstruct this, this MR angiogram. This gives you a very good insight of the vessel supplying it. We believe in CT angiogram most of the time, like I showed in the JNA case today. See this. See this, carotid is displaced medially. That is classically seen in a vagal schwannoma. Had this been a sympathetic, it would have been displaced laterally. For the simplest understanding, you can assume like this. Anteriorly and medially, that is classical of a vagal schwannoma. There are no flow voids. See this, even on the MR angiogram, you remember last time's vagal schwannoma, the image in the kind of flow voids that patient vagal schwannoma has, you can clearly, distinctly, find the appearance of these two lesions. Any questions?
Oh, very well said, very well illustrated.
So now, yes?
How is the FNAC
Volume.
there?
Pardon?
FNAC, role of FNAC over here.
The FNAC can pick up schwannoma, yes, very well. And since your radiology is the final answer, with a well-circumscribed lesion, see this, such a well-circumscribed benign lesion displacing the vessels anteriorly with a capsule around, it cannot be anything else than a schwannoma, whatever investigation besides that you get done. इसका आ गया हमारे अच्छी से फोटो लिया नया वाला Okay, any other question?
Yeah, you start the case, I think.
Now, the important thing is whether we can save the vagus nerve or not. I will tell you, this is the hallmark of the technique we follow. Majority of the people don't look at the vagal nerve function. Believe me, this is the real truth. And once you remove the schwannoma, I told you schwannoma arises from the epineurium of a one fiber and displaces the sheath, the other fibers completely. And when you remove all those splaying of the nerve fibers over the tumor all around, it's difficult to save them. Here the technique which I am going to show you, microscopically, you can find those nerve fibers. And splitting between the nerve fibers and doing a subcapsular dissection, 80% of the time, they are able to save the nerve function. Whatever big schwannoma it is, this is huge one, still we can. Now the third thing you need to see on imaging is the upper extent. See the upper extent on radiology, on the coronal. How far it is from the, how far it is from the skull base, you have to see yourself on imaging. See this. This is the upper limit of the schwannoma and this is skull base. Let me measure how it is. It is roughly over 3 centimeters, you can say, away from the skull base, and that is good enough. You can remove from below. Most of the time, the maneuver, like I have shown several times in the carotid body tumor in these webinars, you can increase your exposure by means of dividing the digastric. Then go up. If you need further more exposure, you can divide the styloid process and the muscles attached to it and the stylomandibular ligament, and it opens up the gateway. Many people try to, bring in the mandibulotomy in the higher up tumors. Believe me, for schwannomas, we have never done. And you don't need to. Maximum at the max, if you are not able to get above the tumor to control the vessels, what you can do, mandibular subluxation, or you can do a VRO, vertebral ramus osteotomy at the most. But for this schwannoma, now we have stopped doing all this. What we are doing is, if it is going too high up, I will go inside the tumor in size, use my microdebrider, debulk it, and it will fall down. And then I can get over the tumor and remove with my finger. You never have to do a mandibulotomy for such schwannomas. We have done a couple of times that. So there are many ways to protect the function, to prevent the morbidity in these tumors. Any questions? Any suggestions?
I can understand regarding the microdebrider. What do you do with the microdebrider?
I would incise at one place, go inside with the microdebrider and keep debriding, hollowing it out from inside. Hollowing it out, staying intracapsular, and it will fall down. It will leave above from the skull base if it has gone up to, and you can go above, get above the lesion with your finger and get it down without doing a mandibulotomy.
Saving any fibers, right? Then you won't be saving any nerve fibers.
No, we are going inside the lesion, inside the capsule. Okay. All fibers are outside the capsule, you know.
Okay.
Yeah.
So sometimes a schwannoma can be cystic. So will your approach be different?
No, same. Okay. Sometimes, almost always, these schwannomas have internal cystic and necrotic components as they enlarge. This tumor also has a cystic and necrotic component. You see the heterogeneity inside. See this? Heterogeneity. That's the nature of the schwannoma, any schwannoma. You saw in the last week when I demonstrated the vestibular schwannoma at the CP angle, how big the cysts were. There were two large cysts. So that's the nature of the schwannomas very commonly.
Yeah.
Okay, sure.
So, Dr. Satish Jain, if I can just add one point.
Yes, please.
Yeah. So, you rightly said that for a vagal schwannoma, you might not have to do a mandibulotomy most of the times. But the decision for that would actually depend on the extent of tumor. Of course, the methods you've described could be alternatives to that. But for the beginners who are just looking at it as to when you will have to do a mandibulotomy or not, would be depending on the extent of the upper, the extent of the tumor which is going up towards the skull base. And the other important thing while looking at imaging, as what Dr. Satish Jain rightly said, is that look at the distance from the skull base. Most importantly, look at the stump that is available for you. In case of an event, you should have some amount of stump of the carotid artery from the skull base. In case you end up with an event, you should have the end in control. So that is most important. And then that will actually decide as to whether you will do a mandibulotomy or not.
Yes, yes. So,
what will be the stump which will be safest for you, Dr. Shiva?
At least 1 centimeter of stump should be available for us.
Below the skull base.
From the skull base, that is. From the skull base.
And the same for schwannoma and the carotid body tumor or different?
For carotid body tumor, usually, carotid body tumor that is going higher up, so much higher up, it will probably be a Chamblin 3 most of the time.
Yes, yes.
So in which case, you're better off to do a mandibulotomy because you will have that control. Same thing for the paragangliomas as well. If you're planning to resect the internal carotid artery and if you're planning to do reconstruction of the vessel, especially, so you need to have that stump.
Yes, your point is valid. But what we do, instead of doing a major parotidectomy, what we are doing is a vertical ramus osteotomy. It's a very simple procedure. What you can do, from the mandibular notch to the angle of mandible, we divide the mandible vertically. Behind would be the condyle of the mandible and the rest of the mandible anteriorly. Agreed. Entire mandible can be rotated anteriorly and you just put at 2 plates. The rest of the mandible need not to be disturbed. No neurovascular structure is, affected. Right, rather than doing a mandibulotomy where you can sever a lot of nerves, the mental nerve, the inferior alveolar and many things.
So mandibulotomy, you don't have to serve the mental nerve. If you do a paramedian mandibulotomy.
Paramedian, you can still save.
So the thing is that with the approach that you're mentioning, maxillofacial surgeons could be a bit unhappy.
We are all just simple approach.
Yeah, agreed.
Just we have to
suit you. That might suit you. Agreed. I'm not challenging that. But what I'm trying to say for the audience is that when you cut at the angle, and when you make it, angle is the one which is the most unstable part, which is more prone for pathological fracture. That's because when we eat and all that, so that you have to play it really well. And as for the maxillofacial technique, intermaxillary wiring and all will be required in the, for some time in the post-operative period. That set apart, you can choose your method, but paramedian mandibulotomy is a safe technique where you don't have to damage any of the nerves and it can be very effectively done with acceptable morbidity.
Yeah,
So
yeah, paramedian.
the point I'm trying to make is that you don't have to shy away from a mandibulotomy, because having a vascular, catastrophe is much worse than doing a mandibulotomy.
Yeah,
So be safe
expert.
for your patient is what I'm trying to say.
Absolutely important point. This is a take-home message for everyone, not to compromise with the exposure. Particularly lesions, vascular lesions, the carotid is affected. You may have to reconstruct or repair the carotid. You cannot take a chance of, compromising with the exposure. And this is what Dr. Shiva has rightly said, never compromise. If you can do a good paramedian mandibulotomy, nothing like it. Out of all mandibulotomy described, paramedian is best function preserving, and you can get an amazing exposure. You can go right up to the skull base with that.
Okay.
So, any other questions? As I am moving to the case now, the case is ready. And what I am looking at the CSF case. Yes. So, we can discuss anything. Meantime, I wash up.
Yes, sir.
Anybody has any question regarding previous cases done so far, you can ask. Dr. Shiva is here. Madam Farida Wadi is here. Dr. Ramandeep is here.
Any such lesions arising from the phrenic nerve? Dr. Fazail from Pakistan is asking.
I've not come across one rising from the phrenic nerve, but the vagal schwannomas lower down in the neck is pretty much a known phenomenon. That is common.
Okay.
Phrenic I have not come across or heard in literature.
Okay.
Read in literature.
I can see Dr. Sethi on screen.
So what
Welcome, sir.
What were the complaints of this patient?
This patient she presented with cough. She has a funny finding. Most of the schwannoma, even if they grow larger, they remain asymptomatic. The symptoms come when the nerve is severely affected or the compression to the surrounding, and majority of them come either with dyspnea, dysphagia, all that. This patient presented with a chronic cough. She went to all physicians and all, and when we found such a big tumor, we went to the literature, and this is one of the presentations because of the irritation, as it supplies the airway as well. This is how we picked up this. We couldn't get the electroneuronography of this patient. Generally, we get when the nerves are involved, yet clinically normal, like I mentioned in the patient now earlier, in the vestibular schwannoma as well, we get the pre-op electroneuronography to predict the likelihood of preservation of the nerve. If we have a pre-op electroneuronography showing less than 50% response, yet clinically functioning normal now, it is difficult to preserve the function. The moment you handle the nerve, it is going to go.
Okay.
So this is like that. So this patient is now presented. Our goal is, we have explained her about the vagal symptoms. Majority of the vagal resection after the schwannomas, these patients is still showing the normal nerve clinically, yet they have a ability to withstand vagal resection because of the long-standing compression of the nerve fibers. Their ability to compensate becomes better. So in these patients, even if you see the long-term results, even after the vagal resection, majority of the patients improve well, compensate well, and they have hardly any long-term aspiration and other issues. But with the keeping the capsule intact, the technique which I am going to show, majority of the patient, in our series 80%, still we can preserve the function. Leaving the capsule intact, since they are slow growing tumors, they are rarely going to recur back. They have a slow growing, long natural history, and in the literature with the encapsulation technique, patients followed up to 20 years with hardly any recurrence. That cannot be better safety than this procedure.
Okay.
Because preservation of the vagal function is the most important. So now in the surgery, the most important part is the exposure. Like I have always shown in the series of carotid body and the vagal paragangliomas, I have already shown. The first and the foremost thing is the exposure. And the first and the foremost nerve to be protected is the hypoglossal. Hypoglossal run lateral to it, and we have to retract and preserve it. We have preserved all hypoglossal nerves so far in this series of webinars.
in 3 or 4 carotid body and vagal paragangliomas we have demonstrated. Then the second thing, to gain superior exposure, I will definitely divide the digastric, and if I find reaching problem to the upper end, I will not think twice, dividing the styloid process and the entire styloid complex, including muscle and the stylomandibular ligament, and then I'll have an open gateway to the skull base. Majority of the times, I would say in such phenomena, 99% of the time you don't have to go anything beyond this for the exposure when you divide the styloid complex. That opens up the gateway.
The other point I would add is that, as Dr. Satish Jain rightly said, hypoglossal nerve needs to be saved for better post-op recovery of the patient. The superior laryngeal nerve as well, because the area where you are working there, it's very important to also identify the superior laryngeal nerve, dissect it and save it. Otherwise, the patient might have constant aspiration in the post-op and various other problems.
Dr. Shiva,
Yeah.
I have a habit of doing neck dissection also in the microscope.
Great. Whatever suits you.
Suturing, my assistants do. So,
Meaning to say, whatever method is comfortable for the surgeon, they have to follow that.
yes. Even in the last of the webinars, I demonstrated one SOSD, under microscope. See, it's a good teaching tool, number one. Number two, it cannot be anyway, you find value or not is a different issue. It cannot be inferior to the open eye, naked eye. It cannot be inferior to it. That's it.
Sir,
And
if
see this, even this initial skin incision I am giving under microscope. The only disadvantage is your field of vision become narrow under magnification, So I can mobilize, I have a habit of demonstrating under microscope, so I can do that. Yes, you are making any point?
Sir, if we can take few questions from 1-2 questions from the previous surgery, is that okay?
See, this is platisma. Yes, Paramita, what you are saying?
No, sir, you carry on. So there were few questions from the previous surgery, so can we take it
Yes,
now
yes, please.
So Dr. Girish is asking, does keeping free fat in the parotid lodge defect will help prevent facial nerve injury in the revision surgery by preventing plastering of facial nerve and skin
No. The
flap?
fat is the best tissue, Okay, let me tell you why I said fat. Why not muscle and all? It's not about the closure, I tell you. In the post-operative follow-up, that's why I am always against the muscle flaps in obliteration. Try to avoid as much as possible. The reason is, particularly in tumors, in the parotid lobe, if I obliterate with the fat and I have to follow up radiologically, in the fat suppressed imaging, I can always see the recurrence so easily, Got my point? If I use the muscles variably enhance, and it is so difficult to distinguish between a recurrence or the muscle. And that is so frustrating. That's why I always mention, use the fat for obliteration, because you can get the fat suppressed imaging and you can have a very good picture, if there is a recurrence. That is the major reason behind it. Second is, anytime you re-explore, the fat you can easily remove rather than a muscle flap, with a lot of adhesions. Fat will not have that much of adhesion and you can remove it easily. Most easily, what you can remove is the fat.
Okay. Dr. Farida ma'am was saying something?
The contour is also good. With the fat, the facial contour also is much better than with the muscle.
Yes, you can use as many fat as you want according to the contour.
And I wanted to add a point to Dr. Shiva's advice regarding mandibulotomy. We used to do a lot of mandibulotomies for tumors we thought would not be, were closer to the skull base. But one of the complications we found initially was a salivary leak, if the closure was not meticulous. And then we found that, of course, you need not do a mandibulotomy for everything, Mandibulotomy approach is a beautiful approach. The tumor just pops out on your face. It's a beautiful approach to do, but then it's a bit closer, do the closer and all. So this method, if you could do it through the neck, I mean, it is much more convenient and with lesser complications. That's what I feel.
Definitely, ma'am. I mean, as much as possible, if you can avoid a mandibulotomy, nothing like it, because it definitely adds morbidity to your procedure.
No, but then, when you're doing so many mandibulotomies and mandibulectomies, you like to go in for a mandibulotomy.
Absolutely.
What the heck, yeah.
Yeah.
Love that approach also, but I think the cervical approach, as far as possible, is much more better.
Correct. But the point I was trying to drive home was that when necessary, don't shy away from a mandibulotomy. That's the point.
Yeah, that is important point. If required, don't think twice, never compromise with the exposure. That's why, Tata is the center, believe me, this is from my heart, where the evidence-based practice is prevalent. Completely pure evidence-based practice. I can say for one center, for sure, where this is something practiced routinely. It's not something that somebody likes something and is doing something. It is something never happens in Tata. Tata is pure evidence-based, and they've been organizing every year. The workshop, only and only the theme is evidence-based medicine, EBMs, and those are worth attending for everyone. Now, coming to the very important point, I always mention when I open the neck in this region about the marginal mandibular nerve. Like I demonstrated in the, all carotid body tumors, SOSD, submandibular gland resection, every time the identification and preservation of the marginal mandibular nerve, there are many ways, direct, indirect ways. Let me tell you the direct way. See this point, what I am showing, where my finger is, what is this point? Gonian. Gonian is the point you need to take into reference, and the marginal mandibular nerve is within 1 centimeter vicinity. Now see at this point, I raise my flap subplatysmal, and now see, I am elevating this tissue. Can you see something coming? Can you see something?
Yes, sir.
Yes, so simple. We always believe in positive identification of the nerve rather than so many maneuvers described. All indirect methods, this nerve can have a variable course. All indirect measures may not work. If you try to pull the vein up, this and that may not work always. Suction work. So the best is, dal artery, suction. Yes.
From where to where exactly you dissect this nerve?
I don't intend to go right into the parotid for that matter. This I am leaving it as an upper limit, We are not supposed to bother about, the course and dissection of this nerve right into the parotid. That is not needed. This nerve is left below and going deep into the parotid, which I am not going to go. This is going to be my upper limit as I am going to go along the margin of the mandible. Kahan hai pedal?
Point regarding the drain, what Dr. Shiva said, don't put Romovic drain.
In parotid, he is against the drain, Romovic negative pressure in the parotid.
But if you put that drain inferior to the posterior belly of digastric in a U-shaped manner, then there will not be any risk of facial nerve.
So what I was trying to say was, when you're done a neck dissection, you'll have to put a drain, but make sure that it doesn't go into the field of parotidectomy where your nerve is exposed, because the constant negative pressure might add to the post-op paresis.
Yes.
If you've done only a superficial parotidectomy, you can do away from, without a negative pressure drain, that is a Romovac. You can just put a glove drain, and in 2 days it will be out, and it's safer for the patient. So we have done away from using a Romovac drain for superficial parotidectomies, and we just put a.
The reason sometimes the soiling of the dressing is so much
But it
When
shouldn't
we-
be a problem if you can just do frequent dressing. It will take care of it, and it can. I mean, you just need to do appropriate dressing, and that's not a major problem. The main problem would be to save the nerve, I guess.
Yes, yes.
See now, this is just flap raising. I never say that you raise the flap under microscope, but you start doing it, you'll get used to the microscope so easily. So now we are going into the parapharyngeal space quickly. In next few minutes, we'll be right onto the lesion. And our next case is ready? Yes, and after that? Yes. So next case would be a glomus tympanicum. We have already demonstrated couple of glomus jugulars involving the carotid, the skull base and all that. So today would be the glomus tympanicum to add on to the variety. See, that's the retractor. See, that's the anterior border of the, that's the, can you see the internal jugular? Hello?
Yep.
Push
Yep.
anterolaterally. See this?
Yes, yes.
Anterojugular, internal jugular pushed anterolaterally. It's a treat to watch Dr. Shiva doing neck dissections. I have seen couple of times, and watching him operate is a real pleasure.
Thank you for those kind words.
It's really, I'm talking very honest. See this, all the vessels are pushed anteriorly and the tumor is deep to these vessels, what we saw on the scan. देखना क्या है, पकड़ लो. Now anteromedially पकड़ना. All these nerves which are veins which are engorged, I coagulate them. That's the submandibular gland, and here medially would be the carotid artery, and that too anteriorly placed. Uta. These are the nodes at the level 2. Tributary, छोटे. हाँ. Tight. So I'll quickly open up the plane to reach onto the tumor. I am right on the tumor, already on the tumor. Slowly opening up my, space.
Please orient again. So many people are there.
Okay. Because the field is narrow. Okay.
Yes.
This is inferior. This is superior. I am on the left side. So this is lateral. This is medial. This is superior. This is inferior. And superiorly, this is your marginal mandibular branch. Okay. Now a tumor is deeper here. I can feel this tumor. Laterally, this is the internal jugular. And at the medial end, you will find the carotid vessels, which I am going to show you very soon.
And Satish, you may have observed also that always you see these lymph node enlargement before the tumor.
These are all reactive, man.
Yes.
You're right. Veins engorged because the tumor size. These are all, related findings. And see where the carotid artery, you pull karna isko. See, here is your carotid artery.
Yes, sir.
I can show you. See this carotid? Can you see?
Yes. Yes, yes.
See this. चल देख के. That's the carotid which I would like to trace. The tumor is deep to these two critical structures.
So what are the chances of malignant transformation in these tumors?
Vagal schwannomas rarely.
The vagal schwannomas, the one thing is the malignant peripheral nerve sheath tumors. That's a different entity altogether. But the transformation of a vagal schwannoma into a malignant peripheral nerve sheath tumor is very, very rare. But then the rate of growth of the vagal schwannoma is like 1 mm per year.
1 to 3. Some are fast growing.
No, that in general the literature says is 1 mm for a vagal schwannoma. It's not going to be beyond that. That's the documented rate of growth.
Now see the tumor.
Okay.
And the most important structure, as Dr. Shiva has also mentioned, is the hypoglossal. Now see, we all know hypoglossal crosses the carotid vessels. See, this is the surface of the schwannoma. This is schwannoma and some vessels on the surface,
Yeah. So that is why it's very, very rare and uncommon for malignant transformation.
Retractor laga upar.
And that is why the philosophy for treating vagal schwannoma also is changing over the years. Like in this case, it's a symptomatic case, and that's why you are operating in this patient.
Otherwise, asymptomatic.
Yes,
most
asymptomatic
of the patients you can observe.
You can observe safely. You can observe safely. So you don't have to jump into a vagal schwannoma the moment you see it in an MRI.
Can we discuss something about carotid body tumor also here?
Yes.
So like suppose if a patient is having bilateral carotid body tumor, then which side you operate first and why?
I mentioned this, if you remember last time when I was showing the carotid body tumor, Deepak. For anyway, you asked, for first of all, if there are no cranial nerve symptoms so far, first you operate the side where you can preserve the cranial nerves better. You can preserve the carotid better. See the hypoglossal now, can you see?
Yes.
Yes, sir.
Hypoglossal crosses the carotid vessels, and that's how, see in all our carotid body, the first nerve we encounter was the hypoglossal.
Yes.
Jalo. So, first you operate on the side where you can preserve the function of the cranial nerves and the function of the carotid as well, much better, where you have a better chance of preserving. And once you have done it, like we have done a couple of times in bilateral tumors, after 7 days, we went to the other side and operated. If you have given any cranial nerve palsy, any injury to the carotid or any reconstruction you have done, then you cannot do on the other side. Better to avoid that.
So, Dr. Dalmia, the philosophy for treating bilateral, paragangliomas is evolving and it is changing over the time. So, surgery is not the answer all the time. It depends on case-to-case basis. And most importantly, in these patients, you'll have to do genetic counseling and search for any other paragangliomas that are there, in the body other than just in the neck, because bilateral is a very.
Will you do the imaging for that to rule out other areas?
Deepak, either you get the genetic testing like Dr. Shiva is saying, that is succinate dehydrogenase mutations, number 1, or
EMA levels.
that is succinate dehydrogenase mutations. Pakad le.
All these testings are available in India?
Yes.
Yeah, very much.
Or what you can do is a DOTA testing, that
DOTA,
picks.
DOTA
Yeah.
PET. They use the DOTA.
Yes.
That is one of the radio pharmaceutical. Radio
Yes.
pharmaceutical tagged.
Yeah, and there are a lot of advantages of it. Number one, I tell you, sometimes you may assume as a paraganglioma, and you are still in a fix whether it is paraganglioma or not. The DOTA testing will confirm, number one. Number two, it will pick up anywhere lesion anywhere else in the body at the same time. Number three, in the recurrences there's a big role. See the vagal nerve fiber. Can you see here on the capsule?
Yes.
No, this is not vagal nerve fiber. Sorry.
Descendants hypoglossal.
This is ANSA.
Yes.
It's coming from the hypoglossal. See this. Sorry.
Looks like that, but
yeah.
Yes.
Yeah, cut ANSA. Here I don't think twice before, cutting the ANSA away, and that is the carotid. I am trying to separate.
So the thing is that you need to counsel the patient and just see as to how you deal with it, because we have many times, quite often we have seen bilateral carotid body tumors with a vagal schwannoma or a jugular glomus vagal and things like that. So it's a very tricky decision as to how you operate, which one you operate. So there's no straightforward answers to this. It's a you have to talk to the patient, the family, and it's a combined decision. The other thing is, always remember, surgery is not the only option. You have non-surgical options as well for these patients if required. So radiotherapy has shown, like radiotherapy, external beam radiotherapy has shown.
Young female.
That's what. So no, I'm not talking about individual case. I'm just telling an option. So that option will depend on, again, as you said, the age of the patient, and various other factors, whether it's unilateral, bilateral, which one would you want to, irradiate, whether the patient has cranial nerve palsy or not at this present,
Actually, I want to discuss a case scenario like suppose a 25 years female with bilateral carotid body tumor. Just only symptom is swelling over the neck on one side. So how you will proceed, or how
so
you
it
will manage?
So it also depends on whether this is the first time the patient is coming to you. If it is the first time the patient is coming to you, not symptomatic, you just want to do an imaging for this patient and just check what type of carotid body tumor that is, and then observe over a period of time. And then sometime you might have to operate at least one of them. And the question is at which point. So like what Dr. Satish Jain said, whether the nerve is involved or not, whether you'll be able to say whether it's Chamberlain 1, 2 or 3. If it is Chamberlain 1, then you probably will have, you can go in and operate.
Chamberlain 1 on one side and Chamberlain 3 on other side.
Sorry?
Chamberlain 1 on one side and Chamberlain 3 on other side.
Yeah, so in this situation, what I would do, this is a young female, so probably I will just operate on the Chamberlain 1, because I'm sure I'll be able to get it out and give the option, or keep the option of radiotherapy on reserve. In case she becomes symptomatic, then I would suggest radiotherapy rather than resecting the nerve, the carotid, and reconstructing, because you really don't know how the patient will react. Even if you have a balloon occlusion test done, which shows that there is an intact circular villus circulation, you never know. 25% of the times the patient may develop stroke despite a patent circular villus. So you have to be very careful in choosing. That again depends on various other things, So there's no right or wrong in this, and there's a lot of philosophy that is changing, and radiotherapy has shown good control rates. It can definitely be one of your options. Also remember, observation is one of your options, radiotherapy is one of your options, surgery is one of your options. So you can quite diligently use one modality for different type of patient situation that you have, that you're in.
So, like Deepak, if it's an elderly patient, you can observe, and if it is showing growth, you can take the call of radiotherapy, because it is slow growing tumor and radiotherapy contains the growth.
Yes.
It doesn't kill the tumor. Now see,
radiotherapy will not shrink the tumor.
Yes.
It
will induce fibrosis in the vessel supplying.
And it will probably prevent the palsies of the cranial nerves, which is again also important.
Hello?
Yes.
See what I am doing here?
Yes, sir. Yes.
Dissecting the hypoglossal from
This is hypoglossal.
Yes.
And
Yes.
see this toward the upper end. Now I don't have a control at the upper end. See now, what is this muscle? Digastric. See this? I mentioned couple of times to go up what all you can do, all maneuvers. My first maneuver would be artery डाल नीचे. First maneuver would be
To cut this.
cut this, and see, you have to be careful. Just deep to the digastric, you may come across the occipital artery. These are two muscles. The one is digastric, the other one is stylohyoid. And this will, see this artery, can you see this?
Yes, yes.
This is occipital.
Yes.
Like it. This is a very important vessel, and we have discussed couple of times. इधर लगा थोड़ा, इधर लगा नीचे. Couple of times we have discussed the occipital artery base flap we use during mastoid surgery.
What is Satish? What is the use of doing this genetic study? What it gives?
See, you know, the succinate dehydrogenase mutations are responsible most of the time, and there is a good information you can get out of it. Number one, if the patient has a SDHB mutation, there is high likelihood of developing into malignancy as well. Paragangliomas. I mentioned last time vagal paragangliomas. Out of all jugular, carotid and vagal paragangliomas, vagal have a highest chance of converting into malignancy. And those having SDHB mutations have a highest chance of converting into malignancy. If you have a SDHD mutations, there are higher chance of having multiple tumors. And then you need to have an information of all tumors by means of doing systemic studies, angiographies, DOTA studies and all that. So mutations have a value in terms of counseling the patient, in terms of overall management of the patient, and it's available in all India Institute. Now see, this is my vagus nerve. See, this is my hypoglossal. Can you see?
Right, clearly.
Yes, sir.
And here is the tumor.
So there are various studies on the intracapsular excision versus
that's what I'm telling you. That's what I'm coming to.
Yes, sir.
And that's what I'm going to show you under high magnification.
Okay. So do you do, sir? What is your preference?
See what I'm trying to
So
show
I
you
think,
on.
sir, intracapsular.
Yes.
Yes.
See this, what I'm trying to show you. I have to keep an eye on the fibers.
Yes.
Oh. These are vagal fibers. Can you see the fibers? Hello.
Yes, yes.
Can you see the
Yes,
vagal
sir.
fibers?
Clearly seen.
See here.
Yes, yes, yes.
This is the hallmark of our procedure under microscope.
Yes.
See this?
Yes, sir.
Schwannomas.
So can you focus little?
Knife.
So can you focus little more, sir?
Yes, yes. See this?
Yes.
See the vagal fiber?
Yes, yes.
And what I am going to do is, I am going to incise the capsule here.
Capsule. Yes, sir.
See this?
Yes.
See this? Inside the capsule.
Yes.
Inside the capsule, and this capsule will have all around the vagus fibers, you know. Okay, dhire. You have already separated the great vessels.
Yes.
And I believe this will preserve my vagus nerve function to some extent. See this? Out. See this?
Yes.
But this is?
Yes, sir.
The capsule is intact.
Intracapsular. Intact. Yes.
See
Yes,
this?
sir.
Over. And see, this capsule has fiber, nerve fiber. See the lot of nerve fibers.
Yes, sir.
Yes, yes.
Yes, sir.
No,
It's
cottage.
amazing, sir.
And this is intracapsular dissection. See, everything, all structures were around the tumor. We went inside the capsule. You don't have to bother about the jugular, carotid, all nerves. See the hypoglossal, all are outside the capsule. You know?
Yes, sir.
Is there, just out of curiosity, I am asking, is there any study of doing this intracapsular or extracapsular?
Several. I can,
from reference point of view.
Deepak, I will mail you tonight. Several studies.
Okay.
Several articles.
Yes, sir.
So the
now the important thing after this, since this capsule contains nerve fibers, now the only disadvantage that you have to be very, very, cautious about, you are not supposed to use cautery at any point of time now. Because on this capsule all around, where the nerve fibers are, if I happen to use cautery, I will end up damaging what I preserved. Got my point?
Yes, sir.
So what we will do, we will use Surgicel wrapped over the gel form. This is strongly contraindicated here to use any cautery. You have to have patience, it stops. Because this capsule of this tumor contains the nerve fibers. See, the nerve fibers are splayed like this all around the tumor. Like this. Splayed all around like this. This tumor starts from one of the fascicles of the nerve and then keep displacing the other fascicles. And all the nerve fibers are on the capsule and tumor is inside. So now, once I have preserved the capsule, all nerve fibers are supposed to be there. I just inside the capsule parallel to the nerve fiber, did a finger dissection inside, and now this is a thin capsule. I can't even think of using cautery anywhere on the capsule. That will ruin everything, what I have done.
Yes, sir.
So this is the best way, I believe. It's pure evidence based, and we have done couple of times. See, this is the capsule. This is the capsule.
Yes, excellent.
Yes, sir. Very excellent. So which cases will you do the extracapsular resections or?
Hello.
Yeah, we got you
yes.
back.
Am I audible?
So can you hear?
Yes.
Yes.
Yeah.
You are.
So your question is when I would do extracapsular? Hello?
Yes, sir.
Obvious, when the vagus is already gone.
Okay.
Then what I will preserve? When the vagal function is already gone, I will do extracapsular. Then I will just cut it across and remove it. See now what I have used. This gel foam on the marrow cell, on the see this Surgicel on the gel foam around. Can you see this?
Yes.
Just we'll keep a gauze piece for 5 minutes. We'll put a corrugated drain and we'll come out. See this? It will stop. We'll never use the cautery. My great vessels are there on both sides. Can you see? The nerves are there. This is the hypoglossal. Here. See this?
Yes.
Yes, sir.
Or laga dena. And the marginal mandibular up there. You can see.
Yes.
That is the marginal mandibular.
Just, I want to know, excellent dissection, Satish. I want to know the cost of the balloon occlusion test.
Cost of balloon occlusion?
Yes.
Is the cost of DSA. Balloon, lot of people use balloon again and again. The disposable balloons are available, not very costly. But DSA cost depends upon the hospital to hospital. But here in Jaipur, our DSA and balloon occlusion we get done quite often. And the cost around 30,000 or so. With a complete DSA wherein we do 3 testing for the carotid. I already mentioned in the previous one of the webinars why we are doing in case we need to resect the carotid in any unfortunate situation, whether we have adequate cross flow coming from opposite side. So in that DSA we get 3 parameters tested. Number one, the venous phase difference between 2 sides. And it should not be about 2 seconds. That venous phase is difference in the cortical filling veins. And that gives you good insight about the cross flow coming from the opposite side if it is not delayed more than 2 seconds. Number 2, is balloon occlusion test in hypotensive condition. You know, all these tests for the carotid artery occlusion are never 100% safe. In spite of all these tests, you can still get a stroke. The reason is very obvious, because your cerebral vasculature has to adapt to a new circulation, wherein the circulation coming from one side to the entire brain, and the vasculature has to adapt to it. In any given situation in the post-operative period, the patient undergoes hypotension, and what balloon test you have done under normotensive condition may go in stroke. So the balloon occlusion test under hypotensive condition, and if the patient passes that balloon occlusion under hypotensive, that is much more reliable than any regular balloon occlusion test. And the third parameter is the stump pressure. You occlude on one side and the opposite side carotid stump. If that pressure is more than 2/3 of the systolic pressure that time, is something you can go ahead with the carotid resection, I can say. So these three parameters, if the patient passes, they are close to 100% safety towards preventing stroke in case the carotid need to be occluded. So a single parameter of balloon occlusion test doesn't carry any value. What I mean to say.
Yes. Is there any role of just pressing by finger if you are not doing balloon occlusion test?
Pardon?
By just pressing with the index and middle finger, for that is of any use?
That is never reliable, man.
It's too crude.
Deepak, you can't rely on that.
Yes.
How can you?
No, I'm just asking. Yeah, I am just.
This is such a critical decision.
Yes.
Such a critical decision. Rather, many a times, you know, in a skull base we do so often. Many a times we had to take this call of carotid resection, or completely, you know, coiling the parent artery in case we have a tumor around. Looking at a good, anterior and posterior cerebral artery, cerebral circulation at the circle of Willis. In spite of that, even when you resect the carotid or coil it completely, what we do, we keep the patient in ICU and keep the patient in stimulated hypertensive condition. Keep the patient on NORAD at least for 7 days to prevent hypotension happening. If the patient passes those 7 days, you know, the cerebral vasculature develops accordingly, and you can almost nullify the, the incidence of stroke after that. This is such an important parameter. So we keep post-operatively in ICU under NORAD for under hypertension, you know. You have to prevent stroke. That is a disaster. In spite of all tests, still you can give stroke because the cerebral vasculature is not adapted to the new circulation phenomena. Anything anybody wants to add on to this case or any discussion we have done so far? Because the next case we will take is a gloma.
So then in vagal paraganglioma we are doing en-bloc excision. En-bloc excision. Dr. Palaniappan is asking, in vagal paraganglioma we are doing en-bloc excision. Whereas in vagal...
Last week I demonstrated vagal paraganglioma, wherein at both ends I resected the vagus nerve. In vagal paraganglioma, the vagus nerve resection is inevitable. No one on this planet can preserve the vagus nerve in paraganglioma. Vagal paraganglioma. Paraganglioma is a different etiology. Neurofibroma, again, the vagal nerve neurofibroma is a different entity. Like I said, schwannomas arise from the epineurium. The neurofibroma arise within the nerve from the perineurium. Infiltrate the nerve. It is impossible to preserve. So depending, you need to understand the pathology, what we are operating for, and that's how we need to counsel the patient as well.
Tell us something about urine catecholamines, that 24 hours, what we say, the collecting urine.
Initial testing, if you have a, the symptomatology warrants towards a functioning tumor, like functioning carotid body or vagal paraganglioma, yes, you need to do that. And anyway, if it is, you have to operate. The plan is going to be same with additional, anesthesia care, perioperatively. Additional anesthesia care. So the next case we are going to take is a glomus tympanicum, and before that I'll quickly go for 5-10 minutes for STPs in between, and then the next case will be ready by then. That is glomus tympanicum.
Okay.
Let me show you the pictures, the scan. Though in tympanicum, the scan hardly carry any value. कहाँ गया वो? वो निकाल उसको, बोलना उसको खोले scan. अंकित को बुलाना. Where is he? Scan खोलना इधर. हाँ? Tympanicum. K drive. Yes. Now. Just a minute. Yes. And the glomus. Yes. So can you share the screen, please? Glomus tympanicum are the tumors which are generally picked up by the clinical examination. You put your endoscope in the ear or otoscope and you find bluish mass behind the tympanic membrane. A limited bluish mass with the added on CT scan showing no extension anywhere out of the middle ear is a glomus tympanicum. As simple as that.
Dr. Shiva has left and I really want to thank him for his inputs. We really enjoyed his...
I am so grateful to him.
Yes.
Yeah, he's been
Yes.
so good, and I'm really grateful to him from bottom of my heart for sparing his valuable time. Thank you, Dr. Shiva, once again. So, in glomus tympanicum, what you will find on the CT scan? Hardly anything. What all you can find at the most is some mass in the middle ear like this. Can you see? Which may be extending anteriorly towards the Eustachian tube or sometime extending towards the atic. So that's how, if you go to the Mario Sana's classification, the glomus tympanicum or the type A paraganglioma, the right term is not glomus tympanicum for that matter. For our convenience and for understanding, this is a more popular term, glomus tympanicum. Otherwise, the paraganglioma is the more appropriate term. And for these glomus tympanicum, they are type A paraganglioma. Type A are further divided into two types. Type A1, when you see the entire circumference of the tumor through the tympanic membrane, that means it is limited to the promontory and not extending anywhere. That is type A1. And those are the tumor you can simply remove by the same transcanal approach like you use for surgery. Postural. And the type A2 are the tumors when they extend beyond your visualization of the otoscopy. Either they extend in the Eustachian tube, atic, or they could be extending into the hypotympanum or mastoid, maybe type B tumors. You never know. When it is beyond the scope of visualization on otoscopy, it can be anything, but it is at least type A2. And for that, you need a post-auricular approach. What we do, like we do for any tympanoplasty, I'll show the simplest way. There are many ways. Still you can, raise the flap like tympanoplasty and coagulate the tumor and come out. Or this may, many a time, you may end up damaging the tympanomeatal flap by means of your cautery and any other thing. Instrumentation by means of handling the bleeding and all. What we can do, that's what I'm going to show you. You can elevate the entire cup of tympanomeatal flap 360 degree. Bring out in the saline. Drill away the canal properly so that you can see the tumor all around better. And then remove the tumor and replace your cup of skin of the axon artery meatus along with the tympanic membrane back after the temporalis fascia grafting. This is how, this is the safest way of doing this, such tumors which are going little beyond the tympanic membrane confines. But anyway, you have to preserve the ossicular chain, that is the main goal, and that can happen only when you have a good exposure. So this is, to me, is a type A2 tumor. I don't know, even on the CT scan, you can't make out much. See this tumor, which is on the promontory. This is the promontory here. That's a cochlea. And this is going little bit, for sure, it prolapses easily into the Eustachian tube and simply you can pull out of that. There is hardly any big issue. The only issue is whether it is going in the atic. This is doubtful. I have a doubt this tumor is, deep to ossicles. These are malleus and incus. And if this is a tumor, you can't differentiate between the opacities. You know, you can't differentiate between tumor and secretions so easily. And that is how it may be in the aortic or it may be going from there towards the antrum. I'm not very sure. But by and large, it is A2 tumor. And let's see what it is. We'll follow it and remove it. Most likely, I'll be raising the cup of the canal skin along with the TM and make it free and replace it later on. This is the plan. Let's see if I raise the flap and I find a tumor, easily I can bring it into the field by mobilizing it. I may not do it. So that will be a purely intraoperative decision.
Will you not keep that cuff attached at the short process of Malleus or at 12 o'clock?
But still, that will create problem when you are drilling extensively into the canal or using bipolar cautery everywhere. That may damage the. We are preserving it by bringing it out. We are preserving it, not damaging it.
Yeah, I know, but sometimes it is not so easy to keep in a right manner, same way how we lifted in the canal.
Pardon?
Sometimes you are confused after taking it out. Where is the upper and where is the lower? Sometimes the exact repositioning of flap is not so easy.
No, it falls short. You know, once you drill the canal and reposition the flap back, it falls. Hello?
Hello?
Yes, can you hear me?
Yes, yes.
So in that situation, if the flap falls short after drilling, you may have to use some additional thin skin from the post-auricular region. You can use that.
Okay.
So now I have watched up for the Stapes case. In 5-10 minutes we'll be going to the glomus tympanicum that is already induced. Postal khulwa de. Canal khulwa ke root. That case will be ready with the posteriorly canal opened up and we'll go directly to the tumor.
Okay.
Any questions meantime?
Sir, on radiology, how to differentiate type A2 paraganglioma from the cholesteatoma?
Type
Doctor.
Radiology.
Yes.
The paragangliomas will enhance on contrast. The cholesteatoma will not.
Yes.
Paraganglioma is a tumor. बड़ा दे सबसे बड़ा दे
सतीश स्क्रीन को थोड़ा सा ऊपर कर लेगा
या लेके आना तो यार इसको हटा यार Forceps. Are you getting the microscopic picture?
Yes.
पकड़ना दे तो सही दे 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 Yes. How's the picture now?
Yes.
मतलब थोड़ा वॉश कर ये सब करके रखना था ना वॉश
So what is the management for crocodile tear? Dr. Rama Subramaniam from Chennai has been asking this question quite several times.
Difficult. First of all, that is a difficult occurrence, and then Tympanic neurectomy. Shoot all you want to do.
Okay.
For all these issues, finally tympanic neurectomy, because that will take away the salivary gland stimulation completely. As simple as that. All problems related to hyper stimulation of the salivary gland, you can do tympanic neurectomy. Now, can you see the oval window?
Yeah, we can.
Little narrow, You can see little narrow. Can you?
Right.
Yes.
Yeah.
Space between the crura and the facial nerve is the space he's talking about.
Yeah. See this incus and Amelius. Amandeep.
Yes. I'm alive अभी.
बाइक चला के आयो.
अब तो लगता साल नहीं चलेगा.
Now see, I am taking away this joint capsule. I found a joint and pass my instrument to the joint. See this?
Yes.
Laser. Laser. Here's the beam.
Satish, do you believe in reverse staphylotomy? Yes or no?
Yes, I demonstrated last time. It is not the belief. It's a matter of once I have a laser, I need not to do that.
Exactly. So many times people say no, it has to be done every time. I want you to.
No. If you have a laser, you don't have to do all that.
So there are only certain conditions, and especially if you have the laser, you really don't need to.
दिख नहीं रहा. So the reverse staphylotomy we discussed in detail in the Stapes webinar, one of the case I demonstrated, and the idea is in the favorable, that can be done only in certain favorable situations, not always.
And when situation is favorable, you really don't need to do a reverse because
you can do regular one.
Yeah, you can do.
So reverse is to add on to the safety. It's not about the need. If you don't have a laser, you don't want to risk the foot plate coming out and all that. You can add on the safety by means of, fenestration and piston application, keeping the entire stapedial arch intact. That is the whole idea.
Can you move the screen little up because the tendon is not in the
centralized. Yeah.
Now?
Yeah. Okay.
Yes.
Now see.
What is the wattage you are firing here?
The first is the tendon. The tendon is 4.
Using 4 watts, depth of 1
2,
and a round shape.
2
and a round shape.
See tendon gone? Yeah. Now for the crus.
So you will put a gel foam in the foot plate?
Yes, most of the time. Then come kar. This is always good to keep it.
Yeah, because many times the laser beam overruns the edge.
Yeah, it may overshoot. It is always good to have this protection.
So which company is your titanium piston? There's many
Kurz
and Kurz only.
अरे ये हिल क्यों रहा है यार ये? बीम क्यों हिल रहा है? कितने पे है? बड़ा दो.
So if everyone notices carefully, once the char gets formed, the laser's effectiveness reduces.
ये क्यों हो रहा है?
Okay.
वापस लगा इसको.
So do you advise post-op on-table tuning fork test in stapes surgery?
Pardon?
Do you advise post-op on-table tuning fork test in stapes surgery in this surgery?
On-table? Why?
Post-operative. Dr. Girish is asking.
Not needed. On-table, why?
See, if you have done everything to perfection and on table, even if you do and it is not coming okay, that means there is a problem which your diagnosis was wrong. Or the round window autosclerosis, anyway, you don't need to do anything.
Mira.
Okay.
अरे हिल रहा है यार.
डार्क हो गया. अच्छा लाइट कम किया.
See why it is jumping? Why it is blinking?
हाँ उसको सतीश स्टार्ट करना पड़ेगा लेजर.
बंद करके चालू कर यार. Please. See it is blinking.
Yeah. So you restarted it. It will restart.
I have already, hollowed out the posterior crust. Can you see? Already weakened it. Can you see this?
Yes.
So at this point of time, if you want,
a fine pick will fracture it.
Yes. See easily. Easily you can fracture. This is the anterior crust, and it is out. Forceps. Once you have this, Ashish does very frequently. He calls the thinning of the posterior crust. And many of the patients which are not good candidates for the reverse, you can make good candidates for the reverse by means of thinning the posterior crust. See now? Foot plate level?
Yeah. And do you see that little part of the posterior which was left? He's fractured it.
Yeah.
And pushed it posteriorly.
Yeah. So my exposure is not compromised.
So the foot plate is...
Yeah, वो देना मेरे को. Measuring. वो ready है? अरे next.
You can actually see the focus also anteriorly and anterior-superiorly. If you see the color is slightly...
Yes.
Yes.
So now measuring gauge I will keep at 4.25 commonly.
What is exactly fistula antifenestrum? What is this fistula antifenestrum?
Fistula antifenestra is the area of this, enchondral bone. Just see this, absolutely befitting. Can you see?
Yes, sir.
Fistula antifenestra is just anterior to the foot plate, where the part of the inner ear enchondral bone, which is cartilaginous to begin with. Rest of the entire labyrinth, doesn't change. The entire bone remains same. There is no change in the bone after the birth, except that area, and that leads to turnover. That's how the otosclerosis develops, because that bone, which is inactive and hard, changes to this hypodense and vascular bones, and that leads to regular intermittent sclerosis. That's why otosclerosis and sclerosis go on. So that area is immediately anterior to the foot plate. Are you ready?
It's basically a connective tissue filled cleft.
Yes.
And it is only found in humans. That's another thing. That's why otosclerosis is
पूरा circle नहीं आ
in other species.
Okay.
Now see my laser beam.
Yes.
I remember I've seen Ramandeep couple of times doing with the same laser. I remember when you came to Jaipur last time in the workshop.
Yeah.
And I am sure you are not doing without laser anymore.
No, for the last 8 years, no.
See now, हटा लो. Pick, patla.
So many times with the settings of the laser, the hole might not be perfectly circular, because there can be difference in thickness of the plate. And
now see what I have done.
Yeah, he's just circled it, made it completely round with a gentle motion of the pick.
So my vestibule should be full of fluid. That is my safety, If the vestibule is full of fluid, that acts as a shock absorber for the laser, This laser is not going to, this energy is not going to be transmitted to the inner ear organs,
structures, yes.
membranous labyrinth, and even for the laser, which is absorbed by the fluid, lot of studies have been done, about this laser. How much it, irradiates the fluid, how much the temperature increases, And the recent study done, a temperature increase even up to 7 degree, transient, is not detrimental to the membranous labyrinth.
So now they even say that, let's say, had he fired the first shot and the laser had not gone through due to
No, never a second one, never a second one.
Then use the cold instrument too. Okay.
That doesn't mean that you fire a second shot.
You can fire on the edge away from it,
But not there.
So that one
See now?
is it has two.
Hello?
Yes, sir.
The same thing, all 3 steps in one go. My piston at the lower end into the fenestra. The piston, the mouth of the piston is taking on the incus, and it is roughly 0.5 millimeter above the lenticular process. Yes, maybe a little shorter. Can you see this? The piston little shorter. Ek size बढ़ा दे. Could you see this?
Yes, yes. So you can do the bending test and the hanging.
Yeah, it is, see, hanging out.
Yes, yes.
That's what I observed. See this.
Yes, sir.
Ek size बढ़ा ला. See this?
Yes, sir.
I can easily remove the same way. See this.
So it has 2 loops.
See, it has come out.
Yes.
Ek size बढ़ा. And now I can autoclave this piston.
And
This is autoclavable.
Plasma it or autoclave it.
Dena.
And also notice he has not done any suction on the open foot plate.
Sir,
That is disaster. What he has mentioned, if you do, is a disaster.
Yeah. Not only SN loss, you can also cause post-operative severe vertigo.
Sir, what, sir?
If you suck on the open foot plate,
Yes, sir.
your chances
See
of causing loss.
the same thing I am doing with a one size bigger piston.
Yes.
Can you see?
Yes, sir.
What I mean to say, number one, so ease of piston insertion. I've seen people really struggling for half an hour or so with the pistons, with the crimping, and ultimately when the piston is gone, whatever the crimping, they will leave it, we don't remove it. It will be difficult. See now, this piston doesn't need any crimping at all.
Yes.
It is so tightly holding like a clip onto the long process. Blood?
Yes, sir. Sir, amazing.
It
Sir,
will on the 2 surfaces. It will
What I have been showing with these number of step is the reproducibility. Again and again you can do with the same ease and comfort. We have been doing almost 350 or so steppies every year. With the same technique, same piston, with the same ease. If some anatomical abnormalities doesn't make any difference if you have a laser.
Yes, sir.
Sometimes
So what is the cost? What is the cost of this piston?
I think 13,000 or so, I don't know exactly, but it is, the cost is rising up. Rupee is falling, euro is rising up.
Yes, sir. So Dr. Jeevan Vedi from Nagpur has a question that overhanging facial canal unable to do fenestra, then what will you do?
Yeah, many a times, you have seen the video of the Ashim that day. If you not seen, you must go back to the YouTube recordings. First of all, with a dry gel form, wet gel form, you go to the lower edge of the facial nerve and you can mobilize a little bit and get a glimpse of the foot plate. Majority of the times, even if it is prolapsing. Prolapsing doesn't mean the facial nerve will come right in the middle of the promontory every time. That is very rare. That is anomaly. This is because of the dehiscent nerve which can be pushed down. Simple. It's not a congenital anomaly, you can say. It's an abnormality. Abnormally displaced because of the dehiscence. And majority of the time you are able to push it little bit up, get a space. You may have to lengthen the incus a little bit sometime. And you may have to drill the lower edge of the promontory a little bit sometime. And by all these excess maneuvers, Many of the times you are through. You can, place the piston. But this is a difficult problem. If you have a pre-op CT scan in hand, you can counsel the patient accordingly that we may have to abandon the surgery. It depends upon the intraoperative conditions and with a little, consent toward the facial nerve as well. Because of the chances of paralysis or something. In remote situation, in the experienced hands, that is not going to happen, but at least you need to have a consent for that.
Okay. And so one more question, Dr. Rajesh Chaudhary from Amritsar is asking, what could be the reason for profound deafness after 2 to 3 months after successful stepedotomy?
What is the
reason for profound hearing loss after 2 to 3 months after successful
profound hearing loss?
After 2 to 3 months after a successful stepedotomy, if patient comes to you with profound hearing loss, what could be the reason?
Put the slide mentioning n number of regions beyond the surgeon's control can lead to profound SNHL. Some of the regions are preventable, like Ramandeep mentioned, never to suck over the fenestra. This laser, we are not mobilizing the inner ear fluid all of a sudden by mobilizing the foot plate by means of using laser and all that. You can avoid. But there are many regions beyond your control. Because of the change in environment, because you open the inner ear, which is so, close otherwise from the outer environment, so sterile environment, and then the change in the inner ear dynamics, inner ear fluid situation, there may be high drops developing, there may be, the molecular changes happening inside the inner ear fluids and all that can lead to. But those are beyond your control. That's why you should always take a consent. In spite of an uneventful stepedotomy, still there are chances of SNHL that those are beyond your control in very, very small percentage of cases. Yes.
Okay. And sir, one more question from Dr. NVK Mohan. What are the chances of long process necrosis with these pistons?
Yes, that's a very important. NVK Mohan from Calcutta. Good evening, boss. First of all, pistons can lead to necrosis of the long process by various ways. The commonest way is a loose piston. A loose piston into the vestibule inside and a loose on the incus can keep on hitting and erode. Number two, the piston which got fixed at the lower end, at the edge or out of the fenestra in the whole window or anywhere, with a vibrating incus can erode it, both ways. Third is over-crimping can also be a cause of, because the anterior-inferiorly in the incus run the vessels which you may strangulate, because this is less likely to be a region. In these titanium pistons, that is the beauty, they take the incus, like a clip. Less than 30% of the circumference of the incus is in contact with the piston, which is less likely to erode. Number one, there is no play between the incus and the piston. That's why there is no need of crimping. With a Teflon, if you are very experienced, you can still do a very good crimping, adequate crimping. Neither over crimping nor under crimping. You have seen Ashim and Ashish in the Staples webinar through their cases. They have been doing with the Teflon with same ease and comfort and results. Otherwise, the crimping is a very demanding procedure, Over crimping and under crimping both are hazardous. And that part is overcome by this titanium. You don't need crimping. It takes on the incus, that too very rigid. So there is no play between the incus and the piston. And there is no question of all those piston related problems are. If it is properly used with the adequate length, forget about it.
So when Satish says
he's also asking how to.
Ramandeep was mentioning something.
Yes, sir. Go ahead.
Yeah, remember we had discussed that article in which they had shown that if the piston is small, it comes out of the fenestra it gets fixed at the lower end, but vibration still continues to come and the underside of the incus gets necrosed.
Yes. That is a very, common reason for this necrosis.
Okay. Also asking, how do you deal with an obliterative foot plate with a laser?
Obliterative foot plate need not to be dealt with the laser, number one. Whatever obliterative foci is, first of all, you can pick up by means of a good
CT scan.
CT scan.
Yes.
Number two, if it is obliterative, you have to counsel the patient accordingly, because results in the obliterative can never be as good as in a regular foot plate. Number one, short term or long term, it calls for a huge experience to deal with the foot plate, because this focus can be dealt with only by one way, that is proper drilling of the focus with a micro drill onto the oval window. So ideally you need to drill away the entire focus, keeping the foot plate intact. Then you bring out, discover the blue foot plate below, and then use the laser for the fenestra. And it calls for a amazing work kind of a thing, it's not all that easy. That's why the obliterative foot plate or difficult foot plates.
Okay.
So the vascularity can be taken away a little bit by firing a few defocus shots on the surface. Then you start your drilling, and once you blue line it, then you can fire a shot again to create a hook.
Okay.
So I'm watching up, I'm ready, getting ready for the next case.
Yes, sir.
And that is a tympanicum. Meantime, we can take more questions.
Yes. So Dr. Ramesh Rohiwal from Aurangabad is also asking, any difference in incus necrosis with the titanium piston?
With titanium, it is unlikely to be. If it is properly used at the lower end, it is unlikely to be.
Okay.
And usually in obliterative focus, the size of the piston is usually which we have to use is longer.
Okay.
You have to measure at the end when you flush the foot plate.
Foot plate, and it will usually be 4.5, 4.75.
Little longer.
Yeah.
Sir, in the previous case, actually few doctors had this query about the mandibulotomy. Can you elaborate a little bit on that? Vertical
Never required, I
mandibulotomy?
mentioned, it is never required. Mandibulotomy for the schwannomas is, we never do it. You can increase your access by dividing the digastric, by dividing the styloid complex, stylomandibular ligament, and then by, even if it is still you are not able to go above the lesion, then you can, using, I mentioned, use your micro debrider and hollow it out, it will fall down. Right.
Okay.
It will fall down. किसने खोली है कैनाल? See now this lesion. Can you see something behind the eardrum? Light बंद करो ऊपर. Hello?
Yes, sir.
Can you see something behind the eardrum?
Yes.
See, you have given trauma while opening the canal. My God. See some trauma on the canal flap. Can you see the tumor behind the tympanic membrane or not?
Yes. The
Very
bulb.
clear?
Yes, yes.
I never wanted this trauma on the canal.
Should have been careful now. Can you see the tympanic membrane intact? Little trauma over it. How could you give trauma during canal opening? Yeah. Come on. Ridiculous. I am first elevating this flap, the posterior part. Okay? Hello?
Yes, sir.
Am I audible?
Yes, yes, you're audible, sir.
Knife. बाइपोलर पतली वाली, सबसे पतली पतली। क्या केस करवा रहा है रमेश? और पतली। हट हट। ग्रस्त है।
So what was the hearing status of this patient?
A little conductive hearing, mild.
Okay.
Not much.
Okay.
See, the hearing loss generally appears when they immobilize the ossicular chain, when they occupy a large part of the middle ear, when they occupy a large part of the eustachian tube. Those are the reasons for hearing loss. And mostly conductive hearing loss, because they do not erode much the anything. I am reaching the annulus level to see inside first,
Yes.
before taking any final call that what I am going to do. See the tumor? Can you see?
Yes, sir, very clearly.
Big one. It is not a small one. Can you see?
Yes.
Better I take the cuff of the skin out. I see this trauma on the skin. I never appreciate this. While just opening the canal, what was he doing inside?
So what are the symptoms of this patient?
Hearing loss, tinnitus.
Okay.
Tinnitus is the major presentation as the tumor comes in contact with ossicles and give rise to tinnitus. See, entire cuff of the skin I am raising. I hope the picture is good.
Yes, sir.
Very good.
See, circumferentially I am elevating the skin. Now the final decision to free it or not, I have to take again on the table. Sickle. Whether I push it superiorly in work if the tumor is not going superiorly, or I need to see the tumor occupying the entire middle ear space. See the entire middle ear cavity. That is chorda. TM elevator, TM elevator. So this is never A1 tumor, it is beyond A1.
Satish?
Yes, yes, please.
Hello, Satish, Maruti here.
Yes, Maruti.
Yeah. Would you like to disconnect inguinal joint before handling this tumor?
Yeah, that's first of all I am ascertaining.
As there is a no,
See,
there
this
is a
is
minimal
going,
conductor loss.
yeah. First of all, for everyone, this should be started dealing inferiorly because the vessel comes from inferior side. Okay. Now, before taking the final call, bipolar, kidhar hai? Final call of removing the cuff, what I will do, I will shrink the tumor. Kidhar hai yaar? See this? Point all. See, this cauterization result into tumor shrinking. Can you see?
Yes, sir. Yes.
And the vessel to the tumor comes from below, so always it should be manipulated from below first.
Can use intermittently the adrenaline cotton balls to minimize the bleeding along with the
You can,
bipolar
but
cautery.
that doesn't make any difference. Because this is, there are bleeding vessels into it. Adrenaline is not going to affect much. It's not a mucosal bleeding. It's a tumor bleeding, See this tumor which was going in the Eustachian tube, I have elevated.
Yes.
Very
Can you
nice.
see?
Very nice.
I have elevated. I will cauterize it and see how it is shrunken now.
Yes, sir.
Yeah.
हाँ ढंग से खुलवाना क्या खोलिए See, more and more you cauterize, the tumor shrinks and you get more and more space. See this, how much the space now we have gained.
Yes.
See this little bit of the capillary oozing, there you can put your gel foam or the cotton ball. And now I will show you the tumor vessels. Lagana yaar, dalna.
So Dr. Fazali from Pakistan is asking if total flap is removed and repositioned, any chance of necrosis as
Not really,
canaloplasty is
not
also-
really. It is taken up so well and we do couple of times because the vascularity to this tumor, to this flap comes from the underlying bone. See this promontory attachment, can you see?
Yes.
Yes.
Really.
See my incus above.
Can't see the incus.
Let me know if I go out of the field or anything, please.
Oh, perfect. It's perfect.
See what I am trying to take away. The promontory attachment.
Yes.
These are most important. Still my cuff is inside, I have not removed the cuff yet. That depends upon the superior extent of the tumor. Then if it is going, I will have to.
Then we have to remove it. Yes, sir.
Come out. See, it has come out. That is the vessel on the promontory you see. See that?
Right.
Yes.
Can you see that vessel?
Yes, clearly.
Yes.
Yeah, the moment I cauterize this vessel, this will be over.
Even the ball probe is a good instrument here.
See now. The circular there. It is out. See this vessel on the promontory.
Right.
Forceps देना यार पकड़ना. See the tumor is out.
Very nice, Satish. Very elegantly done.
Now see the vessel there. Still bleeding. Let me show you.
So the Jacobson nerve will be injured on promontory.
Yeah. See this vessel. Now it is over. See, no more bleeding.
Yes.
Yes.
Give me a small gel from over there. So that tumor vessel over the promontory was the key. I was all set to remove the cuff. Just a one attachment I had to remove, which I was waiting for. Had this tumor been going up in the attic, difficult to mobilize from the ossicles, I would have to remove. What strategy prevented me from removing this cuff? Number one, remember, always start from inferiorly.
Yes.
Number one. This is what I am saying, what Mario Sana's concepts are.
Yes.
Start from inferior. क्या दिया ये? क्या दिया ये? Gel form यार. Number two, start from inferiorly, and number two, keep coagulating the tumor to shrink it. Because once you shrink it, then only you will be able to see where at all it is going.
Visualization.
Yes, for visualization. And you can see the tumor vessel well. I saw the tumor vessel. The moment I saw the tumor vessel, I told you it is going to be out.
Is asking if high jugular bulb occupying the whole of the middle ear space also looks like glomus. Then how will you differentiate?
Radiology will tell you whether it is high jugular bulb or a tumor. In this case, the jugular bulb was normal.
Yeah.
Why would jugular bulb be normal? That's why it is glomus tympanicum.
Yes.
I will show on the CT scan again. I am repositing. If there is a small tear anywhere, you can supplement with the graft. I am not happy with the way the canal was opened by our colleague. So, I graft lagai this. I will ask him to put a graft. Everything is done. We have to just reposit the flap back. Okay? Give me a cotton ball. Take a Ayub, take a fascia graft and apply. Huh? We'll just prophylactically put a fascia graft. Okay?
Yeah. Better.
Otherwise, there is no perforation at all. But when they opened the canal, there was some abrasion of the epithelium of the TM, some canal injury. I don't want to leave a chance of perforation. So we'll just put a graft around.
Sir, Doctor. Yes, sir.
Yeah, that is done.
So Dr. Narayan Jaishankar is. Yes, sir. So
Narayan.
Dr. Narayan Shankar is asking you to explain the different approaches for B-type tumors.
Okay. First of all, I'll congratulate Narayan for writing a nice book in the lateral skull base surgery. That is something must read kind of a thing, wherein he has put in his hard work of years together, compiled everything, and it's amazing. Number two, for the B-type tumors, can you hear me here outside?
Yes, yes.
Yes, yes, yes.
So for B-type tumors, there are 3 types of B-type tumors, what Mario Sana has described.
Sir, we can't see anything. It's a black.
Pardon? There are B categories divided into B1, 2, 3. B1 are the tumors after the A2. This was A2 because the entire tumor was not, the circumference of the tumor was beyond the tympanic membrane visualization, you know, what you see on otoscopy. B are the tumors. B1 when the tumor extends to the hypotympanum. Hypotympanum is the area, kyun jati hai screen? Hypotympanum is the area where the tumor goes towards the jugular bulb and difficult to remove. So that is B1. B2 when the tumor extends to the mastoid. And B3 are the tumors which extends anteriorly to erode the carotid canal, the petrous carotid. So simply looking at the classification, what you can do? B1 going to the hypotympanum, what you can do? Come from behind, mastoid side. Do a posterior tympanotomy, extended posterior tympanotomy by sacrificing the chorda. And besides the anterior approach through the canal, you have another approach from behind. To the extended facial approach towards the hypotympanum. You can go right into the hypotympanum through the extended facial recess, and that is best for the B1. For B2 tumors extending to the mastoid, again the same approach, but they extend towards the facial, you know, retrofacial recess into the mastoid. So besides, now you can use 3 approaches. One through the canal, second through the facial recess, you know, canal, then second through the facial recess, and third through the retrofacial recess. So you can have 3 entries, you know, 3 avenues to access the tumor right from the hypotympanum to the mastoid and the middle ear. And B3 are the tumors which erode the carotid artery, and those are the tumors because you have to clear around the carotid, you have to drill the peritubal cells, pericarotid cells, and then the eustachian tube function is, you know, compromised, and the best approach for them is a subtotal petrosectomy blind sac closure. That is the answer for B3 tumors. And this all these varieties whenever possible. So you can address all these lesions differently. Any other question? Next, kya hai? Next. Okay. Any other questions?
And so this cautery which you used is the usual cautery or any special cautery?
This is a regular bipolar.
Regular
Little smaller. Because the regular one will not be accommodated in the exnotory canal. A little smaller.
Yes.
And is a diode laser?
That is not bipolar, boss. Once these vessels, you know, the best for them is bipolar. Many times we have tried, you know, insulating our microforceps. Only the tip remained open, and you catch the vessel and coagulate with a monopolar. We have tried that, but that is not safe. Bipolar is best.
Okay. So, sir, Dr. Jeevan Vedi is asking, by this cauterization, tympanic neurectomy was already occurred. So, any post-operative effect that you will see in this?
Not really.
Okay.
There are many alternative pathways which open up. There are many interconnections of the glossopharyngeal nerve in the jugular foramen with other nerves. and in long term they really give any morbidity.
One question regarding step is, what is the cause of tinnitus after 1 month of the step surgery? And
Yeah, so just answered.
See, this is a adaptation, cortical adaptation after the hearing loss. It becomes hypersensitive, and there is a lot of unexplained things, but majority of the low frequency tinnitus disappear.
So, any of your stapes cases, do you use vein graft ever for any?
Yeah, many a times.
Many
Okay.
I used to do earlier a lot, and this is what Ashim was saying. He always uses a vein graft, except certain circumstances in a deep oval window or obliterating and all. Obliterative is a contraindication for that matter, because if you use a vein, can ossify.
Okay. So then maybe
when you use more perforator or the drill, that time you have to because sometimes you get a half full plate comes out. In that case, the vein graft is the one more good option. If your foot plate is out, or in the laser, I think there's no chances of floater or this thing. So, and vein graft is everybody should know how to take the vein graft and how to use it. That is a thing.
Okay, in one of the next time in one of the case, we'll demonstrate.
yes, sir. Can we? Yes, sir. So that many are requesting you to demonstrate the harvesting of the vein graft.
Okay, we'll show one in the one case at least how to harvest and use the vein graft. Basic principles.
Yes, sir. Yes, sir.
Actually, what I learned from Professor Desai, when complete foot plate comes out, then you use perichondrium.
Yes.
And when part of the foot plate comes out, then it is better to use vein. Am I right, Satish?
Okay.
Yes, exactly. And another thing he used always, when the entire stapes came out, total platinectomy done, he was by and large against using the piston. The reason was, being the the vestibule having the more pressure than the inner ear, than the middle ear, whatever membrane you seal with this vestibule, it bulges towards the middle ear because of the high pressure inside the vestibule. And if you use a piston, what he believes, it may lead to perforation of the membrane. So once you are doing a total platinectomy and covering the foot plate with perichondrium anything, he prefers to use the cartilage. That's what Ashim showed that day, if you remember.
Yes.
He used the cartilage, and that is the something important to learn from. Now the next case we are moving to, and this is a very interesting story. This patient, I don't know what I am going to get, because currently this patient has developed meningitis thrice. And on radiology, finally found to have a defect in the tegmen. Has intermittent history of rhinorrhea. Not exactly otorrhea, though his tympanic membrane and everything is also not normal. But a history of intermittent rhinorrhea. At present, for last couple of days, there is no rhinorrhea. We got the scan done, and I will share with you the scan findings, and then we'll explore and see what it is. Now, having developed meningitis thrice with a defect in the tegmen with, meningocele coming, in itself is an indication to close it to prevent future meningitis now, which he has developed already 3 times. It's not necessary to have active discharge now, once this patient has already suffered so much. So let me put you this one. The 3D MR cysternography. Okay. This is 3D MR cysternography, which I am going to reconstruct in all planes. This one. See, MR cysternography means everything
the CSF is bright and rest of the things in the background are suppressed. So you can become even as small as the CSF coming down in the dark background. You know, that is what MR cysternography is. It is a heavily T2 weighted image. So, let me share you the positive finding this patient has. See the coronal image?
Right.
And if I go behind at this point of time, see something. Compare this side to the opposite side. Okay?
It's a small protrusion.
Yeah, this looks like a meningocele coming down, and see this.
Right.
See this in continuity here.
Right.
With the brain gliosis in vicinity and hyperintensity of the residual brain. That is classical of the changes going on. And opposite side, absolute normal sulci and gyri. And here, the gyrus is obliterated. You know, sulcus is obliterated here.
Yes.
And this is something which is coming down from here. Now, what is this level? Let me change the sequence. What is this level exactly? Let me show you. See this level. Can you see this? Can you see this coming out? In the coronal picture, this is meningocele. See this? With a defect at the skull base, the tegmen, and the opposite side normal with a gliosis around. And see the area. What area is this? See the area of the cochlea.
Yeah.
See this?
Yes.
See the defect. See, this is the semicircular canals behind.
Right.
Now I am going anteriorly. I am going anteriorly towards the cochlea. See the towards the cochlea and just anterior to the cochlea is this defect. So you can gauge the site of defect as well. Cochlea is in the anterior part of the, in relation to the tegmen. Cochlea is in the medial wall of the middle ear. The semicircular canals are behind. Cochlea is the anterior-most part of the labyrinth. And this defect is superior to the level of the cochlea. See this cochlea? Superior to the level and little anterior to it. That means in the anterior-most part of the atic tegmen, it has gone. And this kind of a meningocele which is coming out, so clear it is. Though presently for last couple of days it doesn't have any discharge, surprisingly, because it is intermittent. And because of that, it has been overlooked and this poor patient has developed meningitis thrice. So, this is one finding. Second is, if you look at the same thing into the CT scan carefully, मेरा बैग देना, इसकी सीडी लगाओ. The CT scan, if I show you the level of the defect as well, Ramnivas naam hai. The other CT scan, this is not good.
कौन सा?
हाँ, इनमें है, ये वाली है. Not these, among these. Let me put up the right CT scan picture. Yeah, it is here. Here it is. इनमें देख रामनिवास. Just a minute, because that is important to understand the relationship with the on the CT scan, because it corroborates with the MRI same. The defect is in the anterior part of the tegmen tympani and laterally, not only anteriorly, but laterally as well. That's what I want to show you. This will help us reaching to the level of defect easily. सही लगा ना? Yeah, इसी की लगाई ना? I'm opening the DVD.
तो MRI किया. Let me open the same. Okay, let me show on this. This is also reasonably good. See, this is the regular high resolution CT scan. Let me open up in the coronal plane. See this defect in the tegment on this side, can you see?
Very clear.
Yes.
Let me reconstruct and show you on again in a better way. See, the importance is the radiology to clinically evaluate such cases properly. See this. Can you see the level of the defect? Hello?
We can see very clearly.
And this is the level of the defect. And see, if you see in the coronal, in the sagittal plane, such defect. See the defect.
Yes, yes.
Here is the defect.
Yes, sir. Yes, sir.
And in the sagittal plane, anterior to posterior, this is the level of the TM joint. Behind that, in the anterior part of the tegmen, behind the TM joint, and just behind is the superior semicircular canal arm. We know the superior semicircular canal anterior arm is in the atic, and it is just anterior to the arm of the superior semicircular canal. Can you see very clear? See how in three-dimensional CT scan you can pick up the lesion, the defect, so easily. It is so important to reach to the site of the defect. Size of the defect, site of the defect, everything is so obvious now. So now we have opened the case already. I will go and reach to the site of defect and let's see what best we can do to this patient.
How old is the patient? How is it?
Pardon?
How old is the patient and what could be the reason for this thing?
Trauma. He has a history of trauma, long back, more than 2 years back.
And hearing loss? How much is the hearing loss?
He has a sensory neural hearing loss.
Okay. The main symptom is repeated attacks of meningitis.
That's how he came to the neurologist, because he has developed meningitis thrice and finally he got this defect.
Okay. But the cochlea is not ossified that side.
Cochlea is not ossified.
Okay.
So was there any history of trauma you said? Hello?
I was there 2 years back.
Hello?
2 years back.
Hello?
The history of trauma was 2 years back.
Yes. That's how he developed this defect, and it was intermittent leak, hardly observed, the lateral part can be overlooked, presented with meningitis. See the gliosis of the brain because of the repeated meningitis in that region, and then finally the CT scan, this imaging picked up the defect. So presently it is not active. Let's see the defect first, and we have to close this defect to prevent future meningitis anyhow.
What is your surgical planning, Satish? Approach?
The same post-oral I will see, assess the site and size of the defect,
and then accordingly take a call. If it is little bigger, I will don't mind. I will not mind using the middle fossa approach.
Middle fossa approach.
That is simplest and most reliable. ये क्या? चलो. Hello.
Yes.
So we are ready now.
Yes, very much.
Yes, sir.
So now after this, quickly 3 more cases to follow quickly, because those are not big cases, and we'll keep something ready to save time. The parotid will keep the flap raised. Just show the facial nerve and removal of the tumor. Next JNA limited one, I'll keep the Denkers done already so that I can show the removal of the tumor, and a single-sided AFRS in a child quickly. So all those 3 will not take long.
But before that, you have to tell us the secret of your energy.
Huh? Come on, Deepak. Now, are you getting the picture?
Yeah, very clear.
Yes, yes. So for that matter, even Deepak Dalmia sir, is a super fast surgeon, has kept so many cases in his hospital in a day.
Yeah, Deepak is champion, all-rounder. Next week will be, advanced endoscopy, pure skull base, like pituitary and more intracranial cases or skull base cases.
Sir, there have been 2 requests from the query that I get always, that they all want to see a septal perforation case, one, and also want to have a good discussion on malignant otitis.
Yeah, we'll keep a case, malignant otitis.
Yes,
a suitable case.
And malignant otitis extra discussion.
Yeah, definitely. That is a good topic. Now see, are you getting the picture?
Yes.
Now see the surface of the mastoid bone, the fracture line. Can you see this?
Yeah, very clear.
Past fracture line, this has been more than 2 years, so it has become like this. See the condition of the the tympanic membrane. The entire bone is broken, and see this, how it is tenting.
Yes. The bony spicule is.
Yes. दिल देना छोटी पतली. CSF otorhinorias are many times, very often they are overlooked. Many of these patients come via this after developing meningitis. Like. बताता हूँ. Circular.
Besides you, Satish, I salute the dedication of Paramita and Rajiv also. They are
amazing.
Completely with you. And, we are enjoying because of them your excellent demonstration of all the surgery.
Entire credit go to them for these webinars, for their commitment, dedication, and the hard work.
Yes.
See how it has become because of the trauma.
Yes, fibrosis also is there a lot of.
Cotton ball and drill.
What you are assessing, you will do inside out or outside in, what you are assessing here now?
Here that is not the goal, inside out, outside in. Here we have to reach to the site of defect. Drill. And we have to seal it.
So site of defect you will do by which approach?
No, थोड़ी बहुत cutting देना बंदा. I will open from behind. I will follow the tegment entry anteriorly. Okay, this is just the fracture line. See the fracture line behind. See this?
Yes, very clearly.
Okay. Cotton ball. This will ultimately use the the fascia to repair this thin drum. See, that is the reason for the hearing loss. See this ossicle all fixed. Or the cotton ball.
I've definitely had ear bleed after the head injury, with a CSF leak.
Yes.
Victoria, he must have had post-head injury.
The drill there.
Must have been missed.
पीछे के लिए मोटे. Yes, madam.
Sir, Dr. Prashant Kevade from Mumbai is asking, even after opening mastoid, you can go via middle fossa approach?
Yes. Obviously, the middle fossa is above the mastoid. Middle fossa is above the level of the mastoid. I will show you in case required. Let me first find out the problem. The only thing which concerns me is not having the active discharge. It is always better to go from the normal area to the disease area, so that you can appreciate what exactly is going on better. What's it? See the mastoid? Absolutely good. Not centralized? You attack here. Hello?
Yes, Satish.
Yes, madam.
Yes, sir.
Yeah. See the mastoid good. Now we will move on anteriorly.
Sunil from Jaipur is asking what percentage of cases
Right angle. Yeah.
of meningitis develop labyrinthitis ossificans and why some do not develop it?
Yeah, it depends upon the pathology, the pathologic organism, and the immunity and resistance of the patient himself. So mostly, but by and large, the meningitis patients who develop, इससे एक side छोटा देता this thing, labyrinthine ossificans are mostly after pneumococcal meningitis. Still I have not reached to the level, I am going quickly, more anteriorly. This is far anteriorly. Yes, I can see glimpse of. I can see glimpse of something. I will show you. Yes, you are asking something? See something? Can you see? See the glimpse of the meningocele most likely. See that?
Yes.
I am not sure.
See it now. Yes.
But
yes.
that is something abnormal there.
So you can just show us the landmarks?
Yeah, I am going towards the anterior atic. See from behind. That is the area of the lateral semicircular canal you can see. Can you see the lateral canal here?
Yes, we can.
This is lateral canal.
Right.
And these are the ossicle completely fixed. I don't know, ossicle or a bone. See this? And this is something, the meninges which is prolapsing. See that? See here. Could you see the glimpse of the brain tissue?
Yes. We can.
That is the site. Drill. Side circular. See now?
Yes, sir. Yes, sir.
Yes. See this? The malleus got impacted.
Yes. So will you expose that area more?
Where is it? Yeah, I have to expose that area completely because that region is far anteriorly. See, I can see there.
So, doctor.
Oh, got a good lesion, big one. See that below?
Yes. So, Dr. Jeevan Vedi is asking if it is an anterior attic, then why not by zygomatic approach?
We can go by zygomatic as well, but the zygomatic doesn't mean that zygomatic approach was invented to come from anteriorly for the labyrinthine facial now, Here you need a wide approach. See the meningocele coming?
Yes.
See this long?
Yes, sir.
What an amazing finding. See that? What a radiology it was which could pick up. Now I got the lesion very nicely. See this?
Yes.
देख तो ऊपर से आना पड़ेगा.
So what was the hearing? What was the hearing status?
अरे profound loss. What's up? Unilateral profound loss.
Okay, sir.
Side knife. See the CSF.
Yes.
See this?
Yes.
Reason for developing meningitis again and again. See the reason.
Yes, sir.
Forceps. What an amazing finding. See, I segregated this tympanic membrane and whatever the retracted portion was. See this? See this?
Yes.
This is a little bit of the bridge we have kept intact, and for that here we'll put a cartilage and put a graft to reconstruct later on. That is the secondary part of the reconstruction. The primary thing is the CSF. See the site of CSF.
Yes.
I told you above above and anterior to the cochlea, and see exactly where it is. Can you see?
Yes. Yes, sir. A big defect.
Yeah.
So that will you remove the lateral part of the bone as well?
Yes. Diamond. I will completely, expose the defect. First of all, diagnosing such a condition is difficult.
Yes.
Most difficult part.
Number two, a good imaging.
Yes.
I could pick up only because of this good imaging, otherwise it is so easy to miss. See, this is the defect. Bipolar. छोटी वाली ला. See, this is a defect.
Right.
Yes.
Circular. Over there. Pick.
So will you do a blind side closure in these cases?
No. Not so big. Though this is, in profound loss cases, one of the indication. See, this is the defect. From where?
Yes, sir.
So clear cut.
Yes.
This is the area which is most difficult to be dealt with the middle fossa approach, I tell you. Because the bone there is not flat. When you come from the middle fossa, it is quite deep. Can you see this?
Yes.
Really not.
Yes.
And there the bone, when you come from the middle fossa, There are a lot of curvatures, in that bone there. Difficult to place a bony graft from above. So first of all, I will try from below. Set, Set. Are you okay? See, this is the size and height of the defect. This one, can you see?
Yes, yes.
Diamond. All patients who have history of trauma and develop meningitis should be, carefully scrutinized. Thoroughly look for.
Yes.
There are a lot of cases reported. The post-traumatic, even a perilimb fistula, led to meningitis. So now I have this area of interest to be closed, this defect, okay?
Yes.
And I have a good access to close this defect as well. I have very good access now. Diamond, एक side छोटी.
Satish, where is the eustachian tube side?
Eustachian tube is much below, madam. Here. The middle ear is here inferiorly, far below. See this here.
Okay.
Middle ear is here where my suction is. And this defect is there. See in the tegmen, in the most anterior part where we expected, above and lateral to the cochlea and anterior to it. And this is exactly where the defect is.
So, sir, many have this doubt that why have you kept the posterior wall intact? So you can just give them the explanation.
Posterior? What?
The strut of the anterior.
Why have you the posterior canal? Yes, the bridge intact. Why have you left?
Yeah, we'll reconstruct. We have to give him a dry ear as well now. What I will do, we'll put a small graft here in this, see this? TM graft and reconstruct this rest with the cartilage. This canal wall we have to reconstruct with the cartilage to segregate this area completely now. This is a different reconstruction. This is going to be for the CSF. Okay?
Okay.
And here we have to reconstruct the canal wall and the temporomeatal flap as well.
Yes.
As usual. That is simple. We'll use a graft and we'll put a cartilage like I had shown in the intact canal that day.
Yes.
So this area can be completely reconstructed. We have to just put a graft here. See this? Hello?
Yes, sir.
Yes, see, we'll put a temporal fascia graft here and a cartilage behind it over here. That is different. After bipolar. After closing the leak,
Pressure leak is very high pressure leak is there. Very.
Yeah, the flow is good. You cannot say high pressure like this. CSF is always under some pressure in the brain. Laudo, सर्जिकल में. So now I am going to repair this defect. Fascia भी ले. Guru fascia. Cotton ball. You have already harvested the fat. लो थोड़ा फेशिया निकालो. लिया फेशिया. ग्लू तैयार है. So like any CSF, any other CSF leak, we are going to seal it in multiple layers.
Yes.
Okay? This is the
Yes,
rent
sir.
where the meningocele was coming out. We have coagulated and this is the rent. The site is little tricky. No, this is too big. We'll use the fat fascia and glue.
Sir, please orient everyone where you're working once again, because there are a few queries on that.
Orientation
Yeah, which area exactly is the defect?
at the anterior superior part of the atic. देना अंदर घुसाने को. I have been persistently telling from the radiology about the area.
Yes. So
Anterior and superior to the cochlea in the tegmen, you know.
that femcid and
See this leak stopped?
yeah. How much losses, hearing losses there, if loss is there?
Profound.
Then we could have gone for obliteration also. This.
Yeah. It's not a big defect to warrant that.
Yes.
Cotton ball. Now see, after closing with the fat and the surgical, see completely stopped. Can you see?
Yes, wonderful.
Absolutely.
Yeah, ultimate.
Yes, sir.
Now,
If there is herniation of brain tissue, then how will you manage?
Yeah, I would excise that particular, first of all, the herniated part, and if it is a bigger defect, then I would do a sort of, structural reconstruction. Mostly, what I was telling about the middle fossa approach is what mostly we do for the tegmen enteri defects, that two lateral ones mostly. Suppose you have a 1 by 1 centimeter defect here, okay? I will make a 1.5 to 1.5 centimeter this bone graft, okay? Bone graft from here, I will thin out because we don't need a thick one there, and then elevate after after elevating this bone graft, there would be dura. Then I would retake the dura from above to go above the defect, and from intracranial side I would place that bone graft. So that to prevent the brain falling down.
Herniation, yes.
Herniation, yes.
Yes, you can wrap in the fascia to prevent the leak and prevent brain herniation. With the brain pulsations, that bone will be kept in place between this bone below and the brain above. So that will be sandwiched. That is the best technique.
Yes.
We'll keep that case also sometime.
Okay.
See, this is so easily controlled.
Yeah. A very unique case, Satish. Very nice.
And this poor man developed meningitis thrice. Yes. See, that was the glue?
Right.
Fascia. छोटा दे. और काट नहीं सोचा रहा था, छोटा कर. And I will put a layer of fascia as well, additional. Ayup.
Sir, can you show us the facial canal? The horizontal canal.
इसे फेशियल कैनाल लगा देना ग्रा, हाँ, कार्टिलेज और फेशियल. Pardon?
So can you show us the facial canal?
That is here behind. I will show you.
This facial letter, I think, looks like facial letter.
Yes, yes. Too big. Other day. Yeah, facial canal. See the facial canal in the floor.
So centralized.
Could you see?
Yes. Yes. Yes.
We have nothing to do with that. Here is the lateral semicircular canal, and see here is the facial canal. So after this, what we have to do a small work. I had shown you that day. My associate would put a cartilage from here to here, and a small graft, and this will, you know, this will be replaced like this, like this.
So focus.
That will be segregated. See this?
Very nice, very nice, very nice.
That is the simplest way. Right? Now I am putting some fascia. Last repositor. Gel foam, Surgicel. See this beyond the margins of perforation. Can you appreciate?
Yes.
Beyond everywhere. Glue. And now a little bit more glue to fix it.
So Dr. NVK Mohan is asking, will you use the lumbar drain in such cases?
No, not really. Traumatic, no need.
And will you be blocking the eustachian tube opening?
No, why? We have a good middle ear. We are reconstructing the canal wall and the tympanic membrane to have a natural middle ear. See now, after the glue, I pack with the gel foam. See everything closed completely. I hope the picture is good there.
Yeah, it's okay.
Yes, sir.
Very good.
The pad and the Surgicel combination is hit now, I think. Most of us. It's a wonderful, I used in one or two cases. Wonderful.
So this was all about cartilage or graft laga dena. So the cartilage and graft will be placed by my associate, and we move on to the another case. So we have quickly now 3 cases in 1.5 hours, less than that.
Satish, could you keep this patient on Diamox or something? Hello?
Yes, I think.
Hello, Satish sir. So what about post-op? What will you, what will be your post-op management for this case?
Like any ear surgery, but additionally we'll add on Diamox.
Okay.
So now 3 quick cases left. We have already done probably 8 cases, I think.
Yes, sir.
1, 2, 3, 4, 5, 6, 7.
Anyway, this one. See, this is a child.
How old is the child?
This is Master Hitesh, probably 7 years or so.
The age is not written.
It is, I know, he's a small child, 7 years. You know, his initial picture, see this?
Right.
Huge,
yes.
expensile, heterogeneous density mass lesion with a lot of polyps coming out, cannot be anything else than AFRS. See the expansion. Guru, hydrodifried. So, this is heterogeneous density, see within the sinuses. Then we have a soft tissue window. See on soft tissue window.
Yes.
These heterogeneous densities. See that?
Right.
This is classical of fungus. Now coming from anterior to posterior, I am not going details of radiology, we have already discussed. That's the frontal sinus. See this erosion of the intersinus septum all the way, filling up both sides of the sinuses. See this, it has to be thoroughly washed, that's it. Then completely expansile, pushing the lamina papracia, pushing the nasal septum like up to the lateral wall opposite side. You can see.
Yes.
Everything, all fungus. That's it. Nothing else than fungus everywhere. Huge. But thankfully the sphenoid is spared. Only thing this side sphenoid is a small one with some opacity and doesn't look like a fungus within. That is because of the blockage of the sphenoidal recess.
Retained secretions, yeah.
It looks like. So, and we can always reconstruct in, all three planes, and you can, if you want to see. You can see all three planes.
Right.
काढून घे ड्रॉइंग रूम मध्ये पण मला आवाज दे म्हणजे मला फोन कर इथं 5 मिनिटात कर.
That is the region of the lamina papracia. You can see all the way.
Yes.
That's the region of the frontal sinus. All the way, completely gone. And this is hyperosteosis of the bone all around. This is classical in fungus. Many a times you will find. So quickly, the next case is I am getting the dankers. Then already we have seen dankers several times now.
Many times.
Many times. So no need to, we can spare some time without showing the dankers.
When 7-year-old boy, what are the possibility causes of this allergic anything? Because at so early age.
What is the reason for?
This AFRS at this early age.
This is reaction. This is type 1 hypersensitivity to the fungus.
Yes.
This patient inhaled the fungal antigen which is ubiquitous in the air,
Yes.
And because of its hypersensitivity, the eosinophilic reaction
Body reacts to the fungus.
and this is how it has led to this kind of phenomena. So now the goal is remove everything and give access to the steroid, because this is reaction for which steroid is the answer. After removal of the antigen, we'll give topical steroid, no need of oral even later on. It's a straightforward situation. Really?
Yes, sir. Yes, sir.
But it has to be in regular follow for a long time, many years. Ma'am, Faida madam and Deepak, what is the earliest stage you have done tests in this, like AFRS case?
For ARFS.
Yeah, AFRS.
6-year-old in medical college.
Okay.
I did at about 12 years of age.
Because these
this surgery was done 3-4 times.
Satish, sir?
Yes?
Yes, sir. So what about the frozen section of your vagal schwannoma case?
No, we didn't get the frozen section in vagal schwannoma. We got in parotid.
Parotid, yes, sir. What about the
parotid was the same low-grade mucoepidermoid.
Okay.
Vagal schwannoma, no need of frozen.
No, not
Exactly.
vagal. Sorry, sir.
So now we are all set for this AFRS quickly, and the meantime, in the other theatre, the dankers would be done. So I will go directly onto the tumor. That's not a
extensive one and will be good for the beginners to see. And once they start taking up the smaller tumors and doing dankers more often, they can tackle the big one as well, because it is all the dankers which matters. That's it. Nothing else. Exposure. So then after the dankers will finish off in 10-15 minutes maximum, and meantime the parotid flap will open up and then will be the last case.
Okay. So, sir, in this case, did you give preoperative antifungals, as you had advised that you usually
Not
give
really.
preoperative antifungals?
For AFRS, we have already discussed several times. This is non-invasive fungus, and there is no role of antifungals as such.
Yes.
Completely.
Yes, only.
एक जने को और बोला. No role of antifungal at all. Are you getting the picture?
Yes, yes.
See,
Yes, sir.
the polyposis, fungus.
Yes.
Now is the test for your suction.
Yes, high pressure suction.
Now,
Suction, debrider.
see the suction we have. Pachauri boss,
Yes, yes.
I have traveled worldwide to the best of the centers, and the thing which I am always disappointed at most of the places,
The suction.
suction.
Yes, yes.
See here, ours is a very, very high power suction here.
Yeah, look.
Please tell us about suction, which company and
No,
what
this
does-
is, we got, developed, this is tailor-made, and we have, generally I advise those who are using micro debrider and all to use at least 1 horsepower suction for the longevity of your
Machine.
micro debrider, longevity of your blades.
Yes, yes.
Because it improves your
See,
timing.
in such lesions, if your suction doesn't work, you get frustrated.
Yes, yes.
See the power of the suction.
Ultimate. The suction, desuction, and intact.
That's why wherever I go, first thing I ask about the suction. And same thing I have seen in Agra as well. At boss's place, they have a high power suction there.
We keep 3-4 suction connected.
See this GG material, clogs the suction very often. Still this section is not getting blocked. See the blade.
Yeah, ultimate.
See so far the only instrument working is the micro debrider. Find all. एक जने को और बुला
What
लो.
you will do for this? Because septum
Narish
is
को-
diverted toward left
नरेश
side.
को किसी को बुला लेना.
So what you will do for the septum?
Pardon?
Because of this polyposis, the septum is totally diverted to one side. So
Yeah, we will do septoplasty. Obviously. We'll definitely do septoplasty. Otherwise, see this opposite nose.
Yeah, totally blocked.
Now, then he will complain of the obstruction. He will not be happy. Find all. Zero. Rakesh. Dal. Law, debrider. Not now. See all this cheesy material.
Yes, yes.
That is all about this case. उन्हें डंकर चालू कर दिया क्या?
See, right now I am just removing the bulk of the lesion, you know, quickly, as quick as possible. Now see this, see how the lateral wall is pushed.
Yes, yes.
This is lateral wall, see this?
Good.
This is lateral wall.
Lateral wall of?
Nose.
Lateral wall nose. Means
I mean medial maxillary wall.
yeah, sinus medial wall.
Which is pushed by the lesion, and it is giving rise to this nasal blockage. डाल पॉइंट डाल यार. See, still the airway is not opened up.
Yeah, still a lot of tissue is there.
Yeah. See the continuous irrigation.
We have already discussed all these things in first webinar, but again I would ask, will you go for all allergy tests in this case, this child allergy test, or what investigation would you prefer for the further management?
See now the nasopharynx behind.
Yes, yes.
Yes, sir.
See why I was saying the lateral wall pushed. See this?
Yes.
This is septum, and see how the lateral wall is pushed by the mass lesion. Mass effect. See, rare to see kind of a thing.
So, sir, have you done the serum eosinophilic count in this patient?
Yeah, high, huge. 2600 something.
Okay.
See this turbinate collapsed. The inferior turbinate. Because of the push of the fungal mass from inside the maxillary sinus. See this turbinate collapsed.
Yeah.
See this?
Yes.
This 4 mm endoscope or 2.7 endoscope?
Pardon?
Is 2.7 mm endoscope or 4 mm?
4 mm. 3 days before we did a DCR in a 5-month-old child. That too with a 4 mm.
4 mm.
See, I have to remove the part of the turbinate as well. Irrigation. Partial gag. This maxillary sinus is widened like anything, and we have to really remove the fungus completely from the maxillary and give it a huge opening. It will be like a medial maxillectomy.
Yes.
We have seen how big the maxillary sinus was. The entire floor, the medial wall of the maxillary sinus is gone. Section. सेप्टा चालू कर दिया पता See now the nasopharynx in view behind.
Yes, we can see it.
I think without good suction, you cannot do this case so fast.
Yeah, without a powerful suction is a, can't think of. It will take hours and hours. Suction should not get blocked. And that is the principle of micro debrider. It should be backed by a high power suction. And see, this is all maxillary sinus now.
Yes, yes.
Yes, sir.
What I was removing until now was the medial wall.
Yes.
जो सेक्शन कर सेक्शन लगा see you can flash and remove this.
Yes.
No, ejaculate. पकड़. I will mobilize this fungus more. लगा. See, this is pure non-invasive fungus. It doesn't invade the mucosa. Had this been a case of invasive fungus, it would not have been so extensively occupying the sinuses.
Yes, yes.
There would be minimal intrasinus component and maximum extrasinus. And for them, surgery is not the first line treatment. Yes, obviously you need a tissue to prove it, fungus to culture, so you can give medical treatment, and for them, medical treatment is the answer, antifungals.
In this case, you have to teach the child to do nasal douching every day, regularly, and everything. More so family also.
See the huge maxillary sinus.
Yeah, yeah.
So Dr. Nityananda from Kanhagad is asking that will this patient develop atropic rhinitis post-operatively?
What?
No.
What?
Will this patient develop atropic rhinitis post-operatively?
Not really.
No.
This is all mucosa lined space. See, we are not removing the mucosa,
Yes.
and for that, I would use the term section record, excessive dryness. You know, atrophic rhinitis is an immune complex disease. Look. आ रहा. You could imagine from the CT scan how big the fungal mass was.
Yes.
Yes.
And here the man of the match is my suction.
Yes, that's true.
Very true.
The rest is hardly anything. Look. Believe me, in the biggest of the hospitals, they will not invest in the section, good section.
Pentosuction is of no use, and
See this? It's pure beauty of the section.
Yes, sir.
Only curved debrider. Maxillary is out now completely. I will check with a 70 degree. I will wash more, but majority is out. Find out. See the maxillary sinus now.
yes.
Yes, now we see some.
Wash. I will see later with a 70 degree. Not now. Looks clear now. Now the rest of the part is not much. Ethmoids and the frontal. Debrider. Straight. उधर ले जाओ. See the ethmoids?
Yes.
I have already, cleared in the beginning. And you have to be careful laterally about the orbit.
Yes.
Because the lamina is partially gone.
Yes.
In children, lamina is more prone to get breached.
Pardon?
In children, lamina is more prone to get breached as compared to children.
All septation, not only lamina. Look. See the ethmoid cavity along the lamina?
Yes.
Yes, sir.
See, we have to preserve the mucosa maximum. रुकना यार. We are not supposed to remove the mucosa at all. Now this is the post-ethmoids.
Sir, any proptosis or vision loss? Dr. Riaz is asking from Pakistan.
Yes. What?
Is there any proptosis or vision loss?
Yeah, the mild proptosis, not vision loss. Not significant. That is because of the pressure.
Okay. So, sir, while you're operating, though you have discussed quite several times about the post-operative Management, you can just tell us in brief, sir, again, once again. Many are requesting to.
I didn't get your question, Paramita. Can you
Sir,
repeat?
the post-operative management to avoid crusting, what will you do while you're operating?
Irrigation, douching.
Okay. Anything about what irrigation, sir?
Budanoside, ringer lactate and budanoside.
Yes.
Budanoside mixed in ringer lactate or saline.
One restful and 400 ml. Then
Yes.
Now ethmoids are getting cleared off.
yes.
Find out. Everywhere is fungus.
Yes, full of. There is a hydro repairer now. Now it will.
डाल पानी देख के जब रुक जाए हाँ दिख रहा है तो रुक जाएगा That is the skull base behind.
Yeah.
There's all skull base behind. That's the superior turbinate.
Yes, dominant.
Debrider.
Maybe the area of artery.
Yeah. Yeah. See now my skull base is cleared in this region.
Yes.
And now I will take the superior turbinate here to open up the small sphenoid.
Right.
Yes.
We saw this patient had a very small sphenoid, and that is here. See there behind, straight. This patient has a very small sphenoid sinus on this side. Yes, the bread. Wash. Now washing away everything, reorient, and we'll show you the sphenoid now properly. My sphenoid is here, I could see the glimpse of it. See this?
Yes.
Yes.
But we'll show you properly. The man of the match is section.
Yes, it is true.
That is the sphenoid.
Very small, very small.
उठा लेना यार क्यों इरिटेट कर रहा है कौन है
How much septum? What will be septoplasty in this case? How much septum you will take it out, or?
No, we will not take out. We will just correct. Little bit of the cartilage we may have to. Why to take out?
Just correct, just take it out and correct it. Limited septal.
Yeah, this is because of this pathology.
Yes, sir.
Yes. So now the last part of the model work, and then finally we'll go with 70 up. Counter. So far I didn't change the scope and did the entire work with a 0. See that?
Right.
Yeah.
Very clear.
Not much is required here to be done now. See, all these bony spicules should be taken care of from the healing point of view. Catch here. Yes. See, this part is done?
Yes.
That's the ethmoidal artery.
Yeah.
You may find anything dehiscent in such a case, but there is already so much of bone expansion and all.
Suppose you get a large adenoid at this level, would you take it out?
Yeah, better to address.
Yes.
Why not? He's a 7-year child, right age for that.
Luckily it was not, but sometimes we may get it.
Yeah. Now I finally, after doing this, will go toward the frontal sinus. And next 5-10 minutes will be through. Or already the Denker is done on that side, and next 15 minutes will be through to the angiofibroma as well. So now with the 70 degree, first we'll see in the maxillary. Give me.
Yeah.
See this?
Yes, sir.
Yeah, wash is needed.
Right over there. Yeah.
So Dr. Riaz from Pakistan is saying that Suction is the man of the match, but Satish sir is the man of the series.
Dr. Riaz from Pakistan is very sincere. He is
Very regular.
You know, he is the biggest of the corona warrior.
Yeah, you are.
In his duties, he developed the COVID-19 infection, and by God's grace now, he has recovered. But even during that COVID period, when he had infection, he used to watch our webinars.
Yeah.
So what is a reliable landmark in this kind of cases?
Here the disease itself is the landmark. Disease is taking you all the way.
Okay.
It has expanded everything. All sinuses. See this? See this? I am with the 70 degree now.
Yes.
Wherever the disease is going, you have to follow. It has destroyed all landmarks.
Yes.
Such cases, you don't have to apply your brain much for the landmarks, just follow the disease. Obviously, for the critical ones, the skull base and all, you have to be careful. See now. And now I am going into frontal. See?
Yes.
I am widening the opening before entering. Not in hurry of entering the frontal. See now? The last part of the surgery.
Yes.
Yes.
This is your frontal. And this is already expanded by the
Fungus.
Disease, yes, fungus. Such patients we give at least 2 to 3 weeks of oral steroid in tapering doses.
Yes, sir.
And topical from the day we remove the pack.
Yes.
3 weeks of oral steroid.
And any pre-operative steroids, sir?
Yes, yes. That is must.
So Dr. T.K. Hazra from Calcutta wants to know what doses do you give, sir? Pre-operative steroid for this child?
Pre-operative is the same, 1 milligram kg, full dose. Pre-operative steroid, will improve the surgical conditions, will decrease the disease burden by reducing the inflammation and eosinophilia. See this?
Yeah. Terrible.
Going to the opposite side from here. No intersinus septum.
Right.
Yeah.
Now the last part is left. हो गया क्या देखा?
Sir, medial maxillectomy, inferior turbinectomy will affect the facial development in a 7-year-old child till his adolescent?
Not really. There are a lot of studies done. It doesn't affect. See this?
Okay.
Fungus coming from the opposite side. See this?
Yes.
Yes.
See with a 70 degree. Some more.
Yes.
Right.
See this?
Oh my God, it's terrible.
This is I am removing from the opposite sinus. Look. Now it's through, little bit is still there.
Have to wash it more.
Yes. पतला ही दे वही वाला दे section लगा. See that one fungal material mass lesion is still there. Give me the इसके लगा के दे. And otherwise we'll use the hydrodebrider. See, it is stuck there. Body wali. See the most inaccessible area.
Yes.
Out little bit more. You do know. See, this is my 120 degree blade. One down. Could you see reeds right there? Hello?
Yeah.
This is 120 blade.
Okay.
Right into the lateral part of the frontal sinus of the opposite side. See that?
Yes.
Completely out. Now,
Yes, sir.
Use a hydrodebrider.
No need.
People want to see.
It was ready. It needed. It was ready. See now, there is no bleeding. It's good. We'll wash with the saline. We'll wash with the Dexona.
Yes.
That's the steroid. And then pack with the Dexona impregnated packs
Yes.
for 2 days. Okay?
Yes, sir. Amazing.
That's
sir.
it. Thank you.
Very nice, sir.
And the next case is ready. The Dankers is already done. There's again a 15 minutes case, that is JNA. And I will take you to the, the connect karo. So the imaging.
Yes, sir. So, sir, more than 5,000 viewers are watching you right now, and just to announce, we have completed almost more than 120 hours of webinar till now. Yes, sir.
Oh, really?
Wow.
120 hours.
Yes, of live surgical demonstration.
Marathon.
Marathon.
See this tumor. This is for the beginners. This is for the beginners. The tumor in the nasal cavity, a little bit going. See in the pterygopalatine fossa.
Yes.
Why I am saying for the beginners? Because they are not supposed to compromise with the excess.
Yes.
I can do such lesions, with now, without much struggling, with the endonasal route only, without doing a Danker even. It's not going far off. But if some beginner who is doing with this and not having a control over the vessel over here can be a disaster, and if the bleeding starts, he'll be disappointed. So best is, see this Danker with minimal extension over here, we can remove it. So in next 10 minutes time, we'll remove this, okay?
Yes.
So that's a very interesting. I would suggest the beginners to start with the less extensive cases. Once you get used to Danker, you can do any given extension. So first thing is to get used to Dankers.
Good evening, sir. This is Rajat Jain here.
Yes, Rajat. How are you, dear?
All fine, sir. So these are cases for people like us.
Pardon?
These are the cases for people like us.
Your voice is breaking, man.
Now these are the cases like for people like him. He is the skull-based surgeon doing wonderful job. It is not for you. It is for more junior people.
That's why I purposely kept in the end. We have shown the extensive case in the beginning, in the morning. And this I kept in the end to show that you can do it easily, and that will give you confidence. And once you know the Dankers, you have seen so many JNAs now, we have shown any given extension you can remove.
This extension are we supposed to do with Dankers, or can we just do a
I can do it without Danker as well. I can do it without Danker as well. You may have to struggle a little bit at the posterior end, but once you have a cobbleter, there is never a problem. The thing is, we are supposed to go in the pterygopalatine fossa at the lateral end over here.
Right.
Yes.
Catch the vessel and push it down. That's it. That's the only role we have.
Sir, yes.
And if I see in the coronal, see this lesion. So you may have to struggle without Dankers, because vascular tumor, the vessel slips. See this. This is the pterygopalatine fossa extension.
Right.
Yes.
Can you see? And this is like the previous case, pushing into the sphenoid.
Sphenoid, right.
Yeah, the floor of the sphenoid is also eroded, sir.
And this is the, the pterygoid, which is eroded. So once the pterygoid eroded, going in the pterygopalatine fossa, little bit sphenoid, in the nasopharynx, why to take a chance with the exposure?
Very true.
Yes.
See, it will come very fast. So I am going to do this, and the last will be a superficial parotidectomy for benign. We have seen we have shown the the extensive lesions earlier, the JNA, parotid. So those who cannot sustain for long, cannot watch, at least they have seen the major part. This is for the junior colleagues who really want to see the smaller cases, they can continue. So last will be the adenoma and
In the last case, I had shown the importance of the flap. In parotid, the most important is the incision and flap raising. All complications are related to that part, maximum, except the facial nerve. And the rest is the facial nerve, which I am going to show you. So in the last case, the flap will be automatically, I'll get it raised, and I will go directly to the facial to show you again the convergent approach. So again, I'll take 10 minutes for the last case. So now from on now, we have half an hour to finish off these two cases.
Okay, sir.
So recently, one of my juniors did parodied by your convergent approach.
Hello?
Recently, my junior, he did parodied from your convergent approach, and he was very happy about it. यार कुछ आवाज नहीं
देखो वॉश कर बिल्कुल क्लीन कर रहे डोंट डू यस बॉस एनीथिंग एनी क्वेश्चंस in couple of minutes I'll be back with the endoscopic picture.
So I was just telling that one of my juniors did parotid by the convergent approach, and he was very happy about it.
Oh, great. That is, I believe, is the simplest pack. Simplest of the approach, simplest of the approach for this pack.
There was one question by some the possibility of self-regression of angiofibroma at any time.
Pardon?
Is there any possibility of self-regression of angiofibroma after the age of 20, 25 years?
Not really, I don't think. I have, done one angiofibroma, was a 48-year-old male. And that was at NVK Mohan's place. NVK Mohan was there sometime back with a coach in Kolkata in a workshop. That patient had gone 25 or 30 years back, angiofibroma surgery. And he presented with a recurrence, massive recurrence, with cavernous sinus involvement, this, that, every possible area was involved and was too vascular. I don't think it regressed after a time. So, Kumar, my goal is, will straight away go to pterygopalatine fossa, resect the, do a inferior ethmoidectomy, into the, and will resect. The Denker is done, the rest of the time we are going to take is going to be less. Flap it on. Done, sir. So, we are going to start soon.
Sir, what is the size of the vessel which you take control by using coagulation?
It is breaking. Boss, what is he asking?
Till what size of the sphenopalatine do you use coagulation, and after that you use starting clips?
Still, I didn't get the question. Your voice is breaking.
In daytime, you miscoagulate the vessel, then you clipped it. Any advantage?
Yeah, to minimize the blood supply to the tumor, obviously. I know that is not a foolproof vessel. So, coagulated the vessel, pressed it, the bleeding was minimized. And when the lateral component was being removed, the vessel was obviously in front of us, you can easily clip it. These are variations, according to the situation, you can take a call.
So till date, we have done, I think, almost 8 or 9 vascular tumors in head and neck. I think no case has been, you can say, embolized, all without embolization, all the cases.
So none of the cases in the webinar
Yeah,
None of the cases, all glomus, jugular, whatever, acoustic neuroma,
all unembolized.
angiofibroma, and all non-embolized, and no transfusion required so far.
Good, that's good.
Touch wood.
You have tested it. That is a plus point. That is a good point.
Bless ko. Tattoo कहाँ गया?
Next week we can have that neuroblastoma case, olfactory neuroblastoma.
Yeah, we'll have pituitary, olfactory neuroblastoma, something skull base. That is like we had a lateral skull base day. We'll keep like endoscopic skull base day.
That patient is up to you. It's up to you. Tomorrow he will want to meet you.
लाइट कम करना. कम करना लाइट. लाइट कम कर, कम कर.
So there have been many messages from many doctors who are saying that they've started using the convergent method.
Oh, really? If they,
Yes,
I would like to have their feedback. Is it really?
All the good points should be followed. Yeah, I told Dr. Satish yesterday, I did all 3 implants yesterday with inferior cochleostomy.
Ah, that was great to know. He did inferior cochleostomy. Dr. Pachauri boss, yesterday he did 3 implants. And for the first time he did inferior cochleostomy. Now see, are you getting the picture?
Yeah, well, wonderful.
Yes, sir. Perfect.
See now what has been done. This is our, see our team. How nicely the Danker has been done.
Wonderful, wonderful.
And see, this is the nasolacrimal duct. You can see.
Yes.
Yes.
And this is the tumor there. And this is the turbinate.
Yes.
So now,
So, sir, for any given lesion, do you do modified dentures?
most of the time, this is fortunately we got this patient at this stage. Generally we don't get so early. But even for this patient there are indications for Dankers. And I will suggest the people who are starting angiofibroma surgery to do such cases with Danker. They will give them more confidence to get used to Dankers. You can avoid problems with less exposure. Once you get experience, you can do without Dankers even.
Okay, sir.
Pardon? Maybe I happen to enter the tumor somewhere. See this?
Yes, sir. Yes.
Just to expose the tumor more and more, just for your, to show you. This is the turbinate below. Now see the posterior wall.
Yeah. Thick.
So you will be drilling it, sir, to take control?
Pardon?
You will be drilling the posterior wall of the maxilla to
Yeah,
get the control of
yes, obviously. The tumor is a supply coming from the internal maxillary only. Oh, didn't I show you the CT angiogram? Sorry.
No, in this case.
I will show. Then यार छोटा वो भी ला. See, this is the posterior wall there.
this posterior wall of the maxilla.
Yes. I am removing the.
Yeah, you can fleck out most of the time this bone. If it is not
Usually you use kerosene here. This time you are using a different instrument.
Yeah, you can use anything, boss.
Actually, we are so much in routine to see kerosene work by you. So other instruments doesn't suit our eyes.
Yes. One day.
So, for the sake of everyone, can you just tell layer by layer what you get first after the posterior wall of the maxilla, then what you encounter, and then how to trace the vessel properly?
This case is not a big problem. Though what you are asking, I've been always been telling and discussed several times that once you remove the bone, you'll have the periosteum coming, and then after the periosteum, the vessel coming. Everything in order. We have discussed, but this case. कहाँ से आ रहा है? Wash. Wash.
আচ্ছা হোম সেন্টারের বিল কোন
সব এখানে
না না গোদরেজের বিল
এইবারে এইবারকার সব
এইবারে না বললাম না এটা কোথায় গোদরেজের বিল দেখেছিলে
See the pterygobaltine fossa area?
Yes sir.
ঘরে দেখেছি
তো আমাদের
হ্যাঁ
আমাদের এইবারকার
গোদরেজের বিল তুমি
কেন আমাদের টেবিলে ওটা তো এর মধ্যে আছে
ऊपर सेक्शन रख ऊपर See, this is the area of the pterygobaltine fossa.
Yes sir.
Yes, thick bone.
Yeah, you can remove more precisely with the kerosene as well. You're right.
Yes.
Kerosene works perfectly in your hands, sir.
Yeah, kerosene is one of the best tools. Section. Debrider. Wash. Straight. Now I have to jaldi de wash.
Sir, this time when you were doing AFRS, you didn't use that jet thing which you had.
This time I didn't use.
Sir, you once showed one jet kind of thing which you used to put in the frontal and then used to take out all the mud from the frontal.
Yeah, that makes your life so easy. That makes your life so easy.
Yeah.
That is hydro debrider. I mentioned several times. See, the suction was so good. It didn't feel like using the hydro debrider at any point of time.
Yes, sir.
Now, this is the pterygobaltine fossa here. Sickle. Give me a sickle. I will open it. Keep the kerosene there. Thoda. Widen a little bit. Kerosene.
Yes, sir.
हर चीज मांगनी पड़ती है.
So many are requesting your email ID, so I'll just say it is jainsatish3@gmail.com.
Yes, yes.
Numeric 3@gmail.
Yeah, numeric 3. See, this is what exactly you were telling.
Yeah, it is.
Yes, sir. Yes, sir. This is
more safe and
Yeah, it is an amazing tool.
we are used to see it like this.
See, the same thing can be done by various ways. I am more and more, widening this fossa.
More and more they expose and better we have the control.
Yes. Cobbler, sickle. See, this is the periosteum with so many prominent vessels. Now I am opening the periosteum.
Yes, sir.
And just behind the periosteum, it is fat. See this?
Yes, sir.
And in the anterior part of the fat plane,
We have the vessel.
yes, I will show you.
So for the sake of everyone, can you just tell once there is a tumor in
See
the
the vessel.
tubercular fossa and infratemporal fossa? Yes, sir, we can see that. Yes, sir.
See the vessel.
So once, if there is a tumor in the tubercular fossa, then what is the usual displacement of the vessel, sir?
It is displaced more and more anteriorly. Bigger the tumor, more anteriorly it is displaced because the tumor is coming from behind. And that is the advantage of endoscopic approach.
Yes, sir.
Because this vessel lies in the most anterior part of the compartment. And
Yes,
since the tumor comes from behind, see the vessel.
Yes, sir, we can see that. Perfect. Beautiful. In the morning, in that case, there was a lot of tumor in the maxillary side, so it was creating problem.
That makes your life difficult.
Yes, sir, yes. So if somebody doesn't have a clip facility at his house, so what all the measures are like we can take control other than coblation?
Look at this. See, I am going to use a clip, simple.
Supposing somebody doesn't have a clip, then
You don't have a clip, then you can use a bipolar, monopolar. See, the problem
which
is,
clip do you use, sir?
this is Carl Storz. One more. See, this is Carl Storz. And from the Carl Storz clip,
What's the cost of these clips?
clip cost is, the applicator and the clip.
Yes.
There is 36 clips. With this applicator cost, something like 2 lakhs. But see how amazing it is. See this?
Yes, sir.
It
Yes, sir. Yes,
success.
perfect. We have
It holds so well.
the clips.
You can use the Kalolkar clip as well.
Okay, sir. For people who are starters, that is a good option.
See, now I have divided the vessel.
Yes, sir.
Could you see?
Yes.
Yes, sir. Yes, sir. Yes.
With so much of ease after clipping it. That is the beauty. The sense of security you get after clipping is amazing.
Yes, sir. Great.
Yes, now the last part. Good. Now I will remove this turbinate, go into the ethmoids, go behind and quickly remove this. My most important job is done, that is taking the vessel in control.
Yes, sir.
Now this turbinate I am taking out.
So usually in all the cases, you trim down half of the terminals.
Trim down? Yes.
Usually you take down half
yes,
of the terminals.
I keep the upper stump intact.
Yes, sir.
That is not something which is bothering us here. And here it is important to, go about the tumor. How will you go about the tumor otherwise?
Yes, sir. It gives us more area to work around.
See now, I will quickly do this lower ethmoidectomy now.
Yes, sir. Yes, sir.
To ensure that no tumor is there in the ethmoid. See this?
Yes, sir. Yes, sir.
So vascular clip, which company sir this is?
Carl Stores. This clip is little costly, but it is so, reliable. We don't compromise with the instruments at any point of time. If something is good, you have to respect it. And in JNA, imagine post-operatively if your vessel happens to open, what is going to be the scene? How can you take a chance?
Yes, sir.
Yes, sir.
Cobblator and wash. See now the tumor.
Yes.
Wash करता रहना थोड़ा क्या करता तू? See this tumor attached to the septum there?
Yes, sir.
Now the ethmoids are pretty clear. What I will do now, this is the region of the, imagine the situation without the dankers. You could have been, struggling a lot.
Yes, sir. Yes.
Yes.
Once you are dealing with a vascular tumor like this, why to take a chance?
You have stopped embolization at all?
Pardon?
Have you stopped doing embolization?
Almost in selected cases, when I have multiple vessels supplying the tumor, vessels coming from behind, wash. What's your
protocol in recurrent cases, sir? Do you embolize or not?
Recurrent are more difficult,
Yes, sir.
In recurrent, the vascularity is always aberrant. Because the previous surgeon must have, ligated or claved the internal maxillary, and now the aberrant vessel coming up to supply are more difficult to handle.
Yes, sir.
Revision surgery for anything is always difficult, for that matter.
Yes.
Okay.
Now see, this tumor, this was the attachment to the septum.
Right.
And see here, that is the sphenoid.
Yes,
Yes,
sir.
sir.
Sir, Dr. Satyaprakash Dubey sir is asking role of stilbestrol in the management of hair.
Role of?
Stilbestrol.
The estrogen.
Yes. Hormonal therapy.
Testosterone inhibitor or estrogen, all these have been used, and you can use them to buy the time to reduce the tumor or whatsoever in post-pubertal patients, They are supposed to contain all these receptors into the tumor, not pre-pubertal.
Yes.
See, I have separated from the septum here.
Right.
Yes.
This is the sphenoid. This is the mucosa inside which I am removing.
Yes, sir.
And see the sphenoid sinus here.
Yes, sir. Nicely. So that's the superior control.
Yeah, I will remove this wall of the sphenoid as well here, because some of the tumor was riding.
Yeah, we could see that in the CT scan.
Yeah, that's what I'm showing. Now see towards the floor of the sphenoid.
Yes, sir.
Yes, sir. Yes. Yes.
See this?
Right.
This is towards the floor. Now see the interior of the sphenoid better.
Yes, sir. Yes. So in this case, will you be doing the posterior subtorsion, sir?
Let me try without that.
Okay.
That I can combine any point of time. Retract कर इसको हटाओ. पकड़. पकड़. उठा. हाँ.
So, sir.
See this part of the tumor.
Have you?
Hello.
Yes, sir.
We can hear you, Satish.
Yeah, this part of the tumor.
Right.
I am separating in the subperiosteal plane. You can see now.
Right.
Yes, sir.
And this is a little bit of the tumor which is riding into the sphenoid. Let me show you. See, I have left a little bit of the tumor here in the, as usual I told you, you tackle the, this pterygoid tumor in the end.
Okay.
Yes, sir.
Now see the sphenoid. And this was the component. Forceps.
This
now
one
this
square thing always is a trouble.
Yeah, now this is going to be out soon. What differently I am doing? Vessel, not.
I think that's a branch of phenobarbital that is bleeding.
Yeah. Hata. Now see, I have not removed the part of the septum. Now you can imagine the struggle. Removing the septum makes your life so easy. Posterior part, I had shown you earlier several times. Now here not removing.
Yes, sir.
So you may have some struggle here. Pani dal, Pani dal, endoscope pe. See tumor taken down in the subperiosteal plane.
Right.
And this is how it can be pushed
below.
These are periosteal attachment, All
so
these
usually these are difficult to take down. Sometimes they are highly adhered.
The cobblator helps you. What I am cutting is cutting through the periosteum.
So at this time you are using ablation.
Yes. When you are supposed to cut, you are supposed to use the ablation. And now lastly, this periosteal attachment, in the sphenoid, in the nasopharynx. Pani dal. Down.
Yes, sir. Wow. Great.
A little bit of this periosteal attachment, Simple. Sit is free.
Yes, sir.
I can remove it easily and then we'll concentrate only on one part here in the pterygoid.
Yes.
That is a very important area and we'll be through. See, the Denkers gives you opportunity for the proper instrumentation. See now why I am putting this? So that it doesn't jump up back when we remove from inside.
Yes, sir.
Cool. And now simply I am removing from the tracker. That was the tumor. See this?
Yes, good, wonderful.
Yes.
And now, go back, wash.
Which instrument did you use to pull up the soft palate?
That was a pillar retractor we used to retract the soft palate. Tonsillar pillar retractor.
Okay.
See this? Give me the brother. This adenoid surface.
The remnant of this inferior turbinate, if you get a CT done, CT contrast, post-operatively it enhances, and they write it as residual tumor.
Oh my God, Peck. Now on the adenoid surface, we will use, there is no tumor attachment, never. What you can use if you have abraded somewhere, you can use the cautery later or the cobbleter later on. Now the most important area is this. Pterygoid. Because you have to drill it. That is the site of recurrence. See the sphenoid is pretty clear.
Yes, sir. So there is a lot of fear among people, like how deep can we drill into pterygoids?
Yeah, you can remove the pterygoid completely. You can remove the existence of the pterygoid.
It's not a bad, it's a safe place, not very easy.
You can remove the existence of the pterygoid thoroughly. Wash. See, this is our vessel.
Yes, sir.
Yes, sir.
And this is the I have to thoroughly clean this area. Give me the cobbleter and the drill.
Sir, do you also send samples for median artery or nerve?
For?
So do you Alok Thakkar sir sends samples for median canal? Do you also send samples for median canal?
We always assess the median canal by default, and I have shown in the afternoon in the previous case how the median canal. See now, this above, this here is the nerve above which I am going to. See the above now?
Yes. Yes, sir. Yes, sir.
Yes.
That is V2.
Yes, sir. This is interpret.
And that is the median artery,
Yeah.
That is the median canal here. Let me show you. See here. That is the median canal, which I am going to completely drill off. Rest of the tumor is out, and this part of the pterygoid is so good. See that?
Yes, sir.
There is nothing. Give me the drill.
So you recommend drilling in all the cases, whether it
Always. This is the commonest site, Yes.
Yes.
And sir, usually we have seen, we have got few references that surgery was done. Now that
Boss, I can't.
It has gone towards the greater end of the skin.
Your half of the voice is not understandable. It is breaking. Maybe because of the internet speed.
Internet issue here.
Yes.
Please put off your video, then
Sir, there are few
See, this is the pterygoid muscle below.
Yes, sir.
I am coagulating everything.
Yes.
Sir, can you hear me?
Yes. See, I have removed everything. I drilled away the pterygoid. Let me drill away a little bit of the base sphenoid. This, you can't take a chance over here. That is the region of the pterygoid canal. See this?
Yes.
Which I have coagulated.
Yes, sir. Yes, sir.
This part of the anterior wall of the floor section under. That is the cancellous bone of the sphenoid.
Yes, sir.
See this? And that's the final picture.
Sir, can you just throw light on something?
Pardon?
Sir, we just got a case which was previously operated, and now there was recurrence in the pterygoid region, and the tumor was going towards the greater wing of the sphenoid.
That is the commonest site, man. That is not recurrence. First of all, that is not recurrent. That is a residual tumor which is regrown.
Yes, that is yes.
See, this is the sphenoid, and in the floor, see this median canal. See this?
Yes, sir. Yes, sir.
Which I have coagulated completely. In the floor of the sphenoid. That is the sphenoid. This is the pterygoid process I have completely drilled off. You can see. My V2 is above, and this is the clipped vessel. See this vessel? See this vessel with two clips.
Yes.
See now the pterygoid process. Absolutely cleaned up.
Yes, absolutely.
No question of leaving any disease behind there. Drill.
Perfect.
This is how you have to spend 5 minutes extra to this pterygoid. And see this bone of the cancellous bone of the sphenoid. Here also sometimes the tumor enters. See this? Now completely cleared off. Wash. Dang se kar. Wash se kar. Dikha do. Hello. To show you the final picture. Arey Guru Dhire. This is to show you the final picture. Can you?
Yes, sir. Very clearly.
See, the most important thing is.
Someone's voice is coming. I think someone has to.
See, the most important thing is drilling this bone of the pterygoid and the cancellous bone of the sphenoid. See the interior of the sphenoid very clear. Close up.
Very clear.
These are the two clips on the vessel. The tumor was not going laterally over there. And this is my V2. See inside? That is V2 here.
Yes.
This one, not disturbed at all.
Yes.
And the tumor is completely removed. And we had some, I coagulated some areas of the periosteum in the nasopharyngeal roof. That is clear. And see the adenoid surface. It is always innocent. It doesn't give rise to any attachment. See this?
Yes, wonderful.
In the periosteum, that's why I specifically drilled this sphenoid cancellous bone over here. That is the site of, sometime the disease in the bone marrow and this median canal and this pterygoid process. All are absolutely clear. Okay?
Perfect.
And now the last case which we have already raised the flap.
Yes.
चौधरी को बोला था ना लाए बेटा तुम क्या कर रहे हैं तू छोड़ पेटवा hello
yes sir
so next 5 minutes we are going to start this. There's a 2.5 centimeter to 3 centimeter size pleomorphic adenoma. And the thing to be shown again, we have shown it earlier also a couple of times, is the convergent approach. That's the only theme. Case is not a big case. Pleomorphic adenoma, you have seen the mucoepidermal carcinoma, so pleomorphic adenoma is not a big case now.
Yes.
But the important thing is convergent approach. Any questions so far for the day? Anything?
These are one of the best case for the genius. I think this would do.
Yes.
See the recording every time.
Very clear and very nicely. And now I think by now all of us are.
Sir has made JNA like a ball game.
JNA is understandable tumor, it has a pattern of spread which you can understand, pattern of vascularity you can understand, and certain principle not to enter into the tumor, stay around, catch the vessel and remove it. The simple philosophy you follow, whatever the extent of the tumor, the treatment remains same.
Yes.
Doesn't change at all. Now, are you getting something on the screen, the MRI?
Yes, we can.
This is the last case, and see this tumor on T2 weighted. You see on the axial and see this is my retromandibular vein and tumor is far laterally. Can you see? Far superficial in the deep lobe. It is not malignant. Why I am not saying malignant? There are certain features on MRI itself. It tells you it is not malignant. Number one, see how circumscribed it is. Had this been malignant, it would have been diffusely, going out of the capsule to invade the parotid tissue. This is so homogeneous, and pleomorphic adenomas are very types according to the cell they contain. Pleomorphic means variety of cells they have. Now, this is contrast, and this is contrast here as well. I will bring. Yes. So now, if you see on the contrast, see this enhancement.
Yes.
Now, I always make it a point to go to the diffusion that clears whether it is benign or malignant to a major extent. See now, this lesion, see on the diffusion here, it is enhancing, it is not restricting. Had there been a lot of cellularity like malignant tumor with a major and a big nuclear cytoplasmic ratio, more cells, less water content, it would give diffusion restriction. And it is bright on diffusion means more water content, less chances of being malignant. As simple as that. This is pure bioimaging. This is so reliable. By means of looking at the diffusion, I can say whether it is benign or malignant 95% of the time. And this adds on to your decision making. Sometimes you are not very sure on FNSE or core biopsy or whatever. And this diffusion MRI with all these features of MRI are certainly very, very important in those situations.
Yes, sir.
So, we are going to start in a couple of minutes. The flap is raised, and this will be the last case of the day. Anybody, any question in mind?
Miss, you advise MRI. Any role of CT scan, Miss?
Not really. CT has role only for the bone. For soft tissues, MRI. Only and only thing is MRI. CT. So in overall our practice, now role of the CT scan is reduced down to less than 20%. For CT, the PNS for the sinusitis, and for CSOM and other otosclerosis and cochlear implant and those for the temporal bone. For rest of the pathologies, it is all MRI. Even for the bone, for certain regions, MRI is more informative, particularly giving the information of bone marrow invasion. Marrow canal invasion, like in oral cavity for the mandibular invasion. For cortical invasion, CT scan gives you picture of early invasion, but beyond the cortex, it is MRI. For the medullary canal, it is MRI. For perineural spread, it is MRI. So role of the CT scan is reduced more and more because of the versatility of the MRI. It can give rise to, more than 1500 different sequences. Every sequence has a value for certain indications. The MRI is so vast, so difficult to understand. But there are certain common sequences. By taking use of them, you can reach to your differential diagnosis most of the time in your clinical practice. So I'm washing up now, and
yes, sir.
So what's the FNAC finding of the case?
Pleomorphic adenoma. Straightforward.
Okay.
Sir.
ये चला ना? मेरे को बुला रहे हैं इसको.
Dr. Dixit asked this question even in the previous parotidectomy case about the types of parotidectomy. So we have discussed about
that is,
superficial.
There are so many classifications existing.
Yes.
Everyone has its own classification. The European system, European Salivary Gland Society is a different classification. Spanish Society is a different. Boston Society is a different. And every individual is a different. From extracapsular dissection to superficial to very superficial parotidectomy to extended superficial to total, near total, subtotal, extended radical. There are so many things to confuse you. By and large, the standard classification system involves extracapsular dissection is what? When you remove the tumor from one subsite of the parotid. There are many subsites of the parotid defined. Like in the superficial lobe, there are two subsites. The one in the superficial lobe superior to the main trunk of the facial nerve, one inferior to the main trunk of facial nerve. Those are again subdivided by the branches to 1A, 1B, 2A, 2B. Then the same thing in the deeper lobe, level 3 and 4, above and below the facial nerve. Then the level 5 is accessory parotid along the duct. So if you are removing one level superficial with cup of tissue around with no localization of the facial nerve, just go around it like excisional biopsy, is extracapsular dissection. Lot of people consider it as standard dissection in limited tumors. Then comes the superficial parotidectomy, the gold standard procedure. No term like for us, very superficial parotidectomy, it doesn't exist. Then a total parotidectomy when you remove the entire parotid tissue, deep and superficial lobe. Extended, or I would say the radical parotidectomy when you involve the facial nerve in resection, when the facial nerve is involved. Extended when the tumor extends out of the confines of the parotid to involve other subsites like mandible, extraocular canal, masseter, skull base, and you go on to remove that extended subsite along with the parotid, is extended parotidectomy. There are many ways. Can you see the tumor?
Yes, yes.
The flap has already been elevated.
Yes.
Let me give you a good focus. Can you see better?
Yes. Yes, sir. Yes, now is much better.
Okay, so the theme is, we have discussed the parotid in detail today. The only thing we are going to discuss here now is the facial nerve. Okay?
Yes.
Yes, sir.
Now, first of all, before the facial nerve is another nerve. Can you see this? Greater auricular.
Yes.
And we are supposed to preserve the posterior division. Don't ignore it. It's very important for the females or anybody who wear earrings. See this?
Yes. Beautiful.
Yes, sir.
That's the anterior branch which is going to be divided. Damage. Give me the one. पकड़ना यार. I always mention there are two landmarks to be taken into consideration, and that is what using them converging onto the facial nerve known as convergent approach. See what I am defining is the anterior border of the sternomastoid.
Yeah.
See this vein? See this vein I was telling you. The landmark for the last case we couldn't find that. Landmark for the greater auricular. See this? 1 centimeter below and parallel. If you remember I mentioned.
Yes, sir. Yes.
See this? In the last case it was missing. Venous abnormalities are more common. Take. And now we have two landmarks which we have to follow and complete this parotidectomy. Number one, superiorly, is the tragal pointer. See, this is the tragus.
Yes, sir.
Utha. Counter traction. This is the tragal pointer. Can you see cartilage?
Yeah.
Yes.
Yes, sir.
Okay. We have to look at the lower end of the cartilage, which ends as a pointer.
Yes, sir.
Now I mentioned to Dr. Shiva, if you remember, as long as you are superficial to the lower end of the cartilage,
Yes.
you are miles away from the facial nerve.
Yes, yes.
This is the cartilage, and this is how it is ending here. See this
Yes, sir.
as a pointer. This is the pointer. See the pointer. Can
Yes,
you?
sir. Yes.
Can you see here? Very clear?
Very clear.
Now, the second landmark I'll see from below and remove the bridging tissue completely. Can you see this muscle below?
Yes.
This is our very important muscle. This muscle is a, very important muscle for the surgeon. Always use as a landmark everywhere.
Yes, sir.
Saving surgeons from giving complication. This is digastric.
Yes, sir.
कौन है बदल पकड़ मत कर now see this is the digastric muscle coming to the under surface of the mastoid here. See this?
Yes.
Yes, sir. Yes,
As
sir.
I mentioned, staying lateral to the digastric. Staying lateral to the digastric, I can remove. See this? I am lateral to the digastric.
Yes, sir.
Yes.
Lateral to the tragal pointer as well. This is tragal pointer. See this?
Yes, sir.
Yes.
I can remove this tissue completely. See this? And see now in the depth. What is there?
Yeah, but not, but it's little bit more laterally.
Lateral, yes.
Little bit you can see, but at the same point where it is
Quite
converging.
lateral.
This is the digastric ending here, just above that, and this is the tragal pointer here, just 1 centimeter below and deeper. So easy it is to find this now.
But that looks very lateral, sir.
They are little lateral. Now see, staying above the you know, the lower division now. See this?
Yes.
If I open up, yeah. See this lower division, beta? Can you see the lower division fibers?
Yeah.
That is the retromandibular vein.
Yes.
Then this is your upper division. See this?
Going up, yes.
Yes, sir, yes.
See my artery. The direction of the artery forceps is lateral always.
Yes.
Away from the nerve, you can see.
So the kind of teaching we do is like you have already taught us, like insert, elevate, and spread.
Yes, exactly. See how it is going. Stay above the nerve, elevate the tissue above, not the nerve. Don't give traction to the nerve.
Yes, sir, no traction.
No traction to the nerve, traction on the tissue, not on the nerve. See, this is lower division, branches going.
Yes.
This is the vein. I can bipolarize it here. One more place, can you give me? And now the other branches, see this? See this?
Yes, sir.
This is your marginal mandibular.
Yes, yes, clearly seen.
And see, I am below the tumor. My tumor is here. Staying lateral to this, I can take this cup of tissue.
Yes, sir.
See this? So both sides I will elevate and remove this in next 5 minutes.
Sir, how come you don't get bleeding? When we do parotid, it's lot of parotid always bleeding.
Microscope. Microscope gives you opportunity to even have a look at the small capillaries. See so many branches from the lower division.
Yes, sir.
See, I am getting away from these branches. See, staying above the branches.
Yes, sir.
Yes, see the branches going?
Yes, sir.
See, so many branches from the lower division, so many interconnecting branches and all. These are all, small blood vessels. See this. My lower pole is getting freed very soon. My all important branches have gone through.
Yes, sir.
I push them aside and I can really remove this
Yes, sir.
away. Similarly from the upper pole here. Now some buccal branches, these are important. See this? See this upper buccal?
Yes.
Yeah.
Yes, sir.
Mop. These are the upper buccal, see this?
Yes.
Now again see my branches below?
Yes, sir.
Bipolar.
So supposedly like this tumor is small, supposedly we have a big tumor and we are not able to trace the main trunk of facial nerve and we plan to do a retrograde dissection.
Yeah,
So
yeah, we
what are
did.
the landmarks for various frontal, buccal, mesenteric?
Yeah, for every branch there are landmarks. We have discussed several times for the marginal mandibular, we have discussed. Then go to, see for that best is to go to the anterior border. Masseter, all these branches go on the masseter.
Yes, sir.
Here, see all these branches go on the masseter. See these branches, see these?
Yes, sir.
Follow any of these branches, follow any of these, retrograde. They are going to take you to the main trunk. See this lower buccal now?
Yes, sir.
See so many branches from the lower division. How do people call there are 5 branches of facial nerve? I see till anterior part, till zygomatical major if I go, I see almost more than 100 branches. And all are important because this nerve is serving such a most complex function of the body. A spontaneous smile.
Sir, I have one more question. Supposedly, the facial nerve is damaged during prostatectomy, and we want to like reanimate. So, should we do a facial masseteric, or should we take a sural nerve and then from the main trunk we should join various branches?
Depends upon the gap amongst the branches you are going to intend to reanasmose. If there is no gap, primary anastomosis is the best. There is no comparison to it.
Okay, sir.
If there is a big gap, you can use a nerve graft like sural.
Yes, sir.
But if you don't have a proximal end, then only you bring the masseteric. Why masseteric otherwise? Spontaneous smile will come only when the discharge is going to come from the facial nucleus.
Yes, sir. Yes. Because recently we had a case of mucoepidermoid carcinoma and we could not trace the main trunk, so we did total prostatectomy. And then the plastic surgeon of our team did the sural nerve grafting.
Yes. See now, all branches going respectively.
Yes, yes.
And we remove the tumor. See the network of branches. Network.
Focus, please. Little bit. Yeah, no, it's very, very
Yeah. Network of vessels. And everywhere where are the nerves are the vessels. You have to be very careful. Controlling the bleeding can create problems and injure the nerves. So you have to be very careful. Use bipolar and see now all the branches. This is inferior trunk. See the branches, this. Superior, this one, this is zygomatic, this is buccal and so many interconnecting. See this?
Yes, sir.
Yes, sir. Yes, sir. We all will.
This is all about the parotid. We'll just wait, wash it. See the full plexus.
Amazing, sir.
Pes anserinus. So parotid surgery revolves all around the. See, this is greater auricular behind the facial there.
Sir, we could see. Yes.
Thank you. We'll close it. And now, lastly, if anybody has any question, any suggestions, Madam, you do any parotidectomy any differently? Madam has a vast experience in head and neck.
Oh no, Satish, you've done it beautifully. It was a visual feast to watch all your surgeries. I didn't even feel like getting up even once. And thank you for inviting me to be with you. Thank you, Paramita. Thank you, Rajiv. and it was wonderful.
Seeing you always is a something learning experience, madam.
Thank you so much.
Thank you, ma'am. We have learned a lot from you. Today we had really good discussion and amazing cases. So we've really learned a
I
lot
really enjoyed
today.
every moment. Thank you so much, Satish.
Thank you. Thank you all. Thank you.
Bye.
Thank you, Satish.
Son, Empress.
Thank you, Rajat.
Barmanji.
And big thanks to Pachauri boss and Paramita.
Mr. Varmanji is there? No, he is there gone.
Thank you very much, sir. It's a pleasure being with you.
So I think that from on the behalf of Son, we can thanks all.
Yes, sir. Your idea of inviting your pathologist, Dr. Parik madam, was an amazing idea. So we have learned so much of it.
Wonderful.
So much. We have really learned. A lot.
See, these pathologists are very important, you know.
Very important, sir. Very
You
important.
have to give them full respect to learn from them, and they are really important. One wrong pathology can ruin your career.
Yes, yes, yes.
That is true.
Similarly, radiologist.
Hmm.
I always emphasize on the diagnosis. The pathologist and radiologist are the backbone of your diagnosis.
Yes.
And third is, I always, whenever, you know, I am hardcore oncosurgeon. The rest, ENT is secondary for me. I am basically oncosurgeon and doing a lot of oncology procedures every day. Most of the day, oncology only. And these Tata people are the people who are doing purely evidence-based medicine.
Evidence-based,
The
yes.
kind of experience they have, the kind of work they are doing day and night, like these head and neck guys are doing only head and neck oncology. They are so good at, you know, academical part. They publish so much, they have a, you know, huge workload. And the training system in Tata is amazing. If
Yes.
somebody has to do something in head and neck, he has to visit Tata in life, at least for a few months.
That is Thank you, Dr. Maruti. Kalyan.
Thank you, Raju. Thank you.
Thank you. Thank you, Sun Pharma, for everything.
Thank you, and thank you, Rajat. Keep coming. Your
Yeah,
comments are valuable. No, see, the goal, see, overall our goal is to extend the, you know, evidence-based medicine. Your comments, suggestions are valuable. You are most welcome.
Yes, sir.
Thank you. I thank today Dr. Shiva, Dr. Archana Parikh, Dr. Gaurav Chaturvedi, Dr. Maruti,
Dwaipan also joined in between.
Ashish, Dwaipan, all these guys are amazing. And big thanks to Ramandeep, who is, you know,
Yes.
is a very
He's
hardcore
very-
academician. Thank you. Thank you all. Thank you, Paramita. Thank you, Rajiv boss. Thank you. See you. And see you next week, next Sunday, with some more interesting cases, more advanced cases next Sunday. Thank you.
Thank you, Dinesh.
Good night, sir. Good night.
Thank you.